have variable size, and we know that when you are dealing with the left mains, there is absolutely no proximal reference you have, and that is where the imaging becomes very important so that you size the vessels well. The left main might be small sized or big as this, as seen on the screen. This was from a patient who had coarctation of aorta, and the left main sizes, the daughter branches were 4.5. The left main, you can imagine what size it was. It can trifurcate as is seen. So I told you 17% can have trifurcations. It can have ACS situation. It can come with thrombus. The LAD is totally occluded. Distal left main has a lot of thrombus, and the daughter branches are also involved. Or it could be the sole surviving vessel, as seen in this case with diffuse disease of the left main segment involving the circumflex, which is collateralizing the other segment. So there's considerable complexity which comes with the left main, or it can be prone to calcification, tax score involving all the daughter branches. So what I'm trying to show, certain other factors which come into play in this subgroup, patient subsets, like you have invariably elderlies with multiple comorbidities like diabetes, COPD, CKD. They can have ACS presentation. Invariably, they have poor LV function requiring hemodynamic support and complex morphology of the plaque, which I've already mentioned. Now, complications in this segment are absolutely not well tolerated, so you have to be very careful. Planning is very, very important, so you have to plan your cases and then only go ahead and do, so that you do it carefully, because complications can lead to mortality on table. So one has to have a very cautious approach. Number one question is it an appropriate procedure? And in true sense, you should have an heart team approach. There is considerable functional, anatomical functional mismatch in this subgroup. So physiology is very, very important if you feel that the lesion could be plus minus. Anticipate potential problems. You should have a clear strategy and have a backup plan. And most importantly, don't launch into this segment without having all the equipment on shelf. You should not be found wanting, because you cannot just get back once you've started the procedure. So it's always better to seek help rather than ending up having a life-threatening complication on the table. Well, imaging is very important, and that has been stressed by the previous speakers in the previous session, which was the left main. We know that there is considerable individual variability in assessing the left main sizes, and you cannot leave underexpanded or malopose stents in these segments, so you avoid the reference sizing errors in this subgroup. Stent optimization is of utmost importance, because if you lead maloposition and if you have to go in again, you will be going substrate, and we've seen now enough literature coming showing that the access, once you deployed a malopose stent, is substrate in majority of these cases. Calcium is very important because it's not picked up on angiogram, so imaging will show you, and post-PCI complications can be devastating. So we have IVUS NERS now available for CKD patients, and NERS in addition helps you to characterize the plaque, especially in the ACS situations. OCT is considered to be better because it's got three-dimensional component available, so you'll be able to see your wires, whether they're going through a proximal distal strut, and the 3D images generally give you a very nice sense of job done. Well, if you look at this study in the left main segment, under-expansion of stents was pretty common, seen in about 34%. And this translates into a lot of stent failure and is a kind of predictor of a 2 years MACE. So one needs to be careful, and if you do your job under imaging, you are assured of very good results. Now, certain tips for left main angioplasty. The key to successful left main angioplasty is proper risk stratification of the patient. Have a holistic approach to the patient. Maintain the hemodynamics up front and have all the hemodynamic support devices available, or as per the affordability of the patient. Imaging is the foundation. You need to image. You need to do both pre and post. Don't rely only on post imaging, which is a very faulty technique. Have all the tools on the table which are required. Be watchful of complications while in pursuit for perfection. Now, this is very important if you're dealing with a calcific left main segment. You can go overboard looking at imaging that, okay, stent is malopose, underexpanded, and you can kind of damage this segment. So the key to success lies in proper planning of the case. Now, to summarize, I will give you some differences between left main and non-left main bifurcation. Now, invariably, if you'll see that the side branch, which is circumflex, is not exactly a side branch. It can be called the second branch of the left main, and it supplies bigger chunk of myocardium. The bifurcation angle invariably is wider here. The lesion is often complex. It is The circumflex is invariably tortuous, angulated. So you need to plan upfront, because if you do a provisional and if you have to do a bailout, there can be problems. So you need to plan it well so that if the side branch needs attention, you should address it first. So the crossover stenting is about 50% more in the left main segment compared to the non-left main segment. There is interaction of the carrying catheter with the main vessel, which is more in the left main, because if you are pulling and pushing the hardware, you can damage the proximal part of the stent. You have to be aware of that. Longitudinal deformation of the stents, hence, is more in the left main segment. Wires can go substrate, as I was saying, because it's a large branch, and if you've not opposed it well, then there could be problem. And since it is the segment of the coronary tree which is supplying a big chunk of myocardium, you need to have good hemodynamic supports. If you are not doing that, there could be complications, and these complications can result into mortality. To conclude, I would say that left main bifurcation represents one of the most important CHIP cases, because this is one segment which needs a clear-cut planning and a very well execution of that plan. The comorbidities of the patients add to the complexity of the PCI, so it's not only the anatomy which you are dealing with, but also the complexity which comes along with it. So proper patient selection, meticulous application of the technique are the central pivot on which the outcomes of a PCI are going to rest. And I like this statement, Savdhani hati, durghatna ghati. So invariably, when you're going in the mountains, this is displayed everywhere, which tells you to be careful while driving. Please be very careful when you're into the left main segment. Thank you very much.
Thank you, Dr. Chadha, for finishing before time. Please have a seat. Ajay, next.
May we now request Dr. Ajay J. Swami to come on stage and deliver their presentation.
Before I begin, my salutations to my teachers, some of whom I see in the audience and some of whom are not. I have the daunting task to decide how to select a technique for a left main bifurcation and to look at evidence and practice in this subset. These are my disclosures. This is one case, a 61-year-old hypertensive dyslipidemic male, chronic stable angina for 2 years, crescendo angina, and he had regional wall motion abnormality in all 3 vessels. And we just let the angiogram run through, and we'll come back to it later. This is a second case, a 49-year-old young male who was advised bypass surgery somewhere else, and he also was actually a marathon runner, and he came with inability to run his daily runs and actually progressed to crescendo angina. Coronary bifurcations, as we know, are 20 to 60%. The EBC defines it very succinctly as a coronary artery narrowing occurring adjacent to and stroke all involving the origin of a significant side branch, and a significant side branch is one that we do not want to lose during a revascularization procedure. Now, the concept of the bifurcation PCI is important to appreciate. It is either it's the ability to keep the ostium of the side branch patent at the end of the procedure, and indeed in the long term, with short-term safety, which refers to stent thrombosis in both the branches, and long-term safety that refers to restenosis, usually in the side branch, but more importantly in the main branch. Now, there are basically 2 approaches to bifurcation angioplasty. Do we just need the side branch to remain open at the end of the procedure, as we do in a LED D2 or a circumflex OM bifurcation with a small distal circumflex? Or do we need an optimal result in the side branch? That means no problems in the short term, intermediate term, and if possible in the long term, as in an LM bifurcation or in an LAD large D1, or in a patient with LV dysfunction with the sole surviving vessel supplying the large territory of viable myocardium, where we don't want to lose any of the side branches. What about the clinical considerations? What situation are we dealing with? ACS, acute MI, chronic stable angina, silent ischemia, and all the syndromes in between, and other comorbidities, that means renal function, bleeding risk, arteritis, etc. Thus, the procedure is planned, the die limits are established, the procedural endpoint is defined right in the beginning. This is what we expect from this procedure, and then we go ahead. Anatomical considerations as far as the side branches: is this a significant side branch? We've already discussed what it means. Is this branch easy to wire? Is it likely to close if the main vessel is stented? What's the length of the disease in the side branch? Is there significant calcium? Is there significant thrombus? What is the angle at which it comes off? And the distribution of plaque in the bifurcation. and we use all the information that we can get from various angiographic projections and imaging to answer all these questions, which is a whole topic in itself. LM and non-LM bifurcations have been dealt with elegantly by my previous speaker. I will just say that the majority of side branches in non-LM bifurcations are actually non-significant, and only 20% of non-LM bifurcations have a side branch that supplies over 8% of the myocardium, which is going to end up with a periprocedural MI. The largest of this subgroup is the LAD D1, followed by the circumflex OM, and an even smaller subset, the PDA PLB. Now, LM, as has been already said, is it a true bifurcation? It's actually got two main branches. And in patients with a substantially sized circumflex, it's important to keep it flowing well at the end of the procedure in the short term and the long term. Points for consideration during angioplasty: this is a resource demanding procedure. It requires multiple guide wires, multiple balloons, multiple stents with imaging. Results are often less robust than non-bifurcation stenting, and efficacy is related to the main branch patency. But all the strategies of bifurcation are actually for the side branch, and all the complications that come from our trying to keep this side branch open, and this is an important concept to have. It's important to have the main branch flowing as well as possible at the end of the procedure. There are different technical options, and these have to be married to what is available in the local settings and the expertise available. Now, what is the meaning of complexity? The complexity has three aspects, as we have tried to discuss: the clinical setting and the anatomical relevance of the two branches, the disease extent in the two branches, and the plaque morphology, that means the extent of thrombus and calcium, and the ease of access to the two branches. These three concepts actually decide what is the complex nature of this bifurcation. There have been attempts to bring this down to a protocol, and although it doesn't cover all situations, this is a very, very good chart to consult. For a left main distal bifurcation, if the side branch lesion length is more than 10 and the side branch diameter is greater than 70%, that's the major criteria. With calcification, multiple lesions, bifurcation, unfavorable angles, main vessel reference diameter being small, thrombus containing lesions, and main vessel length more than 25 millimeters lesion length. And for non-left main, if the side branch is lesion length is greater than 10 millimeters and the stenosis is more than 90%, these are the two major criteria. So the complex bifurcation by definition is one major and any two minor, and this is both left main and non-left main situations. This is the LM situation, one protocol that is suggested. That means we use the LM LAD, and this is, if it's a simple lesion, this is what was used in the DK crush. And whenever we used any of these two, it became complex. And the differences in the strategies were shown. In simple lesions, the difference was not so much, although it was there. But in complex lesions, the DK crush shows a distinct and clear advantage in the short term and the long term. Thus, first question, is it significant? And all these questions that we have spoken of. For the non-left main bifurcation, the preferred approach, according to the EBC, is to use the layered provisional stent with the pot, and in case one ends up with a dissection or a residual stenosis, decreased flow, or ischemia, go ahead with a second stent in the provisional stenting, in the simple bifurcation lesions. In the complex, they have spoken of both Q-lot, systematic T, and DK crush, depending on the angle and the comfort of the operator, and final kissing balloon in both if possible. Traditionally, we have known that if you look at the evidence, one stent is best, is the traditional teaching. Less metal is a simple strategy, but these are mostly first generation studies, and it's been shown that more recently, there is an increased use of provisional strategy. We have data from registry, comparison, evidence from other data, and consensus, and we'll quickly look at these. I'm not going into the strategies because they're going to be discussed. What about the data available? As far as the left main is concerned, we know that Q-lot and crush, the classical crush, are associated with increased stent thrombosis compared to provisional, and that probably led to what the benefit of the single stent strategy was. Large meta-analysis with 3-year clinical outcome of 1 and 2 stent have actually shown that provisional was less. But if one looks at these data more carefully, all the studies where provisional was less, this meta-analysis difference is driven by observational studies and not by randomized trials. If you look at the randomized trials, basically RCTs, there are only 3 for bifurcations. When we look at 2 stent versus 1 stent in complex lesions, the meta-analysis of the RCT, and what it does show in DK crush was that there was a significant advantage in favor of the decay crush strategy out to 5 years. Initially 1 year, then 2 years, then out to 5 years. And there is a catch-up phenomena which occurs as far as the long term is concerned in decay crush. But the provisional catch-up is even more, and it goes up to 18% at the end of 3 years, whereas it remains at about 5% at the end of 3 years with decay crush. The EBC main looked at lesions, but they were actually much simpler, and these two basic differences summarize the differences in the decay crush 5 and the EBC main. The mean syntax was 31, so they were much more complex in the decay crush, whereas it was 23 in the EBC main. Side branch lesion length was 16 millimeters in the decay crush, whereas it was only 7 in the EBC main. The definition again looked at two stent versus provisional. 25% of these were bifurcation, left main bifurcations, and at 1 year, the primary endpoint, the target lesion failure, was much higher in the one stent, that is 11.4% versus 6% in the two stent strategies. Again, we'll not go into the detail. This is a total meta-analysis of all the bifurcation studies that was published in Journal of American Heart Association, and it shows a significant advantage as far as cardiac death, MACE, MI, stent thrombosis, TLR, and TVR is concerned in favor of decay crush in comparison to all the bifurcation studies shown, especially in complex lesions. So what about the recommendations? Both from the EBC, which says the layered provisional approach is the chosen one as far as simple lesions are concerned. But in patients who have the definition major criteria or side branch with challenging access, one considers a two-stent strategy and reassess after crossover in all the other subsets using angiography, imaging, and physiology, and escalation to two-strut in case of these particular endpoints in these three modalities that we see. That's what the Euro intervention EBC also says. In case we look at the minor criteria, if it's multiple lesions, if it's complex, consider an operator preference two-stent strategy. The Europeans are not very fond of decay crush, but still it is mentioned, and that's a very big victory. This is the ACC-AHA, which essentially says the same thing. And the EBC also says an intentional two-stent strategy represents optimal practice in selected patients with complex lesions involving large and diseased side branches, especially in LM location. Thus, a provisional one-stent approach remains the most common treatment strategy. Patient selection, meticulous procedure with invasive imaging, especially for the left main, key optimization techniques are the key for acute and long-term clinical success. In simple lesions, one stent always better if feasible. The layered provisional offers the best option. In complex lesions, an upfront two-stent strategy with whatever the operator is comfortable with. Choose the strategy keeping in mind resources, expertise, lesion, and patient complexity. Try to choose the hardware that has the best chance of crossing in the first attempt. This is one message which I'd like to give. Instead of trying to see, will this balloon cross, and trying to save time, use the wire that is most likely to cross. Use the balloon which is most likely to cross. Use the stent which is most likely to cross in the first attempt. Simple lesions is well defined. Even if two stents one uses in a single lesion, there's not much difference in outcome. That's the information that comes from EBC main. If complex, if you're not planning a two-stent strategy, the outcomes are worse. That means if one does have a complex lesion, it's better to use a two-stent strategy. In an LM bifurcation is a true bifurcation. Wherever it's a true bifurcation, two stents are better. This is what happened to our cases. Starting trouble, microcatheter wouldn't cross, small balloon, followed by peck and polish rota, an assessment of the lesion, finished with a decay crush. That's our final result. And these are our imaging measurements, which were perfectly good. 7 and 11 in the distal part of the stent and in the proximal left main. The second case was done as a single crossover with an LM LAD, pot, repot, a kiss, and then a repot again. And that's our final shot. Thank you for your attention.
Thanks, Ajay, for a wonderful presentation, and more so because you finished in time. So, the next speaker is Dr. Dugal.
May we now request Dr. J.S. Dugal to come on stage and deliver their presentation.
Very good morning to you all. My presentation has become very simple after Ajay has described the EBC, which favors a provisional strategy. So So the most important approach to this is provisional is you start with one stent strategy. That is what is called layered. And if you have some problem down the line, then you can go for a tap. So the provisional stenting, you wire the side branch, do a crossover stent, and then if there is a compromise of the side branch, yes or no. If it is no, just leave it. Otherwise, do a balloon angioplasty, success, leave it. And if you are not successful, then you have to put two stent strategy, which may be tap, or it may be crush, cullet, or different two stent strategies. Now, the most important thing is side branch assessment after putting a stent in the main branch. Is it compromised? Yes or no? And if it has to be rewired, then you rewire, remove the jailed wire, do a kissing balloon, do a pot, good result. Still, it can be left, or you have to go in for stenting. Now, I'll basically show you all these steps. You have to assess the anatomy, which has already been described. Then wiring and rewiring, pre-dilatation of the main branch, oblique side branch, main branch stenting, optimization after main branch stenting, and a second stent in provisional stent if you have to put two. Now, regardless of stenting degree, you have to assess. Now, assessment, you have to see the diameters of the branches, the lesion length, the length of the plaque and plaque distribution, and the bifurcation angle. Now, provisional stenting is recommended as a default strategy for approaching bifurcation PCI. Main postulate of this provisional stenting strategy are optimal main branch stenting and possibility of subsequent side branch stenting in case of significant flow impairment or severe stenosis with hemodynamic compromise of clinical importance. Now, keep in mind that the long-term outcome of the bifurcation technique is the main branch success of doing a main branch properly. Therefore, optimizing the result of main branch should take a priority over preeminence of angioplasty results in the side branch. Now, coming to the wiring and rewiring, the peri-procedural occlusion of a large side branch, i.e. more than 2.5 millimeter, has recognized as a contributor of impaired post-PCI prognosis, whereas a jailed wire has been shown to improve the rate of side branch reopening in this if it occurs. The rationale of side branch prior to main branch stenting is mainly built on the following observation. It acts as a marker of rewiring of the side branch, reduces the angle, which becomes more favorable, and jailed wire may improve the patency of after the main branch stenting of the side branch. So, wiring and rewiring in case of clinical urgency after failed multiple attempts at side branch, wiring a small balloon can be advanced over the jailed wire through the stent struts and the vessel wall to facilitate side branch opening. Jailed wire acts as a marker and as an anchor also for the deep intubation of guide wire and increases support in case of side branch crossing. Elective side branch is recommended in all cases where the operator deems that the side branch is clinically important and always when treating the true bifurcation disease. Now, when using two wires, the most angulated vessel should be wired first to avoid wire wrapping. Following main branch stenting, the third wire may be used or the main branch may be removed and you may remove the jailed wire. Side branch wiring is required if there is a dissection, thrombus, stenosis of more than 75% with flow impairment. When third wire not used, the main branch, when you're putting the main branch wire, it should be pre-shaped, the distal tip, so that you can match the angulation of the side branch. After wiring the side branch, the jailed wire is removed and placed in the main branch. Now, rationale for main branch and optimal lesion, sorry, it has gone back. So, rationale for main branch and side branch pre-dilatation. Now, this is whether you should dilate, but side branch should only be dilated if the SS is difficult, it's a calcified, and there a side branch flow is impaired after initial wiring. If side branch is done, it should be carefully assessed before main branch stenting if needing to switch to two-stent strategy. Now, appropriate sizing is very important. You should select the approach side. Long-term outcome should mainly allow avoiding malapposition of proximal and scaffolding of side branch. So you should use a drug-eluting stent according to the distal main branch diameter, and you should keep it 8 to 10 millimeter inside the proximal to the carina. So therefore, for optimization, and now the pot balloons are available. Familiarity with the stent design to avoid stent distortion and stent fracture. Also be familiar with the maximal stent expansion and the cell size, and to avoid side branch occlusion and distal branch dissection. Now, according to the randomized data, routine kissing balloon in provisional bifurcation does not improve outcome. However, it is required if one of the three following is there: if there is a stenosis, impaired flow, and central to obtain central carinal position. Rewiring through the distal strut and NC balloon dilatation is very important. Now, this step is very important because it prevents the carinal shift. Now, kissing balloon is recommended when the NC, according to the side branch and distal branch size and short overlap, and optimal pot. Now, this is very important that you're crossing. If you cross proximal, you'll distort the stent which is seen in the C. But if you cross it distally, you will not distort the stent. And pot also improves you see the two pictures on the right side of the screen, you get a better lumen of the side branch. Now, second stent is required if the following has to be done. You have to do a T and a tap, a cullet, or a DK crush. So I'll now come to the how it is done. These are the randomized trials which shows that whether you should routinely do a kiss on they have not shown any clinical benefit. These are the 5 trials which have been done. So the debate needs whether the clearing of the overhanging or a floating stent struts across the side branch. So this is one of the case I will show you. Sorry, it's not moving. So this is wiring of the side branch and then crossing because the access to the main branch was difficult, so you cross it with a double lumen catheter which was done, and then IVUS was done. OCT was done, and then we dilated the provisional stenting. You see there is an involvement of the LAD and ostium of the left main. So after this dilatation was done, stented the main branch. So this was after dilatation. This is the main branch stenting, keeping the wire inside the side branch. And then a pot was done. And then this was rewired. This is the pot being done. This is rewired. Now this is very important that you can see that the wire crossing is near the carina, the distal portion, the distal strut. And this was followed by a kissing balloon. And this repot was done after kissing balloon. And this was the final result. So this was a single stent strategy, provisional. But if something happens to the side branch, then you have to go for 2-stent strategy, and that is the tap. Now for a tap, you have a favorable angle. That angle which has been discussed between 70 to 90 is favorable. Less than 70, the stent will more protrude, and this is how you can do with the stent boost, or you can do, and you can image this and see that your stent struts which are coming into the main branch is minimum, and that is very important aspect. And you can see this is after keeping the stent strut inside and dilatation, and this was the final result. So this was after doing a provisional strategy, the flow in the LED was less, and then we had to go in for a second, and that was a tap. Thank you.
Excellent presentation on provisional. The concept is, I think, the mainstay of EBC and the European operators. I think let's go to the next presenter. I think we can have a discussion at the end of this session. Can you join us on the dais, Tony?
May we now request Dr. Sridhar Kasturi to come on stage and deliver their presentation.
A very good morning to all of you. So today I'm going to discuss about the decay crush technique and its tips and tricks. It's the most studied two-stent technique, and it's a very challenging problem because it involves multiple steps, because you have performed two-step kissing and crossing twice and part, repart, all these steps are there, so more steps are required. This was introduced by Dr. Chen group in 2005. So as you all aware, as per the previous speakers, provisional stenting is the preferred and recommended stenting strategy for most coronary bifurcations. But complex bifurcation, definitely they do require a two-stent technique. So always, unlike the angiography, you analyze the angiographic analysis of the bifurcation, how is the main vessel, how is the main branch, how is the side branch, and always take at least two orthogonal views to study the bifurcation angles. So with this, most important nowadays, because many studies have shown there is a robust evidence of imaging for bifurcation techniques. Because if you use imaging, the MACE rate is going to be reduced very significantly. Confirm the angiographic analysis, assess the plaque morphology. Always see plaque morphology, is it extending the main vessel to main branch or side branch, and where the plaque burden, luminal areas, everywhere along the bifurcation you assess. And you also choose the diameter and length of the vessel. Patient requires two stents or single stent. And at the end of the procedure, always look for the dust predictors, that is malopacini there, an expansion is adequate or not, are you leaving any medial dissection. The most important key for the success is proper preparation of the lesion, right technique, and optimization of the dust implantation is very, very important. Always when you do the bifurcation lesions, is it left main, non-left main? So if left main, you have to achieve these main stent areas. If non-left main, at least you should achieve more than, IVA studies more than 5.5 square mm. If the OCT, more than 4 square mm. So the steps are, the first, for any bifurcation, lesion preparation is mandatory. Assess the plaque, if the lipid or fibrolipid or calcific. If the calcific, definitely you have to use atherectomy or IVL to prepare the plaque nicely, and subsequently implant the side branch stent and always project 2 to 3 mm into the main vessel. If you don't project sometimes they say nano-crush only 1 mm, you may miss the side branch ostium. That may be associated with the MACE rate. And if you are projecting too much, the more metal burden into the main vessel and MACE rate may go up. So, and crush the stent. Before you crush, always keep them balloon, appropriate balloon in the main vessel. If you don't keep balloon, suppose if you are crushing, after that if you pass the balloon, it is difficult to enter because sometimes it can hit the edge of the stent and it may lead to LSD or it may lead to very, very difficult situation. Always keep the balloon in the main vessel before you crush it, before you place the stent, and pull it and crush it. That's very important. Side branch wiring is very important in decay crush. The distal crossing is not mandatory. Only you have to cross the proximally. Proximal crossing is very important, and first kissing and after crossing with appropriate, most important, appropriate size balloon. Side branch should be adequately dilated with a NC, proper size balloon. But after expanding, take the two balloons and one balloon to the side branch and then to And these balloons should be extended only 2 to 3 mm. Don't extend too much into the main vessel. That is important. And then you put the main vessel stenting and part should be performed. After that, recross and final KBI should be done. Then you take the balloon and repart, and then you confirm the angiographic success and do the imaging and see adequately. I'll show some case example, 2 case examples. And see here, it's ambiguous. LED and diagonal almost overlapped. And ramus, see L6, ramus, L6 and diagonal, very nearby, very difficult to detect angiographically. And you see the angiogram, huge diagonal. So always decay crush can be performed through the 6 French, provided if the patient is not having a very complex bifurcation like a calcified, angulated, where you require more microcatheters, more atherectomy devices. So OCT showed fibrous lesion, the fibrous block, diffuse fibrous block. You can see very nicely, L6 origin, diagonal origin, all, you can see the trifurcation very, very clearly. So analyze always how is the left main area. You see the left main area 13 square mm, and LED area you can analyze at various segments. How is the diagonal origin, how is the ramus L6 origin, all these things you have to analyze prior to the procedure. So morphology, what is the morphology? The patient is having a fibrous block and lesion length is more than 30 mm and diameter is 3 mm distal and approximately 3.5 mm. You can see the LED and diagonal bifurcation, you can see ostia, you can see very nicely, and LED and L6 ostia. Ostia is very nice, the size is big, unlikely to close in the bifurcation lesion. So avoid oversizing of the balloons, that is very important. It may lead to dissection or it may lead to intramural hematomas or perforations. Appropriate, when you use the imaging, always use the appropriate sized balloon and observe the balloon, is it expanding properly or not, and recommended is adequate main vessel, main branch, side branch preparation is very, very essential. Always use the advanced S and careful stent sizing according to the distal vessel, that is distal vessel diameter, that is very important. So after that, we thought of doing the decay crush. You can see that we are preparing the lesion with the 2.5 main vessel and side branch, and main was prepared. And then we put the D1 stenting. And D1 stent, after D1 stenting, always pull the balloon, go with high pressure, expand the ostium of the side branch stent very nicely. If needed, take the NC and appropriate size balloon, optimally expand. That is very important. Once you do the expansion, pull the balloon, pull the wire, and pull the main. Before crushing, always keep the main vessel balloon. That is very important. It's very difficult to cross if you crush and if you want to cross later. So side branch stent 2 to 3 mm into the main vessel, and before removing the side branch, always cross check, are you pulling the balloon also or not? So balloon, wire remove and pull the main vessel balloon and crush with adequate. That size should be adequate. If adequate balloon size is not there, the crush is improper. When the crush is inadequate, sometimes it's very difficult to place a wire into the side branch. So you can see here very clearly, even crushed segment also you can see what is the length of the crushed segment also. Here you can see 3 mm crushed segment, and once you do it, again recross. Put the balloon. First to do the first kissing, put the main vessel stenting and recross. Recross, then you put one balloon to the side branch, one balloon to the main branch, and that second kissing should be performed. So now we are implementing the main vessel stenting. You can see the part before crossing again, you should do the part with the appropriate size balloon and recross and then kissing. When you do the kissing, side branch inflation is first, almost 14 to 16 atmosphere, then main branch, then gradually inflate both and deflate very, very slowly. And that is important step so that it can opposite to carina very well. So part balloon size is very important. Don't go beyond the carina site. If you go beyond, it can pinch the main vessel and it can cause the side branch occlusion. And don't come proximal to the main proximal edge of the stent. That is also very important. Appropriately sized balloon is very important. And if you don't do the adequate part, the wire can go abdominally, and the wire can go into the side branch through the abdominal position, and that may lead to a longitudinal stent deformation. So always you have to keep these steps in mind. So another one is, you can see, once you do it, always take the main luminal areas at every segment. That is, what is the MSD of the LED stent, left main stent, and at the same time, the diagonal stent, wherever you are doing, and this, have you achieved the area or not? You see, distal landing zone is 4.4 square mm, and you see the proximal 5 square mm, and this is always to take the pull back post stent and see the stent is adequately expanded or not, opposed well or not, any medial edge resection is there or not. Then you, if you achieve these targets, finish the procedure. Otherwise, post dilate and do it. That is very important. See, proximal edge of the stent, we got 9 square mm, and distal edge of the stent, we got 6.42 square mm. No medial edge resection, well opposed and well expanded stent. Always in the 3 mode, you can assess the side branch ostia. If studs are there, you press the balloon and again redilate it. So under expansion should be eliminated, because under expansion in 2 stent has a very, very high risk of restenosis rate, and operators should be familiar with the expansion capability of the every stent. So in the cath lab, you should have a chart. So this is the final result, and you can see LED is flowing very well, diagonal is flowing well, LCX is not compromised, so there is no left main compromise. So the another case, this is the, you see the LM bifurcation severely calcified, calcific plaque extending into the LED as well as the left circumflex, angulated. So when you see such angulated lesions, always you should think of keeping the special catheters, like you have to use Supercross or Crusade or Sasuke to cross the lesions, and always microcatheter, or you have to change the shape of the wires. Then run through microcatheter, preparation of the lesion 2 mm, 2.15. So if that is the, then I will go to the final few. See, always in 2-stent technique, decay crush, with the 2-step crush, kissing, what happened, there will not be any stent starts across the ostia. That is the reason their results are much better. Already this was discussed. The results are far better compared to crush versus decay in decay crush 1, and provisional stent versus decay in decay crush 2, and Kulat versus decay, the decay results are far better. Again, decay crush 4 trial has shown it is superior not only in provisional, even complex. So the recent meta-analysis has shown when the side branch is more than 10 mm, and particularly it is when the side branch length is more than 10 mm is there, the results of decay crush or 2-stent technique is far superior compared to the provisional technique. And with this note, I will conclude. So be familiar with the decay crush technique, but it involves multiple steps, but you have to learn, because it is also with better long-term results. Thank you, one and all.
Thank you, Dr. Sridhar. Please come and join us on stage here. Our next talk is going to be QLOT by Dr. Milind Phadke. We started about 20 minutes late, so we're trying to finish and hand over the hall on time for the next session. We'll try and have a discussion at the end if we have time.
So good morning, respected chairpersons and members of the audience. I'm grateful to the NIC and the Bifurcation Club for this opportunity. And now I would talk on the QLOT technique today. After its initial description by Dr. Chevalier, it has undergone quite a few modifications. But the striking thing about QLOT is that it is a versatile technique which is applicable to 1-stent provisional as well as the 2-stent strategy. As far as the provisional is concerned, it can be performed as the last step of the A family when you are stenting across the side branch into the distal main branch, or it can be an inverted provisional strategy in which you first stent into the side branch, depending upon the anticipated difficulty in wiring the side branch. So QLOT can be both strategies. Now, when you are deciding that you need 2 stents, then depending upon the difficulty of wiring and the chances of losing the side branch, you can either do a main branch stenting first and then a culotte, or more commonly, if your side branch is tough, your access is difficult and you're likely to lose it, people do an inverted culotte, in which first stent into the side branch from the main branch and then you tackle the main branch. Patient selection for culotte is extremely important. You should have a fairly large side branch, and importantly, the 2 branches should be almost of the same diameter, preferably within 0.5 millimeters of each other. And it is favorable for angles of bifurcation which are less than 70 degrees. It's not a good condition, not a good technique for near right angle bifurcations, for which tap would be more suitable. So I'm just going to go through this presentation continuously with a case. 52-year-old male with an end STEMI, good LV systolic function, a typical 1-1-1 bifurcation of the LAD and diagonal with a fairly large diagonal, as you can see in all the various views. So much has been spoken about angiographic assessment and imaging. Imaging is important. I'm not going to details, it has been talked about, but at every step of the procedure, right from choosing, selection, assessment till the final evaluation of stenting, imaging plays an important role. We start by wiring both the branches, and then adequate lesion preparation is extremely important. Here imaging also helps us decide to what extent and with what material we want to debulk the lesion. Now, which stent first, main branch or side branch? It generally depends upon which branch is more difficult to access. So if your side branch is tortuous, it is angulated, it has a critical long disease, there is a high chance of losing it. Many a times we end up doing the inverted culotte, in which we stent from the main vessel to the side branch first. So here, as an inverted culotte, we have deployed the stent in the more angulated branch. You still have the main vessel wire there. Then you deflate and remove the stent and the balloon. Now, the stent is always to be sized as per the distal vessel diameter. And adequate length of the stent should be ensured in the proximal vessel to ensure that you can do port as per the shortest port balloon that you have. Then after post-dilatation, okay, so here we can see in our case, both vessels are wired. The main branch lesion was dilated. After melon seeding, the side branch lesion could also be dilated. It was a tough lesion. Then the side branch stent is positioned to ensure optimal length for subsequent ports. Then you use an NC balloon for good dilatation of the side branch ostium at high pressures. And then you perform the first port, maintaining the wire position in the non-stented branch. Now, very important, port should be done with a 1:1 sized NC balloon, which is sized to the proximal main vessel, and the position should be such that the balloon marker is at the carina, and adequate high pressure port should be done, because this will influence subsequent steps. Now, it is important when you rewire the unstented branch, you do it through a distal strut, because proximal strut wiring can have problems. Then open up the strut through with a small balloon. So this has been shown. This is the first port. Then this is the rewiring of the main branch. So note the jailed wire. So this is a third wire which has been taken. So either you can use a pullback technique using the same wire, or some prefer to use a third wire. So important thing, when you remove the jailed wire, when you pull it out, avoid deep intubation of the guiding catheter, which can sometimes occur and cause dissection. Now, at this point, some people are doing a variation. Increasingly, now the trend is to do one kissing balloon at this point. So this is called a decay culotte. So we are not doing it routinely, but it's coming up in the data and in the bench testing. Then after that, you position and deploy the second stent. Very important to have minimal overlap. Now, from initial culotte to mini culotte, now people are even speaking of nano culotte, so that you do not significantly cross the polygon of confluence. So if you have this kind of minimal overlap, then you avoid making long, rigid metal tubes, which has been one of the criticisms of culotte. I won't speak of the POC because Raunak has done it already. So here, in our case, the strut into the main vessel is open. The main stent, vessel stent, so this is a little more overlap, but now the trend is to go for even lesser and lesser overlap. And the main vessel is now stented. Sometimes if you're doing a decay culotte and you have done a very distal report, then you may have, and proximal rewiring, you may have some difficulty in rewiring. So this is overcome by doing adequate port and doing a distal rewiring. Now we come to the second port. Overall, there are 3 ports in culotte. So again, same principles as regards the balloon size and position. So after the second pot is done adequately with the marker at the carina, now again the side branch which you had stented in the beginning is rewired, again through a distal strut. And so this is the rewiring of the side branch for distal strut. Now there are two problems here. Suppose you have not done an adequate pot and your wire goes abluminally, then the subsequent steps can result in the main vessel stent being pushed and a gap being created distal to the carina. On the other hand, if you do a proximal wiring inadvertently, you will end up with a long metallic neocarina, which you want to avoid. Now, if you have difficulty in rewiring, the commonest cause is an inadequate pot and an insufficiently distal pot. So to prevent this, both these things have to be done. So again, go for a repot with adequately sized balloon, and sometimes changing the wire to a more torqueable or polymer coated or a more tougher wire helps. So in our case now, the main vessel stent is post dilated, second pot is done, and then we have done a distal rewiring of the side branch, as you can see here. There is some difficulty in balloon crossing, but ultimately the balloon crosses and you dilate the strut into the side branch. Then you do a kissing balloon inflation. Now if you're doing a DK culotte, this is the second kissing balloon inflation, like in DK crush. Three important points in kissing balloon inflation: short non-compliant balloons which are sized 1:1 to the distal vessels. The distal markers should be at the level of the carina, so avoid crossing the polygon of confluence. Do not do long overlapping segments for kissing. And first, sequentially dilate both the branches at high pressures, and then followed by simultaneous dilations to moderate pressure and near simultaneous deflation of both balloons. So this is the ideal recommended technique and sequence for kissing balloon inflation. But the most important trouble that we have here as well as in DK crush is where we are unable to get a balloon back into the side branch for the kiss. So three problems can have occurred here. Number one, a wire wrap, which you prevent by avoiding excessive rotation of the wire, or then you may just have to get out one wire, pass the balloon over the other wire, and then get the other wire again. Then if you have inadvertently wired the proximal strut, then it is a good idea to go back, change your strut, rewire into the distal strut. And if you have not done an adequate pot, again, this can be a problem. So in most of the cases, an adequate pot and a distal rewiring will solve your problems. Then this is the final and third pot to circularize everything and to give an optimum result at the polygon of confluence. Again, the important principles are like those of the first two pots, but importantly here, your pot position should be slightly more proximal so that you avoid displacing the carina. So just in our case, the kissing balloon inflation has been done here. This is the final pot. As I said, one should not pot too distally. And here are the final results. So just a quick word about, so this is the model, the picture in the EBC presentation, which shows how there is uniform coverage and good scaffolding of both branches in a properly done culotte. So the advantages of this technique, as I said, is that it is versatile. It can be done both with the provisional technique and the two-stent technique. You can do it as an inverted culotte, you can do it as a classical culotte, and it gives good scaffolding of the vessels of the bifurcation. In fact, this is also voiced as a criticism that it effectively converts the bifurcation into rigid metallic tubes. And so therefore, and technically also the final rewiring and passing a balloon is slightly easier than in DK crush. And if you do mini or nano culotte to minimize the area of overlap, this problem of causing rigid metallic tubes may be minimized. Just one quick slide about DK culotte. At least bench testing has shown that if you do DK culotte as opposed to a conventional culotte, there is less deformation of the side branch struts, and there is much lower rate of stent malapposition, especially in the proximal main vessel and the roof of the polygon of confluence. So just to show here how there is less deformation and less under expansion, and C and C are mini culotte, DK culotte, and D and D are conventional culotte. So you can see that there are far fewer struts across the side branch ostium when you do a DK culotte. Of course, crush has its own advantages because you do not lose access to the main wire during the main branch during the procedure. So if you have dissections, crush is a much better way to tackle them. And clinically in left main bifurcations, DK crush has been clearly shown to be superior to culotte in terms of outcomes in DK crush 3. Nonetheless, if I were to give some take-home messages, I think it is a very important technique to know for all specialists, all people who do bifurcations, and it has its own niche indication in selected patients. It's very important to choose your patients well in terms of anatomy, the bifurcation angle, and the size of the vessels. And it would cause probably less metal in the proximal bifurcations. In left main bifurcations, as of today, when you take conventional culotte, decay crush is superior, but we do not know if we can get better results with mini and nano culotte, and especially with the decay culotte. Most importantly, apart from lesion preparation, the two key steps are doing an adequate pot and doing distal rewiring. If these are followed, I think most of the problems and troubleshooting that is needed in culotte would not be needed. And as I said, the newer iterations of the technique like decay culotte and mini nano culotte may have a chance to improve results. This remains to be proven. Thank you.
Thank you, Milind, for an excellent presentation. Can you join us on the dais? Yeah, I have the next presentation. Sorry for this small delay that. NIC chairpersons, seniors and dear friends, thank you for giving us this opportunity. My presentation is alternative techniques that we have been proposing for the last few years. And this is the balloon occlusion side branch stenting.
We can go to presentation mode, sir. It's still on this one. Down bottom of the screen, you can go to presentation. PowerPoint, down. Yeah.
So this is the balloon occlusion side branch stenting technique that we have been proposing for the last few years. This actually takes the cue from the T stenting, which was later modified to the TAP by Antonio Colombo and colleagues. As we all know, that TAP and T have several drawbacks. Often is the geographic miss, often is excessive protrusion in the main branch, and this excessive protrusion basically hampers future interventions. There is metal load at the carina, there is a neocarina formation. There is metal load at the side, where there are areas of low shear and stress. And this is an iconic slide from the EBC, where there is geographic miss. You have another short stent deployed there. You have excessive, less than excessive protrusion, then you crush and then rewire and kissing balloon and pot. And then when there is excessive protrusion in the main branch, you convert this into a culotte. So as a solution, I've been proposing this technique for the last several years. And we presented this technique in EBC 2018 in Porto. So after we started searching for literature, we found this presentation by Dr. Leonard Schwartz, who had done about 12 cases in, but that was way back in 2002. And it was only for LED diagonal, and then he gave up doing this technique. The reasons we didn't go into. And he had a near 90% success rate in 14 cases attempted, successful in 13. So balloon occluding the stented main branch and then pulling the stent in the side branch for a perfect ostial deployment can be an option. So this is an animation where we have a stented main branch. We then advance the stent into the side branch, occlude the main branch with less than nominal pressure. The pressure differential is what the operator decides, as I will show in the animation, and then we can always discuss this. And then you should have just enough pressure in the main branch balloon so that you can pull the side branch stent towards the ostium. And as we pull towards the ostium, when you're reasonably convinced that your stent is just at the ostium, a little into the main branch, you start inflating the stent and simultaneously start inflating the main branch balloon to nominal pressure. Another animation. You pull the side branch stent, deploy the stent. Kissing balloon can be an option, and this is how you have a good coverage of the. Basic idea of doing this technique is to prevent excessive protrusion in the main branch and have a good coverage at the ostium with minimal metal load at the carina. So this is what is the impedient or impeding factor in a perfect tap. Very often you see that the tap, when you attempt a tap, it is less than perfect. It's purely because of we ignore cardiac motion. When you have, especially the cardiac motion is maximal at the left main bifurcation, with all segments moving in different directions. So this is what prevents you, even if you have a good position of the side branch stent into the main branch and you're reasonably convinced that this is where I should deploy. When you start deploying, there can be a shift in or out of the ostium. And this is purely because of cardiac motion. So I would show a few cases here. And this is where you see this stent boost picture. There's a perfect deployment at the ostium. And this is the final result. Then we have a boss done in a narrow angle. If you see there's a dissection, we tried to open the side branch strut. There was a dissection. We had to handle this. And you see this, as I'm inflating the main branch balloon, my side branch stent in place. I'm pulling the side branch. There you see the pull of the side branch stent, and that's where we deployed this. And this was the final result. I will skip this. And you see in the longitudinal view, there is a good side branch and good ostium, which is fully open and with minimal protrusion or practically no protrusion in the main branch. That's the LAD. In the calcified situation, again a narrow angle, was a little challenging here. We had to do a rotablator on both these vessels. And then first we deployed the left main circumflex, open the strut, and then you have the boss. A narrow angle is a little challenge here, but we could still end up giving a good result, and this is how it is. This patient had a follow-up at the end of 1 year, and it showed a good disposition of both the stent with no ISR. So this was actually our first case when we started doing the boss technique. This patient was referred to us for pulmonary hypertension, cardiogenic shock, and was on a ventilator. So a flush LED, possibly a diagonal there, and there was a big bald area in the circumflex territory. Patient had grade 2+ metal incompetence, and that was leading to his compromise. So we first decided to probe the very minor OM, and if you're surprised that this minor OM was actually a big branch, a lot of small branches, and we first decided to do this ostial boss. We occluded the main branch, pulled the side branch, stent into the ostium, and deployed, got a perfect deployment. And then we went to the LAD. So LAD was a little tricky, and this patient was on a balloon pump. So we wanted to finish this before the patient was well covered hemodynamically. So wiring was a little issue, was challenging, and this patient had mitral incompetence, and this mitral incompetence became negligible at the end of the first procedure. So, so we wired the LAD. We just let the wire go wherever it goes. First, it went to the diagonal, and then with some manipulation, we could enter the LED. We did a kissing balloon, and then we deployed the LED stent first. And then you see we have this diagonal stent, a little longer one. The diagonal had long segment disease. And this was a bailout procedure. So we just wanted to ensure the patient is fully revascularized, because he had good segments of myocardial viability, and we could achieve an excellent result here. So we had the luck of, angioing this patient at the end of 10 months, showed a good bifurcation with no ISR, and a good LV function with no atrial regurgitation. BOSS is a bailout. Yes, we have this LED stent post, so I'll just go back. Post dilatation, the diagonal closes, there was plug shift. So we had to rewire, and then we did a BOSS. And this is how the stent is beautifully deployed the ostium. This is a patient we did recently. Total occluded LED, there's ostial circumflex, rather the large OM. Stented the left main, opened the strut, and the BOSS technique. And there's a beautiful disposition of this stent. And this patient had marked improvement in LV function at the end of 4 weeks. So BOSS is not, everything is not hunky-dory. Yes, you have to be a little vigilant. So we had this patient, again a cardiogenic shock, 87-year-old gentleman with CKD, had a left main bifurcation and a LED, long LED and a large diagonal. So we first did a DK crush on this LED diagonal, and then if you see the left main and the ostial circumflex is pretty tight. We stented the left main, then did a BOSS. But here if you see, and we realized this as soon as the balloon, our stent had gone down to the circumflex, we had missed the ostium. And this is primarily because the patient was in cardiogenic shock, he was not very good hemodynamic despite a balloon pump. So we see this, you see there's a miss, there's ostial miss. So we then had no choice but to put another stent, and this time we could do it perfectly. And this patient recovered, creatinine normalized, went home. And this patient, would like to tell you that he just stopped all his medication except statins at the end of 1 year. And he is still living well. So, a take-home message on the BOSS technique. Most often gives you a perfect deployment sideband ostium. Can be employed for narrow angles, especially the wider angles. The narrow angle would be a little tricky. There is ease of reintervention, which is very important. Stent crush at the edges is a proof of good deployment and full coverage of the carina. Restores integrity of the carina. It ensures laminar flow and leaves the bifurcation with minimal metal burden. Thank you.
I think wonderful talk, and it's nice to see some work being done in the bifurcation field, which looks like as though everything has already been seen and we're just reiterating what others do. Our last talk for this session is Dr. Ronnie Matthew, Insights from Imaging for Bifurcation.
May we now request Dr. Roni Matthew K to come on stage and deliver their presentation.
Yeah, thank you, NIC, on behalf of Bifurcation Club. So I've been asked to give you an insight on the bifurcation PCI from imaging, and that's actually a couple of sessions talk, but I will try and summarize this in 10 minutes for you. Now, this is the only and the largest OCT trial that was done in the country, prospective, multi-center from 9 centers, and this gave us a very important information that when you do imaging, you change your decisions in nearly 89% of cases. So imaging does make a difference. And I think in bifurcations, at the last ESC, October trial proved it. There was a 30% reduction in your major adverse cardiac events and nearly a 40% reduction in mortality. And why do we think of imaging and OCT in bifurcations? It's very simple. This bifurcation has overlap and foreshortening, and you will miss it. unless you see a luminal view or a cross-sectional view. And more importantly, you get a three-dimensional view of the bifurcation. And that makes imaging a perfect solution to do a perfect bifurcation stenting. So these are where I think OCT helps in bifurcations. And now let me talk to you about some of the insights we have got from imaging at the Bifurcation Club. Now look at this case. You would agree with me that this is a simple case of a crossover stenting from the left main to LAD because the circumflex does not look very significant. There's a lesion over here, the distal circ, so we went and stented that, and then we decided that we're going to go and subsequently do the left main crossover, and mandatorily we will do imaging in all these cases. You see the lesion is fibrotic, and that's a small diagonal that is coming on. You see a very tight stenosis over here. But look at this. That's a circumflex. And there's something that's suspicious that you can see from the main vessel into the side branch on OCT imaging. And that something is a dissection that has occurred into the circumflex ostium. So we're a little taken aback, and did a caudal view where you can see this clearly, and that happened because of the gear that we had taken into the circumflex earlier. So now the strategy changes completely. You got a dissection, and you have to convert this into a DK crush. So we did a DK crush, and we got a good result. Now, this is an insight from a trifurcation. And in this trifurcation also, we first went only with a crossover. And look at what the OCT shows at the crossover. You see large number of multiple struts that are across this trifurcation. That's how it looks there. Pretty nasty. But if you do a simple kiss, move it out, and then do another OCT, you see the side branch cleared of those struts. And now you see a much better trifurcation. So that's an insight that you get, that you can always, you should do a kiss in these cases and not put in multiple stents into the side branches. Now, insights in bifurcation. Now, this is one issue that I think a number of speakers have spoken about. You do a crossover stenting. You sometimes see a strut across the side branch. Should you remove this or not? And there are other cases when there are no struts across the side branch either. And this is some work which we had done over. And you see in this particular case, there is a strut across. And this, years later, comes back with neointimal growth. And that becomes a cause for a restenosis. And this was presented at the Bifurcation Club, and this was suggested to the European Bifurcation Club. And the EBC did put this up in their 15th consensus document, saying that probably this is something that needs to be looked after, asked us to do some study on this, which we are still continuing. Now, some of the insights from the side branch crossing. Now, this again has been talked to by different speakers. Your distal cell cross, whether you're doing a culotte or whether you're doing a provisional, you must do a distal. The reason we do that is because you remove these struts and take it to the side branch and you scaffold this. Now look at the insight from imaging. This is before kissing. You look at these struts. It's across the side branch. Do a distal cross. You can see it. It is a distal cross. You kiss it. And you get these struts here that have moved and scaffolded the side branch, giving you a very nice opening over here. And you can make that out even in your stent. Your strut has got scaffolded up. And a lot of people say that this may not be feasible, but I'm trying to tell you that this is feasible if you try it well enough. The distal cross, as Dr. Dugal had also shown, you can do it in your spider view when you have a jailed wire. You can see the other wire going distally and make out that it's a distal cross. But sometimes When you evaluate it, it is still not a distal cross. Look at this. The wire is crossing proximal to the strut. This is the distal, this is the proximal. So you rewire it. And when you rewire it, you now find that the wire has gone distally. So you can change the wire on OCT and then get a good result. Similarly, in this vessel, you see a number of struts, 2 layers of struts across the side branch. You can do a distal cross, again using the same technique, and then confirm that you are distally so that you get a perfect side branch. So what is suggested is not to do a routine kiss, but to do an OCT, see if you have a strut, and then subsequently decide to do a kiss. Now what happens if you do a proximal cross? And this is the result of a proximal cross. See, you're crossed proximally, you go with the stent and you blow it up, and unfortunately you see this huge load of neometallic carina that is remaining. It's not running, but you can see that. Yeah, you can see this neometallic carina over here, and this is not going to go anywhere. Whatever you do, whether you do a kiss, it's not going to go away. Now, your insights from a post-procedure OCT. Now, this is a case where we are planning to do a T stenting, so we have done a crossover LM stenting, and we open the side branch, and as usual, we try to take a stent across into the side branch, but then, as usual, sometimes this stent is resisting it. And you look at the guide moving up and down. You don't realize this, because then you try to hitch it and try to take the stent inside. It still doesn't go. You try all these antics in the lab. You're still unsuccessful. It's not going to go in. So you do an OCT. And this is what you see. What you have created is, with all your antics, the guide has gone and hit the left main, and you have got a longitudinal compression. And this is not isolated, because in the October trial, in about good number of patients, they had what we call as unintended stent deformation, USD. And that included abdominal wiring, this guide catheter collision, and the mace was very high in them when you left it untreated. And that's one very important reason why you should why you should image in a bifurcation. Try and prevent this unintended stent deformation. So this is a synopsis of what I wanted to tell you about the insight we have gathered. And I think my thoughts on this is very simple, that we have a trial that shows that it decreases MACE and death. Imaging does decrease MACE and death in bifurcation. It has improved our technique. The insights that we got into with TAP, with BOSS, etc. is so good that we've been able to do a precision implantation and stent optimization. And lastly, we have understood bifurcation failures. And I think it all helps us to fine-tune our procedure and our technique even better. Thank you.
Thank you, Ronnie, for an excellent imaging guided bifurcation overview. Can you Ronnie, can you be on the dais? Yeah, any comments from the chairpersons on the left side? Any questions from the audience?
I wanted to ask you a question, because you have worked on this BOSS technique. Now, doesn't the amount of stent onto the side branch differs depending on the type of stent used? Because if there's a stent that is 1 millimeter away from the marker, that is not for the BOSS technique.
Yeah. So we've always maintained in our presentations that you must know the hardware that we use. There are some stents which cover the marker, some stents touch the marker, some stents are say 0.5 millimeters away from the marker. So that does make a difference, yes. And the other difference that makes is the stent platform that we are using. We always need to know the links, the crown length, so all those very important.
Sir, in one of our case in BOSS technique, when you did the stunting of the OM, isolated OM and you put the balloon in the SIR and you didn't stent the SIR. So does it do any dissection, and what size of balloon you choose when you are going to have only?
Yeah, so I think this is a very valid question. The balloon for the main branch is always 1:1. It's a 1:1 balloon. You go at less than nominal pressure, or maybe just 2-3 atmospheres, so that you can exert a pull on the side branch stent. Once you approximate, once you're reasonably sure that the side branch stent is at the ostium or just into the main branch, that is when you go with the main branch balloon to nominal pressure and start deploying the side branch stent simultaneously.
If dissect, sir, if your aim is not to stent the...
So that was a demonstration of a boss, not a boss, that was a demonstration of ostial stenting actually. That was the circumflex OM stenting was an ostial stenting using balloon occlusion. And then we went ahead and did the boss. Boss is a two stent technique. We went and did the boss on the left main bifurcation. So boss we also use as a bailout. When we do provisional and we find there's a side branch that is dissected or needs addressing,
So that means, sir, boss is for only 2 stent, not in isolated.
no, we can use it as a bailout and as a 2 stent strategy, both. Yeah.
Basically, for bifurcation, single stent strategy is the best. If there is any dissection in the side branch, you can do the kissing balloon. And with the stent boost, if there is a need, you can do the nano crush, direct nano crush or reverse nano crush. If you are putting the stent in the side branch first and dilate the balloon in the main branch, have the stent boost and do. And secondly, if by chance there is a dissection or suboptimal, there is a ostial stenosis, then you put a stent and then do a stent boost, good stent boost, and then exact reverse nano crush you can do. This is published in the journal. We did it about 5 years back, and this is the best strategy. And secondly, now we are doing one study in which this kissing balloon of the side branch and stent in the main, and all these 3 patients in that way. Of course, OCT can be helpful in some cases, but otherwise, this is very good.
Yeah, there are several techniques. Basically, a bifurcation strategy is an operator-dependent strategy, what the operator wants.
Basically...
Wait a minute, so there are different techniques for side branches and different techniques as a 2 stent strategy. So all depends on what you want. So there are different, we feel that the bifurcation strategy, technique, the operations are still evolving. And
basically they are evolving, but the thing is, if there is this DCB in the side branch and stent in the main, that is the best strategy. If there is a dissection, then provisional stenting, maybe by any means.
I think there is a confusion also on the nomenclature of these techniques that you have said. I think when you're thinking of a provisional, then we don't talk of a nano crush. According to the EBC, when you do a provisional, then whatever you do to the side branch is either a T, tap or a culotte. When you're talking of a nano crush or, in the sense, or a micro crush or any form of crush, you are first stenting the side branch. Now we have come with some inverted and reverse and all these things. This confuses the issue.
Even if the 2 stent strategy is there, then you can also put the exact stent, this one stent first in the side branch by a balloon, and then no stent comes in between. This is not mini crush or something. This is a precision nano crush.
But that is not provisional.
I think Dr. Rajesh has another...
This is not provisional, but this is...
See him with a comment. Please go ahead.
Ronnie sir, most of us won't have OCT in our labs. So should we do a routine kissing balloon dilatation after a crossover?
No, I don't know the answer for that. Because I think that job was given to Dr. Bhagwat and the Bifurcation Club to do a randomized trial on this, and that has really not taken place in our country. But I think unless that takes place, we can't answer that question. Without imaging, should you do kiss or not?
I would like to answer. There's a cross-kiss trial which is being done in Korea, and the results will be available in 28. So they have doing this. If there are 2 stent strategies, they've taken out. If there is more than 50%, they've taken out. Less than 50%, they've taken with provisional and 50% kissing, 50% no kiss. And this study will be available whether to do kiss routinely or not. So this is known as cross-COBIS study, which will be published. This was discussed in the European Bifurcation Club last year, 23, about this study.
Just one more thing, we had done a study called IOLAF, where for ostial LED, we had done an LM LED crossover, done a pot, measured an FFR into the side branch, and then left it alone, and followed up these patients. Out of the 89 patients who were included, we only included patients who didn't have baseline circumflex disease. 4 of them came back with ACS at the ostium of the circumflex. And out of the other 16 others came back for check angiograms for other reasons within that 1 year. The FFR measured at baseline was the same as what it was in these 16 patients, but 4 of them came back with ostial circumflex stenosis, having had a negative FFR at the baseline end of the procedure. So I think there is a case for pushing the strut away, as Dr. Ronnie showed, and also there's some Japanese data that if you have just a strut across, it's fine. But if you have a link across, then there is a problem, and these patients are predisposed to coming back with problems. So,
Would like to, okay.
please go
everything
ahead.
almost
We have to hand over the hall. So fascinating as the discussion is, I think we'll have to take it offline.
one question. Yeah. So we
The
discussed
answer
it.
will be given. Question is complete. Answer will be given downstairs. I can see the organizers hinting to us very broadly. Please go ahead with the question.
With the bifurcation. And as Roni sir said, this any cross links across the side branch, we have to kiss and pot. What about the side and pot? One strategy is called a pot, side and pot. That is not discussed. When we'll adopt that technique?
Topic for this session is branch bifurcation. The facilitator for this session is N.K. Mahesh. And the chairpersons for this session are Imad Shevan, D.P. Sinha, Alok Mazumdar, Tom Devsia, Girish M.P., M. Chokalingam, B.H. Natish. And the panelists for this session are N. Chandra Kalita, S. Shri Kumar, Sarvana S.A., Anindya Sundar Trivedi, Sivakumar G.X. And the discussants for this session are Viresha P., Prasad P.R. L.N., Prem Shankar, Akash Singh Yadav, Abu Faj, Rama Subramanian N.S., and Anand Raja.
The permission of the chair, I'll start the session because the live case people have the patient on the table and they're waiting. Can I have the first slide on, please? So, so much about bifurcation and so much about possibilities, imaging. I'll just be discussing about one topic, which is the new kid on the block. Not exactly new, but it's not as commonly used. It's a dedicated bifurcation stents, as we know. 15 to 20% of all bifurcation, all coronaries are bifurcations. You have various modalities of techniques for stenting and bifurcation lesions. Everything has its own plus points and negative points. So the most important thing is the decay crush, and that everybody should know. Everybody should have their own go-to bifurcation strategy. The unmentioned fact about decay crush is that if you're not expert in it, if you have not done adequate number of cases, or if you're not correctly tutored, then the recross into the side branch becomes a nightmare. And if you don't recross, then you are in a mess. So all your decay crush goes for a 6 the moment you don't recross. Even if you recross with the wire, if the balloon and the stent doesn't go through, again the purpose lost. So that's why this concept of a dedicated bifurcation stent has come in. It's got proximal anchoring stents. There are 4 markers: distal marker, closed cells, proximal side branch ostial marker, a carina marker, and a proximal main branch marker. The dimensions are as follows. You have main branch segment, which is about 4 L1, L2, and L3 are the 3 divisions you should see. The total stent length is L1 plus L2 plus L3. The L1 and the L2 are the segments which come into the main branch, which is about 5 plus 4, 9.5 millimeters. So on an average, your side branch to main branch distance should be more than 9 millimeters for you to use this stent. So if you have a 3 millimeter left main and a short bifurcation, you cannot use this stent. So your proximal part of the main vessel should be adequate enough space enough for you to land the stent. So these are the four markers that you should know. Between the third and the fourth marker is a set of closed cells which should go into the side branch. Between the ostial marker and the cranial positional marker, you have a flexi connector which is straight. And between the cranial position and the final marker, you have flexi connector which is curved, plus one set of closed cells which are the anchoring cells. So the positioning, all that you need to remember is that this marker, the most important marker, should not come into the main branch. If it comes, then it becomes a culotte. So it makes sure that you just keep it well inside the side branch, your problem will be solved. So it has got distinct advantages of this flexi connected technology. So you have a culotte with no crowding of stents, A. B, you don't have to worry about distal cross, proximal cross. And C, your crossing is extremely easy because the side branches are very big and the holes between the flexi connectors can easily take a stent through, forget about a wire. So specifically designed for actively treat and protect and secure the entire bifurcation, available in a large size matrix, simplifies the procedure, improves the procedure success rate, and decreases the chances of re-stenosis. So you take the side branch stent, put it into the main side branch, you see, just make sure that your last of the closed cells, which is the third marker from the proximal, should be inside the side branch. You get deployed, then you do a pot with the first pot you do with the balloon, so that whatever is the small connectors that is coming in your way gets moved out. Then you recross into the into the main branch, and then you put the stent in the main branch. After you put the stent in the main branch, you recross both the branches and do a kissing, a pot, and come out. So the number of steps are much less, and the procedure becomes much faster. So this is how the thing looks like. The stent sizes are biggest advantage is that if you have a 4 millimeter main cell or a 3.5 millimeter main vessel and a 2.5 millimeter side branch, this stent accommodates the 3.5 to 2.5 step down by making the side branch stent 2.5 and the main branch stent 3.5. Hopefully it will be shown in the next, the live case that they're going to show. I'll just stop by showing one case. This is a lady with an LED D1 lesion. It is not exactly LED D1, it is a dual LED lesion. So both the vessels are equally important. I will call one vessel D1 for convenience. So I have wired the D1 and the LED, and then I have dilated, post-dilatation. Once the dilatation has been done well, you take the side branch stent. The positioning is extremely important. This should be inside the side branch, this at the carina, this is the proximal part. If you happen to get this into the carina branch here, then we will have a problem because the closed cells are going to create problems for you. Once that is done, make sure in multiple views that your ostium is clear, then you gently dilate. Once you dilate, you can see the differential dilatation. This is a 3 vessel and this is a 2.5 vessel. You can see that there's a significant difference in the dilatation of the balloons. Once that is done, okay, now after that I've done an OCT. This is how the stent should look like. This is the distal side branch, this is the carina, and this is the proximal anchors. And in OCT of this patient, exactly the same thing can be seen. The distal side branch, closed cells. There is no closed cells coming into across the bifurcation. Then there is the straight connectors that you can see, and you can see the anchor cells. So OCT shows you clearly that you've done a good job and you have managed to park it exactly where you wanted. This is the cross-sections of OCT. You can see the distal stent has been opposed well, proximal stent opposed well. And finally, this is the bifurcation of the LED ostium. LED, this is the, you're looking at from the LED into the diagonal. This is the diagonal, and this is the main LED that is there. The next step, what you do, you have to, I did post-dilatation of that for making sure that the stent is well. Then you did the first kiss. The first kiss is done by balloon in the main branch and balloon in the side branch. After that, you may stent the main branch. Once the main branch has been stented, you got to do a pot. You got to recross gently and do a kissing again. This is before the kissing. I've done an OCT. This case has been repeatedly, OCTs has been done for purpose of demonstration. you can see that this is the LED, bifurcation view of the LED diagonal. You can see that the LED has been done well. You can see that the ostium has been opened out. One odd strut across the ostium, that's all. This is a three-dimensional view. And this is the LED post OCT pullback. Basically, what you need to see is the bifurcation. So the bifurcation view shows that there is excellent flow and the side branch is flowing very well. And the bifurcation view shows that the ostium of the LED day one separation is very good. So the purpose of introducing this product to you is that it's a modified culotte technique with very less number of struts across the bifurcation. And in addition, when you do a pot, a few struts of the main branch vessel goes back into the side branch and gives it additional strength. Now we'll go on to the live case and see where it takes us from there. Gwen, sir, all yours.
Okay, thank you very much. I think we have to go for live case.
Good evening. We are having a live case from the University Medical Center, Kazakhstan, and the operator will be Dr. Alexei Gonbachar. Yes.
The UMC Hearts opened its doors on October 12, 2011, and is part of the University Medical Center group of clinics. Today, the UMC Heart Center is the leading cardiac surgery clinic in Central Asia. The clinic has been reaccredited in accordance with national and international standards, JCI, for quality and patient safety. The center is one of the best clinics in the world that perform operations of the highest category of complexity in all areas of modern cardiology, cardiac surgery, interventional cardiology, and arrhythmology.
Good afternoon, dear colleagues. Greetings from Astana. We want to thank you for the invitation to participate in this nice event. It is a great honor for us. We are expanding our professional communication and our friendship. Let me introduce our team today. Dr. Alex. Hello, guys. Dr. Kaiser. Namaste. Dr. Nursultan. Dr. Erkejan. Our technical support, Dr. Ergevan. And Dr. Dimash, our anesthesiologist today. Dr. Erkejan presents our clinical case.
Okay, thank you very much for the presentation. We are waiting to know about the case you are showing today.
Okay, thank you.
Hello again, everyone. So let me make a little introduction to the case on today. So this is our heart team, Dr. Marat, Dr. Alex, Dr. Kaysar, and Dr. Yerkejan. So the patient is 60 years old, male sex, with BMI 28.7. Chief compliance on the time of admission was the angina pectoris class 3 CCS and with the good progression in the last 6 months. Cardiac history includes previous myocardial infarction in 2023. Risk factors has a hypertension and also ICD implantation in January 2024. Non-cardiac history goes with chronic kidney disease with GFR 41 milliliters. And ECG on the time of admission was sinus rhythm with pathological Q waves on leads of AVF3, V1 to V4. TTE showed us left ventricle ejection fraction 33%, and also we could mention the anterior septal and apical wall akinesis of the left ventricle hypokinesis through the lateral wall, and we could see the anterior wall viability by the butamine test, which is shown here. So here on the left picture, you can see the poor motion of the lateral anterior wall of the left ventricle, And here, after inducing of 15 microgram to kilogram dobutamine, we can see the viability of the anterior wall of left ventricle, which tells us about good efficacy of our planned procedure. Performed coronary angiography, we can see the right coronary artery with no significant lesions. Severe lesion on the middle third of the left anterior descending artery. And needless to point, severe lesion on the proximal third of the circumflex artery. So by ERL score, risk score shows us 1.6%, syntax score 20, which is intermediate. And our protected PCI algorithm, which gives us the prediction of any support, hemodynamic support, gives us score 1, which is unlikely we're going to use the ECMO support in this case. PCI planning includes right femoral access, and we use 7 French extra backup 3.75 guiding catheter, and of course, IVUS guided decision, LAD and optus marginalis 1 stenting plus left main provisional stenting. Thank you for your attention. Let's get through the case.
Okay. Thank you. Very interesting case.
Short introduction to the case, which we performed using IVUS technology. Dr. Kaysar will continue discussion.
So, hello everybody. The angiographic diameter of optus marginalis is 2.2, but intravascular ultrasound little bit changed our opinion. So let's see the IVUS of optus marginalis. So there's a medium part, and we're pulling back into the during the left main, and we see the significant lesions and diffuse lesions with significant calcium in the ostium of circumflex. So we already used this guide wire, and the diameter is 2.75. This is the first run, and after that, I will show you the second run of the LAD and left main.
Okay.
Great, thank you.
Yeah, next one, run from LAD to left main.
We're switching our series, so yeah.
So let's start from the medium part of LAD. The average diameter of LAD is 3.5, and we're going, pulling back, and we're going to the left main. So the ostium of LAD is also have the significant calcium with diffuse lesions.
You see here the severe calcinosis, in particular in the proximal part. Yeah. And if you see here, approximately 100, more than 180 grad, the calcinosis. But left main also has some plaque, but minimal luminal area revealed good size. Okay, guys, we will start. Can you hear us?
Yeah, please go ahead.
Yeah.
So can you tell us about what you are going to do? That means, what is your plan?
Great question. So, guys, our plan for this case, first implant stent to optus marginal.
Then left main.
After this, we implant. We are planning to implant BMI branch stent from left main to circumflex. After this, rewiring to the LAD and then to LAD. What do you think?
Well, yeah, I think it is very osteal lesion, and in order to cover the ostium, I think crossing to left main is important to be sure that you are treating the ostium of circumflex. And provisional provisional stenting in left main, I think, depends on what will happen on LAD. That means after stenting, you should take IVUS on LAD and see whether it's needed something to do on LAD or you can leave it without stenting. I would ask the panel if they have other opinion, suggestion.
Yeah, yeah. I believe that this case good for provisional case. Of course, that's why we try to implant BioMy branch for good access for LAD. Yeah.
So if you're going with the biomime branch, you've already committed to a two-stent strategy.
Yeah,
It is not a
maybe.
it is two-stent. What are the size of the branch you're taking?
After if in case with implants BioMy branch, of course, we have only two type of stenting, tap or maybe culotte. Yeah.
What are the size of the stent you're taking?
Stent for, do you mean for BioMy branch, yeah?
Dimensions in millimeters. 3.5, 4.
No, 40, 2.5.
2.5? Too small.
The stent.
And 40 for left main, and after this post-delayed with 50 balloon. According to our measurement, with IVUS. So in the first
We
step,
already used the predilatation in circumflex.
okay, first implant stent to obtuse marginal. These are I want to use 2.75, 38 millimeters. Yeah. Very size. Yeah.
What length? What is the length of the stent?
It's quite long lesion in the obtuse marginalis branch. Yeah.
Okay. Yeah, okay. Yeah. Great. Let's check one more. Yeah. Yeah. Just a moment, pull back. Just pull back. Yeah, yeah. Back. Yeah. Okay. Wait, next thing. Yeah. Yeah. Okay. Check, please. Yeah, little back. Back, little back. Yeah. Check, please. Yeah. Great. I think. Great. Yes. Yeah. Okay. Okay. Yeah. Okay. This is 2.75. That.
And how many atmospheres did you do, Doctor?
11. Yeah. Okay. You can increase more. Yeah.
And your atmospheres was 12.
Oh, yeah.
Okay.
12. Okay. Yeah. Okay. Pull back and we can repeat. Or put the delay, please. Osteum of circumflex. Yeah. I think here's the resistance because here's the calcinosis. Yeah. And gently, I want to repeat here's the regulation. This is balloon. Okay. 16. Okay. Yeah. Go well. Okay. Pressure. Yeah. Was delayed with 2012. Yeah. Yeah.
It seems to be, and also from my was that you might have some calcification in distal left main.
Yeah, some calcium, yeah.
So how do you prepare with other device? I mean, before stenting this distal left main, or you are comfortable to put a stent without any preparation?
Yeah, sometimes we do preparation. We have on demand cutting balloon or rota, but we decided now try delayed without the bulking. But for dilatation, we used here the NC balloon. Yeah. Okay. The wire. Yep. Oh, wire. Just a moment. Change wrong. Change do. Yeah. Okay. Yeah, great. Okay. Balloon is too big. Okay, just a moment. Okay. The where? Yeah. Okay. So we postulate now previous stand with balloon 3.5 according to our measurements. Yeah. Okay. I want to add IWAS measurements because IWAS guided decisions better than NGO guided decision. Okay.
Yeah, it also allows us circumferential stand assessment. Yeah. While stand boost enhancement is two-dimensional and only
okay
can be only the diameters can be measured. Yeah.
Yeah. Okay.
What is the size of the balloon?
3.012. Okay. Yeah. Nominal pressure. Okay. Dear colleagues, what do you think about possibility of BMI branch in this case?
Possibility of?
Possibility of provisional for left main. What do you think?
Yeah, it's a good decision. Provisional standing, you mean?
Yeah, yeah.
Yeah. I think, yeah.
Okay,
According
great.
to what we have seen on IWAS, I think it is good decision.
Yeah.
No.
How is the LED? Is it diseased? Is the ostium of the LED clean?
It was clean on IWAS, yeah.
LAD has some plaque, but significant lesion in the middle of the and some proximal parts. Yeah. So, why am I? Yeah.
I think as intention to treat is very good decision, but again, after stenting crossing over from CERC to left main, I would go to check with IWAS on LAD to see what will happen on the ostium or the proximal part of LAD before deciding final decision.
Yeah.
But the catch here is, if you are going to put a bifurcation stent from LAD, from LMCA to circumflex, you have committed to a two-stent strategy. You cannot leave the ostium of the circ with only few struts of the bifurcation stent across.
Okay, now we implant second stand from circumflex to left main via my branch, 3.0, 3.5, length 24 millimeters. Yeah.
Could you repeat the dimensions, please?
3.0.
Okay.
3.5, 4.0, sorry, 4.0, 3.5, length 24 millimeters. Yeah. Yeah. Go. Yeah. Please check one, Angel.
It is not good decision.
No. Go. Yeah. Just a minute. Okay.
Yeah, actually, again, I misunderstand that you are using a dedicated bifurcation stent, which was presented before. And I think in this situation, you cannot leave it without stenting also the second branch because you are not sure to cover everything with this.
Okay. Check angio. Yeah, pull back.
It's not for
So
provisional.
when you deploy
It's
the
not
bifurcation
provisional.
stent, it's got
This
a
is a
tendency to
dedicated
come
two-stent
back into the
strategy.
left main. Just make sure that your third spot is well inside the side branch.
I mean,
That
this
looks
dedicated bifurcation stent is done for double stenting, not for provisional stenting.
exactly. Sir.
Yeah, yeah. Pull back. Just a minute. Pull back. I feel the resistance once again. And I help you. Okay. Just a little bit. Yeah, okay. Check, please. Yeah,
Pull back.
where do you
Pull
think
back.
about this
He has to come back
position?
into the left main a bit more.
Pull back. I want to gently pull back. Uh-huh. Yeah. Check, check. Check, please. Pull back.
Yeah, and post biome branch deployment, the main branch segment can be stented as a regular stent procedure.
Pull back.
One of the great advantages of this stent technology.
Check. Check. Check now. Now.
Got to come back a bit more.
Yeah, yeah. No. Yeah. Little check. Oh, gates. Oops.
Now the stent is protruding outside
Yeah.
of the ostium.
Check. Just a minute. And now, can we change cranial? No. Okay. Just a minute, but. Yes. Now. Back and contrast. Too big.
You have at least 2 millimeters outside.
Yeah. Perimeter outside, yes. I want to advance a little bit. Yeah. Check. Okay. Could you please now? Just cranial.
It seems,
Just cranial.
it seems that there is an issue of the stent protruding too much into the aorta.
Yeah.
Because the short left main. I think this is not a very suitable place to use this stent. You might reconsider using this stent.
And now check, please. Once again. Check. Now.
I think the length of left main in this case is not appropriate for the use of this stent.
Oh, yeah. Maybe. Now?
Protrusion to aorta, too much.
Okay. Check.
Yeah,
I think it's better in the cranial.
Or
The
maybe
position, the cranial position.
change to this stent to LAD. Yeah.
Could you please?
It will be preferable.
Check.
Yeah, okay.
Ready? I think position is better.
One angio, please. Okay, counter.
Can you show us the ostium of the circ?
No,
No, here.
to. We need a pullback, little pullback.
Now it's a good position for the ostium of left main, but I think the position of the stent the piece of the stent, segment of the stent on circumflex will not be covering totally
Yeah, ostium of
The
circumflex.
ostium of circumflex, that is.
To advance a little bit, 2 millimeters. And I want to do this one.
If he goes to the caudal view, the whole situation will be more smooth.
Yes, I think, just a moment. Checking AP cranial. One pull. Okay. Okay. Pull back. Pull back. Because it has it's implant for those radio part marker. Yeah.
And now?
Yeah. More a little bit. Back. 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 Okay.
Okay.
Yeah. Check.
This one. Check. Ninja.
Quickly. More back. Just a moment. No back. Back.
I guess you can position it as proximally as possible and then see if you have actually covered the costume, in which case you
Yeah.
can deploy.
We need a average ostium of circumflex.
Okay, check once again.
One more. Back. Stand back. No, that. Yeah. Okay, just a moment. Check here. Okay. Ostium not covered from branch. This. No. I think we need a change. Change. Yeah.
You have also ran out of time.
What do you think about change?
Can we
Stance?
have a cine, please, so we can exactly know where the position of the ostium is and the ostium of the circus?
Okay. Ready?
Uh-huh. Okay.
Yeah. No, not covered ostium of circumflex.
So actually, second marker should be at the carina.
Yeah.
Yeah.
Exactly.
But
Just
if
one
we-
maybe a spider view. Just a moment. Yeah.
If we check
Okay.
in such manner,
It's close.
Yeah, now you are in the carina, but
yeah.
the I think the
That's,
stent is outside the.
Much protrusion to aorta. Okay. Okay.
and now we can see. Uh-huh.
AP crane. AP crane. Yeah.
I'd like to let you know that we have 3 minutes, 3 minutes and a half
Okay.
And now
for live transmission.
I think we can.
Okay.
We can secure a little bit protrusion.
Yeah. I don't see carina. Guiding forward.
I try to be closer. Now.
Okay. Yeah.
And now we can repeat in here.
Yeah. What do you think, guys?
What is the? Are you in the aorta by any chance, or you are comfortably inside the left main?
I think yes. What do you think, Dr. Marat?
I think it's a optimal position for this situation.
Pull back,
I
guys.
want to
Pull back,
remove
guys.
just only guide.
Yeah. Pull back, guys.
Just only guide gently.
Okay.
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 And we are ready to open.
Up. Okay. Yeah. Okay. Safe, please? Yeah. Okay. So, we need rewiring and check IVUS.
Okay, go ahead, please.
Okay. I want to gently remove about
deformation of stone, in particular the proximal part. Yeah. Whisper, please, yeah. So,
And the good thing of this stand is like step-up balloon system, which gives us like more complexity of multiple hardware usage. It minimizes it, which is good, and also saves time for us.
Okay. Yeah. Okay. Keep the wire. Yeah. Sorry. So, wiring with polymer jacket wire. Yeah.
So you pulled out the circ wire to put it into the left LED.
Sorry, guys.
So instead of pulling out the wire from the circ, it is always safer to take a third wire, wire the LED, and then pull out the LED jailed wire. It is safer that way.
Okay, yeah, polymer wire, but our workhorse is cyan blue, cyan. So, rewiring hydrophilic wire, polymer jackets, maybe little check angio of
Can we see an
LED.
angio at least now? Because you got about 30 seconds left.
Okay. Please stop. Yeah. Thank you. Yeah. Little bit angio. Okay. Yeah. Please. More. Wait. Yeah. Okay. Okay. Yeah.
Can you just show us one cine before we go so that we are out of time actually? One.
Yeah. Okay. Yeah. So, repair I wish click. So, could you please change right cranial protection? Okay.
Dr. Alexi, we are out of time. If you can just show us one shot so that we know where we stand at when we leave you.
Okay. Uh-huh. Yeah. No one. Yeah. We modified the
Yeah,
end
we
of
are
wire.
actually out of time, so we're just signing off from you. If you can just show us one shot so that we can sign off happily.
Oh. Yeah, okay. One shot, please.
Yeah, please.
Yeah. Okay. Yeah.
Great. At least.
Great.
A moment. And show a caudal one view. Just a moment, guys. Yeah.
It looks good. We thought it did not look so good, but looking quite good now.
Yeah.
Thank you.
Okay.
Okay, thank you very much.
Thank
That's
you.
the case.
Perfectly acceptable results and
Yes,
good.
yes.
Now,
Please finish up and let us know what's the final result.
Yeah, thank you.
Yeah. Okay. Looks good.
Topic for this session is bifurcation. The facilitator for this session is Vivek Gupta. And the chairpersons for this session are Debabrata Roy, Satyanarayan Rotre, Dhiman Kahali, Saroj Mandal, Ali Shafiq, Mahendra Prasad Tripathi. And the panelists for this session are S. Rajesh Kumar, M. S. Meenakshi, P. Balaji, R. Sivan, Sachin Rao, S. Barni Vele. We now request Dr. Pratap Chandra Rath to come on stage and deliver their presentation.
Mr. Chairpersons and panelists and friends, I am going to speak on imaging in bifurcation lesion. Seeing is believing. As you know, bifurcation lesions are the most challenging lesions to treat. The target lesion failure is very high. Intravascular imaging improves the outcome of PCI. Intravascular imaging also helps in understanding bifurcation geometry and the side branch complications. So I'm going to first show you two cases where in one case intravascular ultrasound, other case OCT, how we change the decision strategy, ultimately resulting in an excellent outcome. This is the case number one, 75-year-old male, classical angina, treadmill is strongly positive. This is the angio. Basically, critical ostial circumflex stenosis with a mild disease in the ostium of the left main. LAD is absolutely free from disease, RCA is normal. The plan was, seeing the angio, was to stent from left main to circumflex with a provisional stenting for OM. That was the plan. Then we did the intravascular imaging with, this is the result. You can see there is a critical fibrocalcific plaque in the LAD ostium, which was not seen in angio. And left main ostium was 4.48, which is significant. LAD ostium is 2.89, LCX 2.43. After seeing this, our strategy is changed. We decided to go upfront with two-stent strategy using a decay cross technique. We used two stents, LCX 2.75 by 12, LMCA 3.5 by 24, and pot we did it with 4 in 10 NC balloon. This is what we did. First we did put the stent in circumflex, and then we crossed it with 3.12 balloon. First case was with 3.12 millimeter LM to LAD and 2.5 to 12 millimeter OM1. That was the first case. And mid-LAD also there was a lesion, so we covered it. And ultimately, this is the, we did the full decay across all the steps, we did it. And this was the angiographic result in the end, excellent angiographic result. And then we did the intravascular ultrasound, which shows left main ostium is 10.5, LAD ostium is 8.5, excellent result. The second case is a 68-year-old male. He had classical angina, and we did the angiogram, which shows critical block in LAD and diagonal. The plan was to do a decay cross. There's no disease in the left main, nothing, LAD, proximal part of the LAD is clean, LCX was clean. We did the OCT. What OCT showed is a ruptured plaque in the proximal part of the LAD, which you can see here, and this is clearly demonstrated in this fixed OCT pictures, where you can see that eruptic plaque rupture in the proximal part of the LAD, and diameter of the distal reference diameter was 2.75, left main diameter was 4 millimeter. So seeing this, our plan changed. We decided to use a separate stent for the mid-LED lesion, 2.75 by 33, and use a decay cross from left main to LED and diagonal, using 2.533 stent in D1, 3.528 stent in LMCA to LED, and we did the port with 4.8 NC balloon. All this suffice to say that this is the first stent in the distal part of the LED, mid-LED, and then D1 2.533 cross to 3.510 balloon. All the steps were used, decay cross, and in the end, we did the OCT. What OCT shows is a mid part of the LED which is not expanded. So what we did, we dilated it with the NC balloon and also did a LED D1 kissing. Again, we did the pot. That's the end result after OCT. Very post-cross OCT shows excellent outcome and good opening of the diagonal with no strut across the diagonal. We did the angio also, which shows excellent angiographic result. So in these two cases, I showed one with intravascular ultrasound, one with OCT, how imaging changed the strategy, and we ended up getting a very good, excellent result in both the cases. So when you do a bifurcation lesion, key factors in bifurcation lesion is anatomical configuration, plan for a stent strategy. In the end, you assess the result. And for all this, you need the imaging. And in pre-procedural intravascular ultrasound assessment of bifurcation lesion, you precise anatomic lesion is assessed very clearly, length, diameter, characteristic of the lesion, and also mechanism of the side branch occlusion you can see by longitudinal view. You see the in intravascular ultrasound before doing the procedure. You first find out the stent landing zone and reference diameter, morphology of plaque, whether it's calcified or fibrotic, measurement of the length, and detection of angiographic silent disease in case. And in the end, you can find out if there is any dissection or under expansion. These are all post-procedure IVS assessment to assess the optimal expansion, assess the full length coverage, and to diagnose and treat stent edge hanging or dissection. Similarly, in OCT, you look at the morphology of the lesion, characteristic of the lesion, side branch, diameter, whether the side branch affected or not, length of the lesion, and diameter. And post, you also look for basically dissection, apposition, and expansion of the stent. So also you can identify the bifurcation geometry and predict whether the side branch complication can happen or not. This by looking at the carina tip angle. If it is less than 50, branch point carina tip length, if it is less than 1.7, then chance of side branch occlusion is very high. This is also, we can see with the OCT, crossing, mostly you would have to cross distally to the one side branch crossing, which you can see by OCT three-dimensional very clearly. If it is not done, if it is gone by mistake proximally, you can change it also. There is a intravascular ultrasound guide. There is a systemic review of the intravascular ultrasound guided PCI versus angiography PCI, published in the Medicine Journal in 2020 from University of from China, Guangzhou, China. They studied 5 studies were analyzed, 7,830 patients, and the conclusion was IVS guided PCI strategy was associated with more clinical benefit. This is a meta-analysis of almost 7,830 patients. Recently, this October trial was published in NEJM, where 38 centers from European centers participated. More than 1,200 patients were enrolled. 50%, 50% were OCT guided, and 50% were angiography guided. Result was, MACE was significantly lower in patients who underwent PTCA with OCT guided. The conclusion was, in patients with complex bifurcation lesion, optical coherence tomography guided by PCI is associated with better outcome after 2 years than angiography guided PCI. This was a very excellent trial, and the result was strongly in favor of OCT guided PCI. So the key point is intravascular imaging helps in upfront planning of PCI strategy and provide guidance for stent selection and optimization. Lesion morphology, length, diameter, complications, stent underexpansion or stent malapposition can be seen very clearly. OCT guided side branch rewiring can be done perfectly with this OCT, 3D dimensional OCT. Meta-analysis has clearly shown that intravascular ultrasound guided PCI strategy was associated with more clinical benefit compared with angiography guided PCI, and recently published October trial elucidated better outcome with OCT guided than angiography guided PCI in complex coronary bifurcation lesion. However, use of imaging during complex coronary intervention is still class 2A recommendation as per 21 ACC AHA SKY guideline for coronary vasculation. Thank you very much for your attention.
Sir, please have a seat with us in the dais.
Our next speaker is Dr. Kashima from Japan. He is called the Rota Master because he does the maximum number of rotablation in Japan, and also very expert on imaging and a wonderful operator and a good friend of us. Dr. Kashima, welcome please.
Okay, good afternoon, everyone. So I talk about rotabration in calcified bifurcation regions. So as you know, there's some problem with calcified bifurcation region. So of course, bifurcation is still unresolved region and calcified also. So essential problem with calcified region and bifurcation region. So especially, we focus on severe problem is in the occurrence of malignant cardiac shift in calcified bifurcation regions. So please look at the left side one. Okay, so yes, this moving image. So a lot of physicians consider the loss of the side branch. So also D1 and D2. However, if we have making the rotabration with more than 0.55 bar arterial ratio, you don't afraid to lose in the side branch because you can salvage them. So this is the final result. So if you make in the rotabration, volume reduction enough, of course, you can protect in this for side branch. So I always said this, adequate rotabration, volume reduction always prevent the malignant cardiac shift. So if calcium area is 30%, of course, almost always we cannot, no need to protect the side branch, even the calcified bifurcation region. However, if 50% calcified plaque, so of course without volume reduction, without cracking, at that time definitely happen, so side branch occlusion. So we have to make the volume reduction actively, so when we face to more than 50% calcified volume. So second, I share you in difficult stent management on calcified bifurcation region. If you face this trifurcation case, so LAD and circumflex don't have any significant stenosis, but large disc branch has severe stenosis. How do you treat? Stenting for left main to the branch? Nonsense. So I make it rotabration like this. Of course, this case I choose in the 1.75 as the first bus. This BA ratio is 0.151. But I choose 2.25 bar for this situation because I need and the bar arterial ratio 0.65 more. That situation definitely permit and so stentless strategy in calcified region. So of course I choose in the DCB. Then this is the final result. And please look at this IBUS image. Almost disappeared calcified plaque like this. So if we want to make DECB strategy, stentless strategy for calcified bifurcation, of course, you have to set more than 0.65 of bar arterial ratio. So next, this bifurcation case. Also, stent strategy is much difficult to make it. So of course, I make the rotation for both branch. So 1.5 as a first bar size, and 1.75 as in the second bar size. So finally, I can set in the 0.64 bar arterial ratio for both branch. Then I can get good result without any stent. So it's easy to understand for you. So American, European, also my Japanese expert consensus recommend, and so 0.4 to 0.6 more bar arterial ratio to make a good rotabulation. But I don't think so. Of course, I'm one of the member of the Japanese society, but I don't think so. Because you easily understand on this figure, 0.4 bar arterial ratio means only passing the device. Even good bias cannot make good volume reduction. It's insufficient. More than 0.5 shows us and so volume reduction effect like this. If you can set more than 0.6, it's amazing. You can get and so very nice volume reduction effect. At that time, after volume reduction, rotabulation, your enemy is changed to so much weak enemy. So finally, I show the so difficult bar size selection case. So this case is the short circumflex, and then below the 4 branches and so very short part. So like this. So of course, also stent strategy is much difficult. So I make a 1.5 and 1.75 rotabulation. However, proximal circumflex vessel size and so more than 4. So much so insufficient size for my rotabulation. So I use new technique, my original technique, and max rota. Max rota means a multi-axis rotabulation. So I have 10 max rota, but in this case, I choose the speed bias for safe and efficient, and the branch bias for effective rotabulation. So this is the final result. Of course, it looks so good, and you can easily understand like this. And so 1.75 max rota makes more than 2/3 volume reduction effect. It's max rota. So if you cannot choose more than 2 over, larger over like this situation, including and so very risky case, please use max rota technique. It's easy to use, and you can get and so extra large lumen. So finally, I explained the max rota technique. My max rotor technique, including this guiding catheter bias, wire type bias, wire position, branch, bar size, speed, platform, manipulation, motion, respiration bias. I always use and intentionally, so these biases combine some similar biases to further enhance safety, efficiency, and effectiveness of my rotor ablation. So in this case, I use the branch bias. So when the wire is positioned in different branches and rotation is repeated, each wire bias will be significantly different and the rotation effect will increase. Of course, first findings, both wire always describe same bias because still stenosis is severe. However, first rotor ablation on the one branch, after that, space here, then much different wire bias was described to insert in another branch. So I repeated and change, exchange, then I can get in so much acute gain. So another technique in this case, speed bias. Please look at this moving image. Now 190,000. Bar and shaft are stable. However, less than now 160,000 looks orbital movement. So I don't need orbital atherectomy. Okay, one more. 190,000 bar and shaft stable. So if you want to make a safety rotor ablation, please higher setting. And now 160 orbital movement happen. So you can get extra acute gain. But really bit risky because less than 140,000 rotational speed makes bumping. So I don't recommend setting to the less than 140,000. But the speed bias is very easy to make your rotor ablation because only change only order than your stuff. Please set 180. Please set 140. It's easy. You can get in the safety rotor ablation or effective rotor ablation. So this is in the summary slide. So both calcified and the bifurcation, sorry, I'm not so good but condition. Both calcified and bifurcation regions are among the unresolved regions. And the p-share of calcified bifurcation regions that have both characteristics is not easy. The most common and the biggest problem with calcified bifurcation regions is probably malignant calcium shift due to hard calcification. Although a high BA ratio, bar arterial ratio, is effective in volume reduction, it must always be trade-off against safety in bifurcation regions, which are characterized by larger difference in proximal and distal vessel diameters. So it is difficult to trade off effectiveness and safety in a simple BA ratio setting. And aggressive use of new technique, such as my original max rotor, is considered an effective strategy. Thank you. Thank you for your attention.
Thank you, Professor Kashima. Please join with us. Yeah, I will request our next speaker, Professor Manuel Pan from Spain. He will be speaking on assessing the side branch in bifurcation lesion. Dr. Pan, please.
Thank you. My conflict of interest, and I am afraid that my lecture overlap with the two next presentations. So I will provide a general overview of the side branch relevance and the side branch assessment. A bifurcation lesion is defined as a coronary stenosis adjacent and or involving an adequate side branch, adequate sized side branch. So it's important to define what is a relevant side branch. And according with the EBC, a side branch should be defined as relevant if the reference vessel diameter is bigger or equal to 2 millimeters and symptoms are stemming from a large amount, more than 10% of ischemic side branch related myocardium impacting the prognosis. To assess the relevance of the side branch, a recent bifurcation consensus joined to the Academic Research Consortium published a paper that defined the relevance of the side branch in this slide. You can see different algorithms you can use for defining relevance: angiography, IBUS, OCT, CT, or even myocardial stress test. So sometimes it's very complicated to assess the relevance of the side branch, and I like to go to the simple rules. So if the left main, if the side branch is the circumflex, it is relevant. If the side branch has more than 73 millimeters in length, it's relevant. And if the side branch is a diagonal branch, it's the first one, or with 2.5 millimeter or bigger of diameter, it is relevant. So you can assess the relevance with simple rules. And this is the most simplification of the relevance definition of the side branch by Thierry Lefebvre. For the EBC, for many operators, consider that a relevant side branch is a vessel more than 2 millimeters that they are unwilling to lose in the context of a specific patient anatomy. That's important limitation, and for this reason, dedicated QCA has been used in assessing the importance of the side branch. Only a comment: when you use a QCA system to assess the side branch, it's recommended a dedicated QCA in order to avoid the problem of the phenomenon of the stem down phenomenon that occur normally in bifurcation lesions. With the conventional system, you commit some mistake, some error, so dedicated QCA incorporating bifurcation algorithm is recommended. And finally, for the importance for the angiography is the lesion of the side branch. 10 millimeter, I think, is a good limit in taking decision. And Medina classification is very flexible and modified for many investigators according with the IBUS, according with the QCA, according with everything. So we add a final letter of long side branch lesion or short side branch lesion according with 10 millimeter. This is based in meta-analysis and in many recent studies that demonstrate that complex techniques are better in patients with long lesions at the side branch. You can use the definition criteria, but it's complicated and difficult to memorize, and this is a simple rule that seems to be applied in order to take a therapeutic decision. Second, the physiological assessment. Physiological assessment is important. You can see a classical slide that demonstrates that when the operator thinks that the lesion is severe by angiography, the physiology demonstrates that the lesion is mild. This is all the point in the red circle, in which the severity of the side branch lesion change according with the physiology. On the right, you have an example. Everybody knows this limitation of the angiography. And when these concepts are taken into consideration, these 5 studies using physiology in guiding the side branch intervention demonstrate a reduction in the intervention at the level of the side branch, with a neutral result in terms of MACE and follow-up. The non-hyperemic index has advantage over the classical FFR, because when you assess a bifurcation lesion by physiology, put the wire distally, and the measurement take into consideration 2 segments, the proximal and the distal, if you are in the main vessel, or the proximal and the side branch when you are logically at the side branch. So this is a beautiful example of a bifurcation lesion by angiography. It's a 111 from Medina. But when you apply physiology, it's interesting. You have to pull back. The first one is from the PLA and demonstrate the concentration of the red point only in the proximal part. So the ostium of the PLA is free of disease according with this technology. On the contrary, when you perform the same pullback from the PDA, an additional concentration of point occur at the origin of the PDA. So this vessel have disease, and according with this finding, we change the classification of Medina from angio to physiology. For angio is 111, and for physiology 101. This also changed our strategy, and one stent across the PDA plus POT resolve easily the bifurcation. The pressure gel wire technique is interesting in order to monitorize what happened during all the procedure. This was an old idea proposed by Alfonso Medina more than 20 years ago, was presented in a European meeting. Nobody cared about this concept, but 20 years later, we resuscitated this idea using the new non-hyperemic index, and observational study was published in JAC, and more recently, a comparative study with a control group was published in Revista Española of Cardiology, and the results are summarized here. The use of the gelled pressure wire reduced side branch intervention. The microscopic damage is higher, but curiously, the damage is not in the sensor of the pressure. And regarding the MACE, there is a tendency to a reduction of MACE in patients in which the gelled pressure wire technique was used. Regarding image, we have a next presentation, and this is only a summary that we can obtain in the side branch. We assess the plaque distribution according with the Oviedo classification. Is a modification of Medina according with the distribution of the plaque by IBUS, and also we obtain information about the plaque composition. You can see that the calcium is distributed differently in different lesions. That in a normal lesion, you can obtain deep calcium, superficial calcium, concentric, eccentric, or nodulus. Each type this calcification need a plaque modification according with the morphology. And the image is also useful after the treatment to assess the result. With no stent at the side branch, it's important the evaluation of the dissection of the minimal lumen area. This case is a case with a small dissection at LAD. The main vessel is the circumflex, treated by simple approach with DCB. And this is my final slide with an example of a two-stent technique, a DK culotte. We perform pullback, OCT pullback from the LAD and from the diagonal branch. You can see non-apposition of the proximal part that was corrected, and the diagonal showed an excellent result con good expansion, MLA, non-malapposition, non-tissue protrusion. Thank you for your attention.
Thank you, Professor Manuel. Please join with us. I will request.
Next, we welcome Dr. Gary Mintz to give his lecture on IVUS in LMCA bifurcation PCA.
Dr. Florim is there? Yeah, you can start. After that, we'll do Dr. Florim Kokoli better. Yeah.
Thank you very much. I'm going to talk about IVUS in left main bifurcations. So when you do IVUS-guided left main bifurcation, PCI, you should do IVUS from the LAD and the circumflex back to the left main with at least one pullback to the aorta to determine left main disease severity, disease at the LAD and circumflex ostia, left main plaque composition, disease at the left main ostium, identify proximal distal landing zones, and measure vessel diameters. In 25% of the patients, the MLA differs by 1 square millimeter when imaged during a pullback from the LAD or versus a pullback from the circumflex, and you always take the smallest lumen area, which is the most accurate. Plaque distribution from the left main to the LAD and the circumflex cannot be predicted by tangential imaging or by the Medina classification. This is a clinical example. By Medina, it looks like 110. You can see, first of all, when you look at the left main, from the pullback from the LAD, the MLA is smaller than the pullback from the circumflex. The circumflex doesn't look so bad, but when you image it directly, the lumen area is small and the plaque burden is large. This was suggested in the last talk. This is the Oviedo classification, and it says that in 60% of left mains, the plaque starts in the left main and involves both the LAD and the circumflex. About 25% is more variable, but you can almost always assume that there's some involvement of both the LAD and the circumflex. Now, how do we assess left main severity? People can do FFR, but we use IVUS, the minimal lumen area of at least 6 square millimeters, and this meta-analysis compared IVUS and FFR, showing identical outcomes out to 2.5 years. And what we are concerned with is not the plaque burden, but the lumen area itself. In terms of stent sizing, we pull back from the LAD to the left main. We identify distal and proximal landing zones to determine the stent length. We size the stent to the LAD, and we post-dilate it and do POT to the left, based on the left main size. To decide whether or not to use 2 stents, we look at IVUS of the circumflex, and we look for a lumen area less than 4 and a plaque burden more than 50%, because those tend to predict that the FFR after single stent crossover will be reduced. We also have data to suggest that a calcified nodule at the distal left main bifurcation is at high risk for jailing of the circumflex. We saw that in some fellows' cases yesterday afternoon, and it turns out that the distal left main bifurcation is the second most common site of a calcified nodule. You see this filling defect in the distal left main, and you see a calcified nodule involving the LAD, the left main, and the circumflex. Once you decide you have to do 2 stents, we also look at the circumflex, identify the distal landing zone, measure the length of the stent, and we size the stent again to the distal landing zone, and when necessary, we post-dilate proximally. Other than selecting a 1 stent versus a 2 stent strategy, IVUS is agnostic as to the specific 2 stent strategy. You should do what you are most comfortable with. And then post-intervention, we also do IVUS from the LAD and ideally from the circumflex to assess and correct stent under expansion, deformation, geographic miss, and complications, and proximal edge malapposition. And then we fix them, repeat imaging as necessary until we get a great result. What are the criteria for stent expansion? This is Kong's original study, now 13 years old, and she suggested that you need a stent in the ostium in the circumflex of 5, ostium LAD of 6, and the left main of 8. But since then, we have data from Excel that use not angiographic follow-up at 9 months, but clinical follow-up 3 years, with cutoffs in the left main of 9, LAD of 7, and circumflex of 5. And then most recently, updated data from Asan Medical Center, almost 300 patients treated with 2 stents and 5-year clinical follow-up. The cutoff in the left main was 12, LAD of 8, and the circumflex of 6. And it's really only the stent sizing or stent area in the LAD and circumflex that determine outcomes. Because these were all IVUS guided, the left main stent sizing was not terribly predicted. And you can see here that when you have both a LAD stent less than 8 and a circumflex stent less than 6, the event rate is very high compared to when one or the other is, or only one or the other is underexpanded. And now we have data of single stent crossover showing almost the same thing. It's important to understand the differences between the Kong study, Excel, and the recent data from Asan Medical Center. One of these has to do with Asian patients. In general, Asian patients, and we have data on normal Koreans compared to normal Western patients, have a proximal vessel size 3/4 compared to Western patients. The Kong study had 8.5-month angiographic follow-up, which doesn't quite frankly predict very long-term data. Now we have their updated data with 5-year clinical follow-up, and of course you want to predict late events, not just angiographic events in the first year. DK Crush seems to be taking a stand very similar to the recent, or DK Crush 8 is taking a stance very similar to what we see in the most recent Asan Medical Center data. We also have to look for stent deformation. Stent deformation never happened in the bare metal stent and first generation DS days, and maybe it won't happen with the new Megatron stents. But in the second generation DES and the new generation DES, it happens not infrequently. And here you see an IVUS pullback initially, and it looked like there was underexpansion, so they did kissing balloon inflations and compared this cross-section to this cross section, notice the 2 layers of stent struts. Yes, it is subtle, but this is a huge change. And this means that the stent has accordioned and deformed. Once you get stent deformation, this was seen in Excel, was also seen in October, the event rate goes very high and it must be fixed. You also have to look at proximal edge malapposition. Malapposition in the bodies of the stent has almost no impact as long as the stent is well expanded. But if you have malapposition at the proximal edge, seen here on longitudinal and cross-sectional anatomy, it's easy to get a wire behind it and therefore crush the stent. You also don't want to leave this behind for your colleague who may have to come and treat the patient in the future. This is a quick clinical example, Medina classification 111, but the IVUS image of the circumflex, the lumen area is 10 and the plaque burden is only 37%. So the patient was treated with single stent crossover. Actually looks a little bit better. You see that the ostium, the circumflex, is now somewhat deformed, but the FFR is 0.91. And the question is always, why do you rarely see a reduction in FFR after single stent crossover when treating distal left main lesions? A lot of these are angiographic artifacts. The circumflex stenoses are usually not significant even pre-intervention. The deformation is usually eccentric with carina rather than plaque shift, and you can see carina shift here. And the changes are very focal, and the vessel size is large, and the amount of myocardium is modest. This is a large study from China looking at IVUS imaging after single stent crossover to predict an FFR less than 0.8, and again a lumen area less than 4, and a plaque burden more than 50% should make you cautious. And if you have to treat this, the patients do as well as if it never happened to begin with. In terms of IVUS data, there's really only one study that looked at distal left main bifurcation lesions specifically. It is a Spanish registry from 4 studies published by De La Torre Hernandez in JACC in 2014. And you can see for distal lesions, comparing IVUS to no IVUS, a reduction in death MI and TLR, and particularly when you're using 2 stents, a marked difference in death MI and TLR comparing the IVUS group to the angiographic group. And a predictor of events is again independent, is IVUS. October showed that OCT was better than angiography, except in the left main. The left main was no different. The reason is October allowed IVUS in the angiographic arm, and half the patients in the angiographic arm had IVUS guidance. So to conclude, IVUS is critical to every stage of left main bifurcation PCI. The decision to treat, the PCI strategy, PCI optimization. IVUS-guided left main stent optimization improves patient outcomes, including mortality when treating a distal left main bifurcation. The data in OCT is less convincing and quite frankly just simply confusing, in part because October allowed IVUS in the angiographic arm. Thank you for your attention.
Thank you, Professor Means. Please join us. Professor Kokuli is there, Florim Kokuli? Probably it's not there because so I think we'll have some discussion from our chairpersons. Then we can have. I will request Professor Kali.
Dr. Kashima, You have shown the Rotamax. This is something new to us. Can you elucidate a little? The Rotamax, you have done an approach of heavily calcified lesions, especially in bifurcation situation, because you know the main problem is the carina shift. In heavily calcified lesion, there is a lot of carina shift if you treat the lesions. So, what do you suggest about this Rotamax approach?
Max Rota, yes. Of course, and so Max Rota is so a little bit difficult to choose, and so any biases. So of course, some cases required and speed bias, some cases is a respiration bias. So of course, and so we have to run so some a little bit. Yes, but in the so concept is so much easier. Yes, so speed bias. So for example, speed bias only changing the setting. So respiration bias is more easy. So deep breath, please, or please and the inhalation, exhalation. So it's easy. But then the exchange to the bias is so much a lot. So we can get in so much good effect. So especially the so calcified bifurcation, and I recommend in the so max of the technique.
How do you choose the stent-free strategy? You know, is it the high-vis guided or what? Because you showed a couple of cases. Do you have follow-up of those cases, or any studies are undergoing with respect to stent-free strategy after rotablation?
Yes, of course, and so always and so result of the lesion preparation is and so everything. So of course, and I sometimes and so avoid and so stent-free strategy if I want to set it. So. But then, so anyway, if we cannot so avoid in the rotabulation, volume reduction, we don't have to choose in the stent rest strategy in every case.
Dr. Pan, you were a master in bifurcation lesion preparation, and thank you for making it this year also. You are a great friend of India. So, what is your message in short that when to intervene in the side branch lesion, especially it's a ostium circumflex? Because frequently we find that European Bifurcation Society tells that always we don't have to do the kissing lesion. You have shown some slides in your lecture also. So precisely, what is your message to the youngsters over here?
Regarding the opening the cells in the side branch, or regarding the second stent implanted at the side branch? Regarding the systematic opening the cells in front of the side branch, I think we have not the definitive answer, although many operators in the EBC recommend the systematic opening because of the late OCT findings that demonstrate some breach in the strut in front of the side branch. But I think there is not a definitive consensus in this field. And regarding the use of a systematic two-stent technique, we have recently the long-term follow-up of the EBC main study that also has similar result with the meta-analysis that suggests that the patient with long lesion at the side branch has poor result with provisional strategy that with decay crash. So we incorporate this concept to the Medina classification in order to simplify, in order to advise the upfront two-stent strategy.
It has gone up around 60 to 70% total. I use imaging, intravascular or OCT, because many times I reuse the intravascular imaging.
I think
OCT also 2 to 3 times I reuse.
Thank you. So I think NIC will show light how many percent of the patients we are using imaging in.
I was
in a study or in our practice we are using, but what is the real world scenario?
Real world, I use 70% again OCT, left main and other places I use to intravascular ultrasound. I think my use of intravascular ultrasound is slowly growing off. The reason is, number one practical reason is, it can be reused. That's the main thing why it is going up. But of course, left main, this is a great thing, but all others, OCT is
We
superior.
all agree to optimize the result, we need help of imaging, but there are many centers there without imaging also doing left.
You have got some question, please.
I'm sorry,
it again.
I can't hear anything.
My question is regarding the IVUS in LM bifurcation. We are planning a provisional strategy and we have extended from left main to LAD. So after that, LCX's ostium is compromised and we are planning a TAP strategy. And the stent is slightly protruded. After stenting, we know that slightly protruded into the LAD. So is there any IVUS cutoff to say that whether it need a crushing or we can leave it alone?
Sorry, it's not clear. I don't understand what he's asking. I'm sorry, it's not, you're just not, I mean, we just can't hear you clearly, and I don't know why. I'm sorry.
Okay.
I'll be happy to answer the question afterwards.
Sure.
But I can't understand what you're asking.
Sir, can I have one question more? As you told, कि mal-appositional stent is not going to change your strategy. But when the ostium of the, when there is in exactly ostium of the RC or SORC and LED, then you need to do. Then how do you tackle, sir? How did the 400 millimicron or whatever, sir?
Again, I'm not sure the question, but I think you're asking about malapposition at the proximal edge of the stent. Anytime you have a stent with proximal edge malapposition, you should minimize it unless you know the patient will never come back. Patient is 90 years old or something. Because when recrossing, it's easy to get the wire behind. So how do you fix it? You measure the intimal distance and you put in a balloon sized to the intimal distance at nominal pressure. There's nothing behind it, so you don't need high pressure. You just need a big balloon to gently press it against the vessel wall. It's really simple.
So thank you all the foreign faculty speakers, Dr. Roth, and all the chairpersons and facilitator. It was a wonderful session, and I thank the audience for active interaction also. Thank you very, very much, ladies and gentlemen. So we conclude the session. Thanks a lot.
Good afternoon, everyone. I invite you to the next session, which is on future of precision imaging. IVUS nurse. Can I call upon the chairpersons, Dr. Raj Tabe, Ajit Mullasari, Professor Surya Prakash Rao, Harish Mehta, if he's around, Dr. Sridhar Kasturi, I can see him here. And the panelists, Dr. Mohanty, Smith Srivastav, and Shrikant Shetty. Can we have you all on the dais, please? All right, I'll set the ball rolling by inviting Dr. Gopala if he's here. All right, he's going to talk on high definition IVUS nurse, a new horizon to IVUS guided PCI.
Okay, good afternoon, everyone, and thanks for the NIC Scientific Committee for giving the opportunity, and respects to the chair and moderators. So my task today is to give you a quick overview of this new modality called NIRS, N-I-R-S. What does it mean? How has it changed? I had no clue about it until a few months ago, and I'm learning, and I'll just show you what I've learned and where I use it, and then there are going to be a lot of cases. Yeah, I can hear it. The hall, it's very well audible on the hall, right? Looks okay. It's not audible? Am I audible? Okay, so I will just show you some understandings of NIRS and then we can talk. There are a lot of cases after this, so I won't show any cases. What is the actual problem? The problem, pathophysiologically, we know lipid plaques rupture. These lipid plaques have been seen with some imaging modalities, but we don't have a validated modality that on imaging can tell us this is a rupturable plaque, this is not. That doesn't exist to date. When we get a heart attack, we can treat, but can we actually prevent a future MACE? How do you do that? The cath lab can show a picture like on the far left-hand side, but what it doesn't show you is a cross-section of this, a histological section of what you want to see. This is just to give you an example. This is an FFR negative proximal right coronary artery lesion, and that had a NIRS assessment, and it showed a lipid plaque. Even though the FFR was negative, the patient had an event at 7 months. You can see that. So it just goes to show FFR is going to give us functional information. IVUS will, of course, give you anatomical information from where we have derived some future functional event, but then NIRS is going to tell you these rupturable plaques, which we have not had in the past. As a result, the technology and company claim to be the only device proven to predict, because that is the only validated device currently that we have of all the imaging modalities. We'll talk a little bit about technologies. What is the advantage of having two separate coronary info in one pullback? This is the machine. Some of them have already used it. There's been a small limited release. I think there's going to be a bigger release in due course. So what this machine provides is IVUS information, intravascular imaging, high definition, all the way up to 65 megahertz. And in addition to IVUS, we're going to have NIRS. And NIRS stands for near infrared spectroscopy. It uses infrared, pretty much similar to OCT in terms of penetrating capability. This is the catheter, similar to any IVUS or OCT catheter. Usable length is 160. The imaging range is 15 centimeters. One of the nice features of this is it has an AI built in even for IVUS. It throws out low frequency and high frequency and combines them both. Therefore, there is a good chance you're going to have near field and good far field in the same image. So as a result, the quality of the image is very good because it's a combination of low frequency IVUS and also high frequency image at the same time. This is a comparison between NIRS and the other imaging modalities. You can see here angiography on the left hand, IVUS, OCT, FFR, and NIRS. And what NIRS gives is event risk assessment, which cannot be currently provided by any of the existing modalities, although we see they've not been validated. That's the only extra information we're going to get from NIRS. Plaque characterization with near-infrared spectroscopy is the actual mechanism that NIRS uses. This is just a little bit of the mechanism, how it works, but I will just summarize this later. Before that, I just wanted to compare, because most of us are all very familiar with IVUS and OCT, and I just wanted to give this comparison, why this dual info catheter for coronaries might add some benefit over the existing. So you can see here, all the dark spots are validated info. All the hollow spots are non-validated. So if you see IVUS, it gets good validated information on the expansive remodeling capability of a vessel. It gives us good plaque information and calcium information, but it does not give us lipid core. But NIRS gives us lipid core, and therefore, if you combine NIRS and IVUS, which I've listed down on the far right-hand side, you get the most of what you can possibly get from any single imaging modality to date. What NIRS provides is a chemogram. I thought I'll just spell out what a chemogram means. A chemogram just gives a color generated from AI. And what the color means is all yellow spots are lipid-rich, all the red is not lipid-rich. So therefore, the vulnerable plaque is yellow. How does it do that? So for every millimeter, it just throws out, the catheter throws out 1,300 NIRS rays, receives them, and then analysis of the acquired data, gives an AI color for each data, and that's how it generates the chemogram. So it's not going to give you a number which you got to memorize. You just have to look at the color, and the color tells you whether it's vulnerable plaque or not. This is some validation studies. I won't go into that, but more importantly is the interpretation of the chemogram, which is more important. You can look into the studies later. This is the chemogram that is generated. I will show you the actual practical image that is displayed. The color is red. Red means it's all non-vulnerable, and yellow is vulnerable. And there is a gray zone between red and yellow. You can see here as the red becomes yellow, because it's a very accurate AI algorithm. So even a little bit of NIRS pickup will be color coded. So absolute yellow is fully lipid rich. Absolute red is non-lipid rich. In between there is a gray zone, but that's also validated. I will show you this. This is what the colors actually mean. So if you have yellow, it's 95% probability this is completely lipid rich, and you can be sure about it. If you have red, 0% lipid rich, you can be pretty much sure about that. And in between, it's not too bad, you know. So therefore, anything that's not bright red, you can assume that you have lipid rich plaques there. So that'll be the inference from this chemogram. So it's a very clever, not a huge gray zone that you're going to be scratching your heads. You can make a decision. This is the block chemogram, where you don't just get a patch, you get a block also, as though you get the block visible simultaneously as the longitudinal view of the IVUS catheter. So a lot of, because running out of time, I'm trying to push off unnecessary slides. So this is the display that you get. So on the bottom, you can see here, that's the IVUS L view. And at every IVUS L view, if you drag your cursor, you get a block chemogram on the top that tells you where the cursor is, how much lipid plaque you have. So let's say you have lipid plaque where you want to park your stent, your inflow or outflow is going to be there, and you see on the top it's all yellow. you really don't want to leave your inflow or outflow there. You want to either extend it to the red zone or do something else. This is the lipid core burden index. This is LCBI. Of all the terms we have to memorize, this is another term you have to memorize. It's called LCBI, which stands for lipid core burden index, but best to keep it yellow and red, which is easy because that gives us all practical information. I'll give you an example. This is an IVUS interpretation. This is something we're all familiar with. It shows calcium, and beyond the calcium, you don't see anything because ultrasound does not penetrate calcium. You have an MLA 5.1, beautiful. You can land a stent here. However, if you have nurse information, this is the nurse information. So where you have calcium, you can see the circle. Wherever you have the calcium, it's all yellow. So this is a region where you have calcium. Although the image is shielded beyond the calcium, the nurse can penetrate the calcium and give you information as to whether you have lipid-rich plaques below the calcium from a luminal standpoint. So this is important information which we never had before. And how does it penetrate calcium? Because it's the same. It's infrared, same as OCT. It will penetrate calcium. So you're getting imaging, calcium information, and whether you have lipid-rich plaques further beyond the calcium or not. This is something very important. So if I have this information now, which I have in my lab, now I will not end my stent here. I would extend it. So I don't want to take any risk, because if I break the calcium layer in the endothelial surface, the lipid-rich plaque can be exposed. I don't want to do that. So thereby, there is a chance I can minimize my TLRs. So differentiating layers, it's all from the IVUS functionality. This is an example. This is a typical image that you get. So a good high definition IVUS is here. Majority of the vessels that we do we all want to do near normal to near normal. Normal to normal, we rarely get it. It's near normal to near normal. But then you want to know whether the near normal is lipid rich or not. So this is a good near normal stable plaque where you can happily land your stent, because you do not have any lipid-rich plaques here, because the circle all around in that millimeter is completely red. You can be 100% sure you don't have lipid-rich plaques here. Far field penetration, as I told you, even if you have calcium, you will have far field penetration. This is a bifurcation, and you can see here where the calcium, there's a little bit of speck of lipid. You can see here a little bit of yellow on the outer red margin. Everything else is red. Even if you have a bifurcation, it will pick up, and it'll give you where there is a lipid-rich plaque. This is an example I already showed you. A lot of lipid-rich plaque beyond the calcium, which is shielded by IVUS, and therefore this is a region where you would have landed a stent had we not had NERS. But now we have NERS, we probably wouldn't land it there. Another implication, of course, you can see here, there's just various imaging examples I have just thrown to give you an idea. You get simultaneous IVUS and also there's NERS information. And this is an example. You can see here, this is a plaque rupture. You can see the lipid-rich plaques on from about 7 o'clock all the way to 9 o'clock. You can see at 12 o'clock, there's a ruptured plaque, which just demonstrates the high definition IVUS capability and also the NERS capability. So these are all things I've been learning, because initially I did not know how am I going to actually implement in my clinical practice. We've always gone with MLAs. If you've got an MLA which is Y, big, you're not going to be treating it. And if you have an FFR which is negative, you're not going to be treating it. But now this extra information might give some added value, which I'm learning, and I'm going to show a few more slides. This is a stented segment. You can see here, you can look at apposition, that's all very clear. And although the NERS will not penetrate metal, it will go through in between the struts wherever it can penetrate. And if you have missed any lipid-rich plaques, it also shows it as a yellow signal.
If you can wind up your shooting times.
See that, apologies. So I will wind, I think evidence-wise, I will let you look it up. So these are my conclusions. I'll let the cases flow through. We've been imaging with OCT and IVUS. I think NERS allows prediction of future events by showing lipid-rich plaques. Combining imaging and NIRS gives the best of both worlds. And the practical implication, I told you, the landing zone, you can be sure whether your landing zone is safe towards preventing TLR. And assessing coronaries with NIRS might also help identify those patients where you really want to give PCSK9 inhibitors, because PCSK9 inhibitors are going to work best in lipid-rich plaque, not on calcified segments. So if you can identify, it might be a cost-effective way to give those patients PCSK9 inhibitors, and NIRS penetrates calcium. Thank you.
Thank you, Gopal. We'll keep the discussions at the end of
Sure.
all the talks to save some time. Can I call Dr. Mahesh? A little change in the order. He has some other commitment. So Deepak can come after him.
Thank you, the organizers, chairperson. The difficult part of the nurse IVS has been covered by Dr. Gopal Murugan. So what leaves me is just the practical aspect. So I'd like to show you one left main bifurcation with a suspect lesion in the circumflex ostium and a clear lesion in the circumflex ostium and suspect lesion in the LMCA. So what we did was we first wired both the LAD and the circumflex. Once that was done, we did the IVS nurse. This is the IVS nurse catheter, which has gone into the LAD, and the pullbacks get started. After that, what I did was I just pulled out the wire from the LAD, and with the whole system, pushed it into the circumflex and did the pullback from the circumflex. Not recommended. So this is the IVS nurse. As the previous speaker was saying, can you see this red area circle? That shows that behind whatever calcium we have seen, there is no lipid, and it is absolutely fibrotic plaque. So that's a good thing to know, because here you can see on the circumflex, you can see a little bit of lipids coming up. As we come closer to the left main and the bifurcation of the left main, there is a little bit of lipids. Otherwise, it's predominantly a fibrous plaque. Again, from this LAD, when we come into the left main, the distal left main and the ostial LAD has got lipids. And the red area shows it is fibrous. You can see as we come into the left main, there is tremendous amount of lipid as compared to the rest of the vessel. So this simultaneously gives me the information as to what sort of lesion I'm dealing with, whether I'm dealing with a lipid predominant lesion or just a calcified lesion with no lipid behind. So this is the left main. Can you see? It's about, the arc is about 270 and it's got lipids. This is fibrous plaque. As we go deeper into the circ, the lipid is there, and the circ has got a lipid predominant behind the calcium, which is very dominantly seen. LCBI max was 899, which is significant. In the LAD at the same time, only the proximal LAD, the distal left main, had significant amount of lipid. There is a second lesion that is distal to the primary lesion that has also got significant amount of lipids. So this tells me how to modify the lesion. So I'm dealing with as we go distal from the left main bifurcation, I'm dealing with predominantly a non-lipid lesion, a fibrous plaque, but proximal region has got lipids. So I need to cover the left main, the bifurcation, and the circumflex ostium. So this is the distal LAD lesion was stented. After that was done, the circumflex was rewired, dilated the circumflex, stented the left main to circumflex with the branch stent. Then the LAD was recrossed using, after having wired separately. Then two balloon was pushed into the LAD through the struts of the bifurcation stent. That was dilated. Then LM to LAD was also done. Similarly, the final angiographic results. Dilated the circumflex ostium, did a kissing, did a pot, and came out. And this is the nurse I was pulled back from the LAD after we had done the stent. You can see that absolutely, you can, the plus points of the IVUS pictures are extremely clear and very focused. You can see that the stent has been well apposed. You can see the dimensions. What is more important is this picture on the right. Can you see? Absolutely, only one small speck of fiber of lipid left behind. We have dilated adequately and probably got rid of we have covered the area that is predominantly lipid. So just a distal part across here, there is a little bit of lipid in the LAD. That is the second lesion in the LAD. So this is the information that we get after the thing is over, and these are the final angio results. So this is a new modality which tells you, in addition to what Dr. Gopalamurugan said, it also tells you what should be your strategy for managing your calcified lesions. Because you can't see with NIVUS what is behind the calcium. If it is fibrous plaque, your approach is different. If it is lipid, your approach has to be different. Otherwise, you're going to deal with restenosis. Thank you.
Any comments from?
Since you finished in time.
So one comment that I will have is the practical utilization of the NIRS technology. So the advantage of this technology is that the NIRS is already mounted on an IVUS catheter. So it's a free map. You know, the cost is the same. And it's a high definition IVUS with a 22 micron penetration. So it's a really good quality IVUS catheter. And then you get NIRS map with it. So it's extremely helpful in terms of the landing zone for the stents. You know, so if you have a very high plaque burden and your chemogram shows that your LC max is way over 400, so then it can guide you in terms of where you might want to land your stent. Because if you land edge of the stent straight into the big yellow pool of lipid plaque core, then the potential for restenosis in that area or a future ACS event is going to be higher. So that's the advantage.
Yeah. In some of the views, actually behind that calcium, it is showing yellow mark.
Yeah.
Is it because the lipid behind?
Yeah. Yellow is lipid. Yellow is
when-
lipid.
Yeah.
Red is fibrous plaque.
Yeah, that's what.
And then you have a variation of yellow to orange to red.
Yeah.
That
Our
shows
interpretation in IVUS usually will treat it like a calcium, but it is showing
behind
the calcium, there is
what's
a lipid.
happening.
That's the advantage.
That is the
actually.
biggest. That is
So
the
that's the indication. That's it.
nail on
That-
the head.
That's really
Yeah,
very good advantage with that one.
Behind the metal or calcium is definitely advantageous. One question actually, if you're doing IVUS, you see some attenuated plaque. We have defined lipid by IVUS already. In SD IVUS, you see a lot of attenuated plaque. When you don't see any calcium or metal and there is attenuation of ultrasound beam, you say there is a large lipid core. Unless until you take this LCBI cutoff, what is the advantage you think this nurse catheter has over IVUS?
IVUS has got absolutely no role in lipid. So whatever lipid you pick up in this combination is all courtesy in NIRS, and your strategy depends on how much of lipid you pick up in the in your pullback.
One doubt actually in choosing the landing zones. Clearly, it may show the yellow block.
Yeah.
But will it show like any 50% block burden more than that? Whether
So
lipid rich.
It's valued. The values can be the
Values.
LCBI values can be lipid.
What is the cutoff point to?
400s is being cut
400,
off with.
400. Because in IVUS and OCT, we say 50% block burden.
Yeah.
It should be avoided.
So I'm-
Here for.
I'm so looking forward to an OCT with NIRS. I think that will be the final game changer in the whole issues. Thank you. Thank you,
Call upon
Deepak.
Dr. Deepak.
Yeah, little biased towards OCT maybe.
Well, good afternoon to all of you. Thanking NIC as well as Viva for the opportunity given. Well, over the next 10 minutes, I shall share with you few of our interesting cases which was helpful in decision making during our interventions. Well, the first case Um, uh, regarding the usefulness of IVUS nurse in routine practice, it helps to identify the procedure risk involved during an intervention. Well, this is the first case, 83-year-old gentleman who presented with an acute coronary syndrome, a proximal LED, very critical stenosis. We did a nurse evaluation, IVUS nurse evaluation of this particular lesion, and we made out that in this particular lesion, you can see when you look at the IVUS, it's more of an attenuated plaque over here, and when you look at the LCBI, you could see that it's 722. An LCBI max of more than 500 correlates with a slow flow during the procedure. So when you have a huge amount of lipids inside the lesion, you shouldn't be very aggressive at that particular lesion. You shouldn't be post-dilating it with very high pressure balloons. So that makes us understand that you are encountering a difficult lesion. You're likely to have problems during the intervention. So that sort of information was what we achieved in this particular lesion. We dilated it softly and deployed a stent over there. Despite directing and deploying the stent at low pressures at 12 to 14 atmospheres, you could see in the second image that we encountered a slow flow in that particular vessel, LED and diagonal. Also, we encountered slow flow, and following intracoronary vasodilators, we were able to achieve reasonable flow in LED. However, the flow in the diagonal was not all that great, probably because of distal embolization. Well, this was another situation. One could identify high-risk vein graft interventions. We know that all the vein graft interventions are going to be high risk. However, you could classify whether this particular patient is going to have a distal slow flow during the intervention. This is a patient who had a critical stenosis. In the distal vein graft, you could see that in the frozen image, there is a critical discrete lesion in the vein graft. When we evaluated this, we made out that it was a soft plaque. We also made out that there was no significant lipids. You could see in the chemogram that the lipid score was around 101, no significant lipids, which makes us understand that it's not a very high risk lesion. It's unlikely to embolize distally and produce slow flow. So we went ahead with direct stenting. We did not use a distal protection device. Direct stenting was done, and we could achieve good flow inside that vessel. And then following the next pullback made us understand that there was no significant lipid over there, and that was the final result. This is another patient who had a vein graft to the dominant circumflex. You could see that it's totally occluded with a very critical stenosis in the proximal segment. It was a stented segment. Almost 10 years ago, it was probably more of a new atherogenesis. When we did the IVUS evaluation and NIRS evaluation, we made out that there was a huge amount of lipid at that particular area inside the restenotic segment, which was more of restenosis and more of a new atherogenesis over there. We made out that the LCBA max was around 611. So we were sure that we need to protect this vein graft to avoid distal embolization. So we had a distal protection device. We used a laser, we used a cutting balloon, we used a drug-eluting balloon, and then finally we were able to achieve good flow in that particular vessel. So made us understand that one was a high-risk lesion and the other was a low-risk lesion. So in the high-risk lesion, we used laser as well as distal protection device for managing this particular patient. Now, we could also identify low-risk subset of patients with the help of NIRS IVUS. This is a patient who had an inferior myocardial infarction, underwent stenting to the right coronary artery. You could also see that there is a plaque rupture in the left main bifurcation. So we wanted to evaluate that particular area, the left main bifurcation, almost 40 to 50% lesion over there. So we went ahead with NIRS evaluation. You could see in the IVUS image that it's an ulcerated flap over there. It's an ulcerated flap, and you could also see in the second frame that the minimal luminal area is almost 10 millimeters square. So even though you had an ulcerated flap, the minimal luminal area was 10 millimeters square, and we also evaluated the amount of lipid pool over there. It was less than 400. So when you have a lipid pool of less than 400, LCBA max of less than 400, this correlates with less of future events. So we understood that the lumen was good. There was no huge amount of lipid pool. So we decided on intense medical management rather than going ahead with a stent implantation of the left main bifurcation. Again, you could identify the landing zones. Dr. Mahesh has explained in detail regarding that. This is a patient who presented with an acute coronary syndrome. You could see a tight lesion at the LED D1 bifurcation. Distal lesion is a tight lesion. In the proximal vessel, in the proximal LED, you tend to see a hazy looking lesion in the proximal left antidescending artery. So you have a tight lesion distally, and you also have a proximal hazy looking lesion, which doesn't appear to be a significant lesion. So is it important? So we evaluated with IVUS and NIRS. In the first image, you could see that the plaque burden there is almost 70%. It's a huge plaque burden. In the second image, you could see that it's an attenuated plaque in IVUS. And in the third image, you could see that in the proximal LED, the LCBA was 642. It was huge amount of lipid there. So we understood that proximally there was huge amount of lipid with a huge plaque burden and an attenuated plaque. Distally also we made out that there was a significant amount of lipid pool. It was again 536. So we decided that we shouldn't be just stenting the distal lesion alone. We should be extending the length of the stent. So we covered the both the lesions. We deployed a couple of stents and got a good result, and that was the LCBA following the stent implantation. And then there are situations wherein when you do a bifurcation, you could understand which vessel has got a lot of lipids, and you could avoid multiple stents in those particular situations. Let's say this was a patient who presented with an infemoral myocardial infarction, occluded right coronary artery. We opened both the vessels, and then we understood that it was a diffusely diseased RCA. The PLV was diseased, the PDA was diseased, and even the proximal right coronary artery was significantly diseased. So we wanted to avoid multiple stents implanted during the acute myocardial infarction. So we did an IVUS nurse evaluation. You could see in the first image that in the distalmost portion, in the PLV, there was huge amount of lipids, and in the proximal right coronary artery also, the intermediate lesion was having huge amount of lipids. We also had a pullback from the PDA branch. In this particular image, you could see that there is no significant lipids in the PDA branch. So we understood that PLV was containing huge amount of lipids. The proximal right coronary artery was having huge amount of lipids. So we decided that we would go ahead with a single stent. We would go ahead with a single stent strategy at the distal bifurcation, and did not stent we used a drug-eluting balloon to the PDA and settled with that. So at the bifurcation, we just stented with one stent, and that was the final result. Patient is doing well after 3 weeks at this point of time. Now, you could also identify during acute myocardial infarction interventions, you could identify the risk of patients who is likely to develop slow flow, and you could categorize them. That is, one patient might be having huge lipid pool, he is likely to have slow flow during post-dilatation. The other one might be having less of lipid pool, less likely to have slow flow during intervention. So you could risk stratify intervention in acute myocardial infarction. This was a patient who had a infemoral myocardial infarction. You could see in the LCBA, the score is quite high, it's 861. You know that this patient is likely to have slow flow. We did a direct stenting over there. Despite doing a direct stenting, you could see in the second image that there was significant distal embolization, slow flow in this particular patient, settled down with intracoronary vasodilators. And in the second image, this was another patient who presented with an infemoral myocardial infarction. You could see that the lipid pool was significantly less, it's 168. We went ahead with stent implantation, we went ahead with post-dilatation. Despite that, we didn't have slow flow during the intervention. So just to make us understand that when you have a huge lipid pool in acute myocardial infarction, you are likely to have more of slow flow, and the procedure is going to be more difficult. Now, it could also identify, with the help of nurse, you could also identify the results achieved during PCA. You can evaluate the results achieved during PCA, which can lead on to MACE during the long term. This is a patient who had a PDA tight stenosis. We went ahead with stent implantation of PDA. However, following the stent implantation, we missed the ostium. 2-3 millimeters of the ostium was missed. So we were debating whether we should be putting another stent at the ostium of the PDA or not. So we did a nurse evaluation. We made out that at that particular area, at the ostium of the PDA, the lipid pool was 529, the LCBA was 529, so that we decided that we'll go ahead with a second short stent implantation at the ostium so that the future MACE could be significantly reduced. So a second stent was deployed, and then we could achieve good results. Now, one could also identify the unexpected thing during interventions. This is a patient who had an infemoral myocardial infarction, thrombolized. A stent was placed that was a lesion in the circumflex artery, and we did a nurse evaluation. There was no significant amount of lipids there at that particular area. However, following stent implantation, you could see that at the end, in the IVUS image, you could see that beyond the stented segment, there appears to be something yellow over there. When we evaluated that, just beyond the stented segment, there was lipid pool which was not initially present, probably because of the redistribution of the lipids pushed by the balloon and the stent distally. And that's my last case. It also helps us to identify the balloon-based strategy in calcified lesion. When you have a calcified lesion, if you see huge amount of lipids beyond the calcium, then probably you need to think in terms of a softer balloon, a non-compliant balloon rather than a high-pressure balloon, so that the distal embolization also could be significantly reduced. This is a patient who had an effort angina, a tight calcific LAD disease, went ahead with rotablation. It was difficult rotablation, and then the flow was good in LAD, and you could see in the second image that it's a sturdy catheter, just to show you that the catheter moves even in calcified lesions very, very easily. And when we evaluated this particular lesion, you could see in the first image that it's a 360-degree arc of calcification. In the second image, you could see in the chemogram that there is huge amount of lipids over there. That's 746. That's beyond the calcium. Beyond the calcium, there is significant amount of lipids, which makes us understand that you can easily open up the lesion. Secondly, if you're very aggressive, you're likely to encounter slow flow. So we just went ahead with a non-compliant balloon and we opened it up. And then following the non-compliant balloon, repeat evaluation revealed that there was multiple breaks in the calcification. The amount of lipids have significantly reduced, and finally we went ahead with stent implantation, and that was the final result. So dear friends, what I was trying to tell over the last 10 minutes was just to highlight the usefulness of NIRS in identifying a high-risk patient as well as a high-risk plague, so that we can modify our decisions during intervention so that we could have a better acute outcome as well as a long-term good outcome. Thank you so much.
Thank you, Deepak. That was a breathless presentation, as expected. Very good cases. So I call upon Dr. Kapradi, if he's there. So, all right.
Good afternoon, chairpersons and colleagues. And I think after the fantastic lectures of previous thing, what I understand, especially these IVs with needs, this is important to identify not only the fatty-rich plaques, but high-risk patients for the recurrent events. So it has a lot of clinical applications rather than a guidance for the high-risk procedures. So almost this is repeated by means of Dr. Gopal Murugan. I start from the clinical evidence actually. So this is the important, this is a landmark study which has shown that intravascular needs imaging, identifying both high-risk patients as well as non-curve lesions with high risk of future events. And basically this is safe to perform and with a very high resolution. With this, the risk can be differentiated. High risk if it is more than 400, that LCBA index. If it is less than 400, it is a low risk. And this is the example, a case example which was shown a 30 millimeter length of segment which is intermediate, and a new event happened almost at 22 months after post-index procedure. So where the high LCBS index lesions, they are more prone for recurrent events. And this is another prospect to naturalistic study where it was almost 898 patients were studied with non-full limiting lesions with more than 65% plaque burden, with a clinical follow-up of almost 3.7 years median follow-up. So this is the graphical curve which has shown that cutoff point is 324 LCBA index which was taken, and more than 324 LCBA score having a high risk of events in future. So this representative case showing an adverse event attributed to untreated non-culprit lesion, which are showing almost LCB index of 687. And this you can observe the index day 0 and day 1116 days, which becomes almost become tight lesion, which producing the events. And these are the both studies are landmark studies which have a high reproducibility between the LRP and prospect studies for assessing the recurrent events with the needs, but the cutoff points are 324 in prospect and LRP it is more than 400. And Pacman AMI trial is representative in the AAC, which was shown that there is a elirocumab, that circulating PCSK9 inhibitor, added to high intensity statin therapy on coronary atherosclerosis in acute MI. This is a randomized clinical trial in these patients, which was shown almost low rate, statistically significant low rate of ischemia driven angioplasty, almost 82%, which those who received the elerocumab, and because of lowering of LCB index. So in India, there is, as we know, the multiple risk factors, polyvascular disease, that is multi-vessel coronary artery disease, with almost young patients having MIs. So this is a very important complex subset which requires this evaluation. With this background, I want to present a very interesting clinical case with my initial experience. This is a very young patient, 42 years gentleman, presented with a crescendo angina, and had a strong family history of coronary disease. His younger brother underwent bypass surgery at 38 years, and his elder brother underwent angioplasty at 35 years. And this patient is having hypothyroidism and hypertension are also risk factors. And ECG, resting ECG is showing almost normal sinusitum and no STT changes. And here the patient has a troponin I positive, and he had echo showing almost abnormalities of EPS with good LV function, had a single vessel disease, left anti-descending proximal to mid-segment vessel. And his lipid profile is very interesting. This is very interesting actually. Any patient with a strong family history with lipid profile had almost familial heterozygous hyperlipidemia. In terms of LDL is 245 and total cholesterol is 326 with normal triglycerides. And with this background, the left coronary artery is showing almost a mid-segment tight eccentric lesion with a thin rim of calcium. If you can observe the tram track calcium, you can observe carefully. And we dilated with 2 into 15 millimeters balloon at 12 atmospheres. And then because of the visible calcium, we did the shockwave therapy. Almost 6 cycles were given. And then subsequently we did the IVAS. Because of the bend, you can see as like OCT, which is separated the wire and all these at the bend. And you can observe a napkin ring calcium in the proximal, which was cracked. And then we did this LCBA, that needs, which was showing almost to the tune of 841 maximum, almost double the cutoff point of the risk score. So almost this is correlated with circulating LDL and LCBA index. Very, very good correlation with the tissue fat content as well as the circulating LDL cholesterol. And after deployment of drug-eluting stent 2.7 to 28 and deployed across the lesion with a good landing zones, and then subsequently we dilated with a 2.75 and a 3 millimeters balloon at 20 atmospheres. And then we did again after high pressure intravascular ultrasound with needs we did. And there are some studs are malapposed. And then this is the follow-up you can see after stenting with a 2.75 millimeters, 3 millimeter dilatation. The LCBA came down to almost 358, comes into low risk zone. And then subsequently 3 millimeters and 3.5 millimeters part was done, 6 millimeter, 3.5 to 6 mm part was done at proximal portion, almost at 14 atmospheres part was done along with high pressure with 3 into 12 NC balloon. And then again after these high pressure dilatation we did the IVAS needs, which is showing a good opposition and expansion along with the calcium expansion you can see in the calcific segment. And this is the one almost the LCBA index came to 128, almost very, very minimal risk zone it came, fat content. Now, this is the final result. And there is some diagonal also, some disease is there in this patient. So ultimately what I have the understanding if these IVAS needs compared to the routine IVUS, the resolution is very high, but the catheter is bulky, especially tortuous vessels, it is difficult to manipulate, what I have seen. And third important is the routine understanding of calcium, usually fibrocalcific plaques or calcific plaques, we cannot see the fat attenuations behind the calcium because of the high acoustic shadowing. But here by means of chemogram, it can identify the fat content like terrestrial water behind the calcium plaque, especially even heavy calcium also. And this has a lot of potential of clinical application in identifying the high risk plaques with high LCBA scores in patients with a high risk patient. And here is a example of high calcium with a high fat content. And this is a very prototype of hereditary hypercholesterolemia where LDL is 248 with a strong correlation with high incidence of high atheromatous plaques with very future events. And these are the ideal candidates for PCSK inhibitors as Pacman AMI study, especially evolocumab or inclisiran with very aggressive lipid lowering so that you can reduce the recurrent events and we can make the LCB index very low. And these are the patients especially used for the screening purposes, especially for family history patients if they are there, not only CT angio along with the lipid profile and functional evaluation. I think this is very important to identify the even non-obstructive lesions with high LCB index so that these are the patients who can identify for the biological treatment, whether inclisiran or by evolocumab. Thank you.
I will summarize everything through my talk over the next 5 or 7 minutes and not take much time if I can have my presentation. All right, we've had some fascinating talks on this new modality. My job over the next 10 minutes is going to look into the summary of all the talks which have been given. Yes, imaging is here to stay, and those who believe in imaging, they have more evidence being published every year. So almost everything's target vessel failure, stent thrombosis, MI, and all-cause death, everything is coming out, and this was a recent meta-analysis in the month of March. So I mean, imaging is definitely better than angiographic angioplasty, angiography-guided angioplasty. So one should adopt imaging. Whichever modality you choose is fine, but IVUS, OCT, IVUS nurse, but you must image. This is the new dual modality imaging catheter which has been made available. That means IVUS is there to define the morphology, and the plaque characterization is available through NIRS. How is it different? It is different from the existing IVUS system. It's got 3 differential speeds, 0.5, 1, and 2 millimeter pullback speed, and it's bidirectional. You don't have to, when we do IVUS, we have to manually get the catheter back in position. Here you push a button and the imaging lens gets back to its original position. So it's everything closed. It's something similar to OCT, except that you have to press a button and get the imaging catheter back. It interrogates 150 millimeters against 100 millimeters by the Boston system or the other system. The catheter is very sturdy. So, I mean, you can push it. The profile hasn't changed despite the dual modality being there, but it's 6 French compatible, not 5 French. So with 2 imaging modalities in place, it's a good catheter to have. And image quality, you've seen the cases. They are beautiful imaging. It defines the morphology very well. Well, IVUS, as we know, has much wider clinical applicability, as you can see from this slide. So, I mean, wherever you need to check for diffuse disease, the expansion, sizing, landing zones, osteal disease, CTO segments, patients with renal failure, IVUS definitely scores over OCT and has got much wider. And I always say this, that in IVUS, all you need to do is de-air the catheter, and then the catheter does everything for you. In OCT, you have to make sure that the guide catheter is coaxial, your injections have to be right, and if you acquire poor images, you will never read those images. But in IVUS, just de-air and do a pullback, and you get all the desired information. NERS, everybody has talked about. Yes, it color codes. The important message here is that there has been a histopathological correlation of lipid with the cut sections, and there is about 95% sensitivity specificity of picking up lipids. Now, mind you, it is just the lipid in the necrotic core which leads to ACS. You can have dead cells, you can have extracellular matrix, you have apoptotic macrophages, everything is there in the necrotic core. But it's the lipid which is very important, and we need to pick up lipid. Now, LCBI is scored 0 to 1000. Anything more than 400 is significant, which implies that 40% of your necrotic core is lipid. Higher the LCBI score, more are the chances of having events. Now, the virtues of having NIRS in the cath lab is, I think we've seen a lot of cases, I'm not going to repeat. In ACS, it identifies the vessel which has got high LCBI score, and you can do it to the non-culprit vessels. And if these vessels have got high lipid content, you take the prescription out of the cath lab to the OPD. We don't change the prescriptions in the OPD based on lipid levels. You see 120 cholesterol, you reduce the statins. But here you have an opportunity, you know the non-culprit vessels have got very high LCBI score, please continue statins for long. There are trials which have shown that there is percentage atheroma volume reduction, there is thickening of the fibrous cap which happens with statins. So it helps you that way. So it gives you more information than OCT and IVUS. It tells you what this plaque is made of, and which is very, very important for us to know when we write our prescriptions. We've seen in Indian context that if you start patients on statin 40 or 80 milligram, the cholesterols just drop. There are very rare patients that you have to use additional medicines like ezetimibe or bempedoic acid. So they all work with statin, but yes, our target is to get the lipids down in the coronary vessels. This study has already been covered. This is a landmark study which gave the cutoff of 400 LCBI. Now what is this? This is the max LCBI. That means this is the lipid core burden index over a longitudinal extent of 4 millimeters. So it's telling you it is in this small longitudinal extent of the vessel where you have very high lipid content. It's a marker of plaque instability. And it is based on this study that the FDA approval was granted to NERS. Well, Prospect was yet another study, and both these studies have shown that lipid-laden plaques are the major predictors of MACE. Well, a case example, this was a ACS patient. Again, just the same what previous speakers have shown. I'm not going to go into the details. What I'm just showing you is that this is a plaque which had very high lipid core burden index. The score was 834, so the vessel was adequately stented. Now you can see it circumferentially, it's like an attenuated plaque, but you know that in this attenuated plaque, we have very high lipid content, and you need to treat this so that you prevent the future events. So the vessel was adequately treated. This was the final result. And I think Pacman study has already been covered by the previous speaker. What it showed is that if you use PCSK9 inhibitors, you cause percentage reduction, volume atheroma reduction, you cause reduction in the LCBI score. So it's very important that you interrogate the vessels, and if you see that you have vessels which are studded with lipids, you give respect to that fact and treat your patient for a requisite period of time with the kind of therapy which the patient deserves. Well, in the calcific segment, the previous speakers have already showed NIS plays a very important role because this is the only modality which will tell you what is the character of the plaque behind the calcium plate. We know that OCT is limited by penetration. It can tell you the thickness of the calcium plate. IVUS will just have a acoustic dropout. It will just show that there is calcium. What is beyond that, you really don't know. Now, calcium, we know that calcium is a predictor of atherosclerosis, and if you correlate, the quantum of atheroma correlates with the calcium, coronary artery calcium score. So there's a kind of linear correlation of the calcium in a given vessel with the amount of atheroma in the plaque, but the calcium, the coronary artery calcium score does not correlate with lipids. Lipid is a marker of instability. If the plaque is of a long standing, it will have a lot of calcium and no lipids. The plaques which are in evolution will have more lipid. So lipid in a calcific plaque tells you that this plaque is capable of giving rise to events. So we felt that we should have a tool which can peep through the calcium and tell us, yes, whether we can see anything behind the calcific plate and stratify these patients. In IVUS NIRS, you have this tool. It can look through the calcific plate and tell you that, yes, this is a calcific plate which can give rise to events. And this is a calcific plate which can be modified with routine balloons, and you don't need high pressure balloons. So lipid pool coexisting behind the calcium. So there are a couple of cases. This was one of the LAD calcific plates, a tight lesion in the LAD, as you can see. We rotablated this and we did the NIRS. To save time, I'll just show you the chemogram. This shows a very high score of LCBI. And post dilatation, can you see there's a slow flow? Very rarely in a calcific lesion in the coronary segment, you will see slow flow happening post dilatation. We are used to these images in the vein graft segments. So the disc was implanted, and finally we did the follow-up NIRS, which showed a well expanded. The quality of images are very nice, and if those who are beginning their career with the IVUS, there's a definite learning curve, and I can assure that this particular modality can shorten that learning curve by the good quality of images which you get to see. This was the final image. The second case was a distal left main stenosis. This was again a case which was done under NIRS. There was a pullback done from both circumflex and LAD. And see the clarity of image. You can see the plaque distribution. You see the circ coming. You can see a calcific plate building, which kind of becomes circumferential. And now you see a lipid pool just behind this circumferential calcific plate. We also did the pullback, so there was concentric lipid pool behind. We optimized. There was stent was slightly underexpanded, and this was the final run after the optimization. So in the calcific milieu, it's a marker of, calcium is a marker of a burden of atherosclerosis, and calcium increases as you see the aging population in those with diabetes and CKD. Calcific plaques are unstable if they have lipid behind, and NIRS is the only modality which will tell you if there is a calcium behind the calcific plate, and you have to treat it accordingly. Well, if you leave behind a high residual LCBI score, there are chances that stent can fail. This is a study done on 200 patients, and what they noticed that the residual LCBI score of anything more than 200 predicts the stent failure, and they noticed that each additional 100 units of LCBI increases the risk of stent failure by 1.6 folds. So you also have kind of information which you get post-stenting. If you're leaving behind a higher LCBI score, your stents might fail. So how is NIRS different? To summarize, it's a dual modality catheter with the ability of doing a bidirectional movements, and it not only assesses the plaque morphology, it also tells you the composition. It images a longer length, 150 millimeter at variable speeds, and it's a very sturdy and a good catheter. The advantages are that it gives you information about the character of the plaque vis-a-vis IVUS and OCT, and this helps you predict MACE. This helps you manage the lipid outside the cath lab. Those who are having a high LCBI score, you can put them on statins for a longer period of time. It also helps you stratify your tools in a calcific lesion. If I see a calcific plate sitting on a lipid plaque, I'm not going to go aggressive with high pressure dilatations or IVL or atherectomy tools. I think cutting balloons and NC balloons are good enough. To conclude, I would say that we have a good dual imaging modality with us, which not only tells us about the plaque morphology, but also about the character of the plaque. And we need further trials with this modality to strengthen our belief in it. Thank you so much for your patient hearing.
Thank you, Dr. Chedda, for wonderful overview of NIRS IVUS. I think we are running behind the schedule. We can conclude the session. Thank to all the speakers and chairpersons for, I think it's a very wonderful tool because it shows the fat, that the lipid behind the calcium. That's the most beautiful aspect, where you can identify the vulnerable plaque as well as vulnerable patient. I think it has a great role in our future practice. Thank you, one and all.
Topic for this session is IVF. The facilitator for this session is Praveen Chandra, and the chairpersons for this session are V. Madan Mohan, Harinder Kumar Bali, Ajay J. Swami, Avdesh Kumar Sharma, Ramesh Darguvati, Jaisankar. And the panelists for this session are Ankush Gupta, Nikhil Patil, Naveen T, Naveen Bhamri, Sumanta Shekhar and Rayankar. And the discussants for this session are Mukesh Kumar Tiwari, Chakravarti P.S., Ravi V., Pirumurugan S., Bhaskaran S., Bhanu Subramaniam, Manivarun A.R., and Sabhapati K.
Okay, so in this post-lunch session,
We now request Dr. Pramod Kumar Kuchulakanti to come on stage and deliver their presentation.
so I think we can start now. Rest of the panelists are coming in gradually, and so we are a little late. So we will start now with Dr. Pramod Kumar, and he is going to discuss about complex cases, some cases, so that we start discussing on the use of IVL in complex situations.
Okay. Thank you very much, Dr. Praveen and NIC for asking me to involve in this case discussion on IVL. To set the context for IVL, which is used now to modify the calcium in the contemporary PCI, I'm going to start with one case, and then we can discuss further. Thank you. So this patient is a 63-year-old man with a stable angina and underwent a treadmill which was positive. He's in sinus rhythm with normal LV function, diabetic, and he was referred to me by the physician in our hospital for further evaluation. An angiogram was done which revealed a calcific left main LAD and LCX disease and a non-dominant right coronary artery. And we discussed the options of PCI with the patient and consented for PCI. And this is the angiogram. You can see the circled area which shows there is a calcification at the ostium of the LAD and LCX and also distal left main. And the approach I have taken was right femoral, 7 French sheath, XB3 guide, and both LAD and LCX provided with the Versaton. And we use OCT or IVAS almost 80% of the cases in our lab. And here you can see the OCT run from LAD to LMCA, which shows a very significant stenosis and very high degree of calcification at the ostium of the LAD now you can see there. And of course in LM there was a little bit of blood that was seen. So once again you can go through and you can see that there is a lot of calcium and the tightest lumen was 1.4 at the ostium of the LAD. And this is the pre-PCI OCT analysis. There was a heavy calcification, about 180 degree of arc with a depth of 0.9 millimeter calcium. And there was also a nodule of calcium in the proximal part. And minimal lumen area at the ostium of the LAD was 1.4. And LM was quite big, 4.4. And what are the options for lesion preparation in this case, which is a complex left main bifurcation? Cutting balloon or high pressure balloons, IVL or orbita or rota, we can discuss those things. And what are the options for stent techniques, whether to go with 2 stent versus provisional or DK crush, cullot or T or tap. So I decided to go with IVL in this case because there is a bifurcation. So rota is, requires a sequential rota. So I wired both the lesions and there was a distal LAD lesion as well. So which was pre-dilated with a 2,512 NC balloon at 16 atmospheres. and subsequently stented with a 2.5 and 26 at the distal part. There was a dissection after the balloon. This is the LAD. So this LED lesion was treated with a 2.526 DES at 14 atmospheres, and you can see that very good result in the LAD in the distal part. And subsequently came back to the LAD and LCX both pre-dilated with a 2.512 NC balloon at 18 atmospheres to make a way for the IVL balloon, and then went ahead and did a IVL shockwave C2 plus. It was available at the time. This case is done about a year ago, and it has got 120 pulses, as you know. And because the LED has a lot of calcification right from mid part to the LM ostium, 3512 IVL balloon based on the sizing with the OCT I have taken, and almost 2/3 of the pulses were delivered into the LED. You can see sequentially from mid part proximally I have come, and the final image shows in the LED the IVL. So as you know, it gives 10 pulses with each trigger, and then you allow time for the vacuoles to get absorbed, and then again give one more. So this was completed. And then LCX also I have done with the same balloon and remaining 40 pulses. So that completed the IVL balloon C2 plus. And then I did a OCT run from LAD to LM. You can see some cracks that appeared because of the IVL balloon, and the lumen area has expanded very well. So the gain after IVL is very good, and as you know, it is safe, and the incidence of the distal embolization or dissections, no flow, all those things are quite less with the IVL balloon. And post IVL analysis revealed, you can see some dissection cracks are there, and then went ahead and treated from LM to LAD with a 3.530 DES at 12 atmospheres, and subsequently optimized with a bigger balloon. That is the stenting there from LM to LAD. And then part was done in the LMCA with a 4x8 NC balloon at 18 atmospheres. After securing the LM to LAD is okay, then comes the rewiring of the circumflex. So while keeping the wire in the circumflex, another wire was advanced into the LCX. And after that, the struts were opened with the 2x12 and then 2.5x12 NC balloons. And then I put a 3x34 DES at 14 atmosphere in a fashion of T. Because the angle is quite favorable, I didn't want to come back into the junction. So I could layer it exactly at the LAD take off from the LM. And that is then subsequently optimized again with the 3.5 balloon in the optimal proximal part. This is the post-PCI OCT run from LAD to LMCA. You can see very circular, fully opposed stent. And then on the other panel, you can see the LCX exactly stopping at the LAD struts. So that was a perfect T in this case. And post-PCI analysis showed very good lumen area, and stent area was very good in the LM. And there was a dissection noted because this is a dominant left circumflex distal to the stent edge. There was a dissection. Then again, I covered it with a short stent with a 2.512. And after that, this is the final angiographic picture. And overlapping segment was post-dilated to 18 atmosphere with the 2.512, the same balloon. And we can see here that LM to LAD and also LCX completely reconstructed very well. And finally, we did a kissing balloon, 3x12 in both LAD and LCX at 12 atmosphere, and simultaneous deflation was done to preserve the carina, which is recommended. In the final result, you can see just the fluoroscopy. We can see the stent very clearly, LM to LAD and also the LCX. And patient is asymptomatic out to a year of follow-up so far. And the angiographic result looks very good. And long-term, 1 year is also very good in this patient. So my take-home messages are calcium modification in bifurcation is best accomplished by IVL in contemporary PCI. Imaging is very important adjunct to decide calcium modification strategies. And IVL is the best option, proven to have no major dissections, no perforations, no flow, and no distal embolization from the coronary studies that are published with the IVL. So thank you very much for your attention. If there are any questions.
Thank you, Dr. Pramod. I think this was a very well done case, especially using IVL. And so before we start doing some discussion, maybe we can see how many people are using IVL. How many people are using IVL over here routinely? So it's almost like, I will say 40 to 50% people are using IVL already. So which means that the experience in our colleagues is quite now picking up. And as we saw in this case, there were 2-3 points. One is that when we are using the same IVL balloon in 2 vessels, for example, in one vessel was a 3.5 vessel, the other was 3. Yes. So what is your general approach? Like you take a smaller balloon, like 3 millimeter balloon for both the vessels, or 3.5 for both the vessels?
No, I think the recommendations are it should be 1:1 when we pick up the IVL balloon. So because it was a proximal LCX only, I try to do it with a 3.5 balloon because the cost is also an important consideration.
So in this situation, what typically we discuss is that if the vessel is able to contact the vessel wall, the balloon is able to contact. For example, if you use the 3 millimeter balloon, even for the 3.5 LAD, if it is in touch with the vessel, I think it will have its impact on the vessel. And then use the same balloon on the other side. Because the chance of having a dissection with a bigger balloon in a smaller vessel will be higher. Yeah.
Right, I think that's correct.
Any other points from my colleagues here?
What are the image characteristics like which would make you to decide not to use an IVL balloon? Is there anything like specific image characteristics which maybe like no?
Yeah, actually, if you look at the calcific coronary arteries, the calcium will protrude into the coronary arteries. You can imagine something like a hill projecting into the coronary vessel. That is the classical description. So if you use ablative devices like a rotablator, you are just shaving off the tip of that particular calcium mound that is projecting. The IVL advantage is that it goes into contact with the vessel and it produces deeper cracks into the calcification. From the experimental data also, which was done using gypsum, so it will produce cracks in the vessel wall because media is not calcified in coronaries, unlike peripheral. So here you have only superficial calcium and deep calcium. The ablative devices generally they do a superficial calcium debridement. The advantage with IVL is deeper calcium, and OCT is one of the important tools that gives us. There is a calcium score that can be done also. So it depends on the arc of calcium. If the arc is more than 180, we get 2 points. And then if the depth of the calcium is 5 millimeter, and if the length is more than 5 millimeter, the score becomes 4. So if the score is more than 4 or higher, and then you have to think of a device that is going to provide cracks into the calcium. And after stenting also, it is demonstrated by OCT that the cracks will widen. So it allows us to expand the vessel better with the IVL.
Hello. Sorry. I am Dr. Chokkalingam from Chennai. I appreciate Pramod. How often you encounter perforation coronaries in doing the procedure?
I think it depends on the case, especially nowadays we get a lot of elderly people who come with a lot of calcific disease. And if you are trying to do those cases as we used to do previously before the advent of these new technologies, definitely the risk is always there. But now with the proper planning and usage of these new technologies, the incidence of perforation is definitely less. So in these kind of cases, never try to do with a regular NC balloon, trying to go with a high pressure, or try to use an OPN or those kind of balloons. That is not safe in these kind of cases. Definitely perforation is still known to occur if you do those things.
And another one comment I want from you. Now you see coronary disease much younger age group, 25, 30, both sexes.
Right.
The calcium, when does it occur generally in your experience? Is it after 40 or 50 or even younger one?
I think in my experience of last 25 years, the calcific disease is seen in the 5th decade onwards. It is very unusual to see unless the patient has got a CKD or very uncontrolled diabetes. In those conditions, we may see calcifications at a younger age, but I think in general, it is seen from 5th decade onwards. Maybe senior colleagues like Praveen may add their experience.
Another last comment I want from you or from the chairpersons, is it the calcium when you mention, it may be involving coronaries to the adventitia, media, or intima.
Yeah.
Does it the grading or place of the calcium determines the luminal narrowing? Or you are going to take it equate all calciums of coronary equal?
No, all calciums are not equal. There are several things now with the imaging we understand. Calcium can be concentric calcification, or it can be eccentric, it can be nodular, and it can be diffuse. So there are so many variations now we are understanding with the calcium, and with the imaging we are able to decide what kind of strategy we have to adapt. Whether you can go with a scoring balloon or a cutting balloon, or to go with a ablation like rota or orbita, which we will be discussing tomorrow here during lunch, or go with the IVL balloon. But by and large, yeah, please.
Is it that media in the layer that is involved is matter, or the structure or the pathology of the calcification matters?
No. What I have mentioned is in coronaries, the media calcification is not there because it is divided into only superficial calcium and a deep calcium. It gets effaced when there is a calcification in the coronaries, unlike in periphery. So we divide only into superficial and deep calcium. Depending on that, we have to strategize.
Thank you.
You're welcome, sir.
So that was quite a nice presentation with so much of discussion. We can, I think, keep it because we are already a little late. We'll take your question in the next session because the similar kind of discussion will happen. And Dr. Devdatta is here. Devdatta, come. For the right road to take calcium modification with IVL.
Thank you very much. So my topic is the right road to take, and I have 10 minutes. Is that right, sir? Thank you, sir, respected chairpersons and moderators and dear friends. So, impact of coronary calcium and unmet need for IVL. We know this. I'll quickly go through these slides. We have just had a long discussion that why we should be having calcium modification. And the score suggested by my previous speaker tells you that if the score is high, then the chance of stent expansion is poor. And in those cases, we have had a variety of calcium modification devices in the past, but now we have IVL, which is a new addition to the armamentarium, and it provides us unique opportunities to deal with calcium that was beyond the scope of earlier calcium modification devices. So this is the device, and since majority of us are using it, I'm going to skip this, but this is just a revision. So we have balloons 2.5 to 4 millimeters, and the length is 12 millimeters. There are 80 pulses. Now we have a balloon that has more pulses. Guide wire is same as coronary guide wire. It's 6 French guide catheter compatible. Length is 138. Tip profile is 0.023 and crossing profile is 0.044 to 0.047. And it is now being used in peripheral above knee and below knee cases as well. And how does it crack it? There are multiple mechanisms, but I'm going to just show you what is the difference between a soft structure and on a hard structure. So these two fingers are on the device, as it were, and the device is actually giving the pulses. Nothing is happening to the soft tissue of the fingers, whereas if this was hard calcium and the device started discharging, the calcium would break apart, as you can see in this. So this basically is the principle. If you have soft tissues around the emitter, nothing will happen to it, but the hard ones will crack. And there have been consistent clinical outcomes across the various trials. We have had Disrupt CAD 1, 2, and 3. And I will go into Disrupt 3, CAD 3 because this is the prospective multi-center single-arm global study after which it got FDA approval. And the performance goal was based on Orbit 2, and primary safety endpoint was 30-day MACE, primary effectiveness endpoint was less than 50% residual, and no in-hospital MACE. So there were 384 subjects, and the follow-up was 30 days, 6 months, 12 months, and 24 months. And you can see that the calcified length was a median of 47.9, and there was severe calcification in all of these patients. However, stent delivery was possible in 99.2%, so this is almost 100% stent delivery and post-stent dilatation. And the primary safety and effectiveness endpoints were exceeded. So this was a very safe device. All of those who are using it would vouch for it. It is a question of how we do the imaging and size the device. And if we size the device correctly, then there is a gain from pre-procedure pre-procedure lumen areas to post-IVL to post-stent, and there is a very good lumen gain in all of these cases if the procedure is done properly. Regarding complications, severe dissection, post-IVL 2.5%, perforation 0%, abrupt closure 0%, slow flow 0.6%, and no reflow 0.0%. And these are the in-hospital and 30-day MACE. You can see 7 in-hospital just marginally rises to 7.8, and cardiac death 0.3 to 0.5, all MI 6.8 to 7.3, non-Q wave MI 5.7 to 6.7, and so on. And there is no evidence of learning curve with IVL. So it is a balloon after all, and you have to just deliver the balloon. You have to do some pre-dilatation in very tight lesions, so the balloon is across the point of interest, and then you just start delivering the pulses. So the key takeaways from the 30 days was that it was safe, it was effective, and it had a ease of use and quick learning curve to achieve consistently predictable outcomes. So these are more data which again shows that this is a very effective device, and I'm going to show you some data by Ziad Ali, and this is pooled OCT outcomes across Disrupt CAD 1 to 4, and this is what it shows. What is the post-IVL appearance, and what is the post-stent appearance in various cases of IVL application. And this is pre-IVL, again, pre-IVL, post-IVL. You can sometimes not be able to see fractures on OCT post-IVL, but these segments of the vessel will still dilate and accommodate the stent, and that is because there are some micro fractures which are not in line with the OCT, which may not be visualized. This is calcium nodule. I think our last speaker showed his case where the calcium nodule collapsed, and this is how it behaves. So you can see on your screen 2 cases of calcium nodule and how the calcium nodules have given way. So it ultimately results in a concentric expansion. Sometimes, however, there will be eccentric expansion where the calcium plate is too thick beyond the calcium nodule and it may not fracture completely. It has consistent outcomes in men and women, and there is no differences in primary safety and effectiveness endpoints. So I'm going to finish with some cases. This is a 57-year-old man who had an inferior wall infarct from the circumflex artery, and we were going to deal with the LAD D1 bifurcation. And this is the OCT, and what the OCT showed was a plethora of findings which was interesting in that it showed calcium, it showed lipid-rich plaque, it showed a calcium nodule round about there, and then proximally it showed a spontaneous dissection there. So a lot of findings there. We started to do some balloon dilatation, and there was some slow flow after that. And we also noticed that this part of the balloon where the calcium nodule was there was not expanding properly. We dealt with the slow flow, and we took a IVL balloon 3x12, and we delivered the pulses, and the calcium gave way with sequential pulses. You can see the waste in the balloon going away, and this is the OCT after the IVL delivery, and I'm going to show you the point where I'm going to call it out, where the calcium has collapsed, the nodule has collapsed. So it is round about, okay, I missed it. I'll just show you where we think the nodule has collapsed. Sorry. It is, get this laser pointer on. Yeah. So it is round about here. Anyway, I'm running short of time. If there is time, I'll show you later. After this, the stent is well deployed. I'm going to just show you the final result. I think 2 minutes left, sir? 2 minutes? Okay. I'll show you another case. This is a much more challenging case done by a colleague of mine, and you can see that the entire RCA is calcified. So he begins with rotablation because nothing else would go past, and he does a fine job of rotablation here. And then here comes the IVUS, and you can see the calcium plates here. And it's quite clear that you cannot do this without modification. So this is an IVL with a 3x12 IVL with sequential pulses, and then this gets rid of the calcium plates quite well. There is fractures there, and you can see that the stent is well expanded. There is a distal dissection which is stented, and you can see that the stents, all the stents are well expanded here, and this is the final result. And this is the last case. I'm going to just show you quickly the images. This is a patient who had in-stent restenosis, and he had a stent and then further stenosis beyond the stent, and which was all calcified. And you can see the plate calcium here. We did IVL with a 3x12 balloon, and you can see the cracks in the calcium. I hope I have pointed it out with arrows. And then once it is cracked, the stent expands quite nicely. And the final OCT run, you can see, I'll just skip through for the sake of time. And I'm going to show you the last case, which is very tight calcific stenosis, and I'm going to show you the OCT run here, and you can see that there is a lot of calcium, but we are not really bothered with this calcium. What we are bothered with will come in the end, and that is the proximal tight stenosis. And what it shows is that there is a very tight stenosis, which is probably a calcium nodule, because we can't really see much beyond the, and it is round about there, okay. So this was very, very difficult to crack. We used all our pulses, remaining pulses here. It did ultimately crack, and I'll show you the final result. I'm sorry, I am over, my time is up. So this is, you can imagine how the calcium has cracked, otherwise the stent would not have opened like this. And we did some post-dilatation. This is our final OCT run. And you can see that the stent from top to bottom is well expanded, and it is more or less concentric, and the nodular calcium has collapsed completely, and this is our final result. So IVL, ladies and gentlemen, is a wonderful tool. You need intravascular imaging, preferably optical coherence tomography to assess the vessel, the size of the vessel, the choice of the balloon, the circumference of the stent, the thickness of the calcium, the thickness of the calcium, and the length of the calcium. All of this is important, and once you have done this, and you have done the job properly, it is a wonderful tool, and it has made a real difference. It is a really disruptive technology in the field of calcium modification. Thank you very much.
Thank you, David. I think, you showed very interesting cases and wonderful insights as to how we can use IVL in these complex situations. So I think we'll move on because the time is a little bit issue here. And so we'll go to recent updates on IVL by Jimmy George.
Thank you, Chairperson, and NIC for giving me an opportunity to present. So wasting no time, I'll just rush and apologize. Some few slides are almost same as the previous one. But like when you have a dense calcium, you definitely need some modality which would modify this calcified plaque so that the stent crossability or deliverability also is there, as well as the expansion always occurs. There are different modes of calcification, and all calcification may not be the same. You can have the eccentric one, the concentric one. You can have a 360 degree of calcium, as well as nodular protruding one, superficial and deep, where mostly superficial you need an atherectomy, and deep you need a balloon strategy. The thickness could be a thick plaque or a thin one, and maybe a focal or long segment also. So all these modalities needs to be having different gadgets to manage it up. Earlier, like the balloon strategy, you had high pressure balloons. The risk were more of because of the dissections and perforations it causes. The atherectomy, a good tool for superficial, non-crossable lesions, but it had its own slow flow, no flow, dissections, and thermal injuries too. So definitely a new tool, a lithotripsy, which we were using for the last 3-4 years because of a low pressure, 4 atmospheres dilatation, which doesn't cause any slow flow, no flow, or perforation or dissection, and even the side branches are protected too. I'll just skip these. Basically, all comes with the 12 millimeter balloons. And if you see the CT, that is basically the microfractures or the micro CT where you can get the fractures more prominent, which may not be quite evident even with the intravascular imaging, either an IVUS or an OCT2. So what the upgraded one of the C2 plus catheter, now available in India, is basically a 50% more, 120 pulses, especially useful for diffuse calcified lesions or multivessel involvement, especially eccentric and nodular calcium too. The extra pulses adds on to basically cutting all these calcium out there. I'll quickly run to a few cases out there. This was the first case what we did in 2020, February, 1 month after the IVL had come up in India. You can see a long calcified RCA with almost a subtotal occlusion. You can see the entire jacket of calcium over here. The crossing itself took us 2-3 hours. But after that, once it was crossed and imaging was done, you can see there's a lot of calcified nodule and almost 3/4 or 4/4 of calcium ring coming over there. And this was followed by an IVL at 3/12 IVL with a guide extension catheter was parked, and multiple cuts almost required 50% of cuts to be done in the distal, followed by proximal. And you can definitely see those cuts of the IVL in these OCT images, and the lumen expansion also has increased, and that's the final result over there. But I need to show out here, this was that distal, this was the proximal RCA area, and this was the second one was a distal. Almost you had a good expansion of the distal, but where the entire chunk of calcium, you just had a 50% expansion. So definitely you needed that extra 40 pulses or extra that 50% of pulses, which could have definitely added on in this case and had a better benefit. Now this case, you've got a multi-vessel post-CABG patient, you've got a LED D1 calcified lesion, especially involving the left main tube, but the chunk of calcium you can see over the LED as well as the diagonal you can see. And this was crossed with a 1.25 rota, followed by an imaging, the rota cuts you can see over there. But what I need to highlight over here is that the entire thickness of calcium of almost involving almost 1 to 1.2 millimeters of chunk of calcium at a 360 ring of calcification seen over there. So this was followed by an IVL, a 312 IVL, multiple cuts done, and almost the entire cuts needed to be given to the LAD, and the diagonal we just left out without much cuts. And you can see the post-IVL cuts, very good significant cuts. You can see over here, large cuts across this 360-degree arc of calcium and multiple cuts over here. And that reassures that your stenting would be better then. So this was followed by a mini crush technique where the LAD and D1 was stented. And post-stenting, the lumen expansion was almost 100% in most of the areas, with an proximal almost getting an area of close to 9.5. So disrupt CAT3, I'll just skip on this. Basically, around 400 patients with around 450 centers, where you cannot see in imaging the cuts. It's quite evident in the CT, which, because 2/3 of patients only had IVL cuts if you see in the disrupt 3. So even there could be cuts if you have the micro CT done. The same thing, only the pre-procedure to post IVL and post-stent, the stent expansion is always great. Even the yellow one is what you see the first time doing an IVL, and it's almost at par. There's no much learning curve anywhere at all. Almost the crossability, everything is quite evident. And this is a beautiful, like, majority of these cases in the disrupt CAT3 were very, very severe calcification, almost involving more than 3/4 or 4 arc of calcium, 1 millimeter and more than 5 millimeter size of calcium, length of calcium, and almost 99% had success rate in it. For eccentric calcium, another thing out there, this was a case of a female who had presented with a calcified nodule-like thing in the left main with an proximal LAD calcified occlusion CTO. Whether it's a thrombus or whether it's a calcified nodule, imaging would say, but what strategy to be addressed out? So definitely concentric as well as eccentric calcium in the disrupt CAT3 had fractures, which are more in the concentric, but eccentric definitely had also its outcomes. The thing is, the more pulses are required for eccentric calcium rather than concentric calcium, because the eccentric calcium, whatever pulses which goes to the normal tissues may not get reflected out too. So the extra 50% of calcium in eccentric calcium definitely acts on to it. So we underwent an imaging of this both from the LAD as well as the circumflex. And if you see over here, there's a chunk of calcified nodule which is constricting the lumen area, and that's the distal left main also, having almost completely occluding the vessel with a large chunk of eccentric calcified nodule. So an IVL, almost 20 pulses done over here, but what was surprising is almost the rest 60% of our IVL pulses needed to be done over the LAD, and this was followed by a reverse stab. I'll just skip this. The post-stent optimization imaging also I'll just show. The lumen area almost expanded to 10 with an expansion of almost 100+%. Final kissing balloon and the final result. Still you can see over there that still LAD was a large chunk of calcium. Maybe the extra 40 pulses would have been definitely beneficial. That's the final results. That's the top one is the pre-IVL, the other one is after the IVL, and the bottom one is the post-IVL result. It's quite evident that the eccentric nodule has been taken out and the stent has been expanded well. Now I'll just go to the last case. The case of stent expansion, a pre-dilatation was done with a 3 balloon, and after which a stent was deployed, but still with post-dilatation of 3.5, 3.25 balloons and all, the results were all dog boning effects. So definitely, this is the OCT view of that under-expanded stent. You can have a big dog boning effect in the OCT even after multiple balloon dilatations over here. So IVL was a bailout in this case, which unfortunately crossed. And after giving around 50 to 60 pulses over here, you can see the opening of the vessel. This was a constricted one, and this was the well-opened under expanded part of the stent. The lumen area also you could see well expanded. Sorry. And this was final result after the post-dilatation. So in conclusion, I would say like IVL C2 Plus with the extra 50% A120 pulses is the new tool in the kit, which would definitely be beneficial for long diffuse disease, especially when you're planning to have an overlapping two IVLs, which may not be that cost effective. But when you have to use for multi-vessel cases in these scenarios, it could be definitely useful out. As well as the better pulses can be shared with all the three vessels if you have calcified lesion. And especially in eccentric calcified nodules, the extra pulses could be really handy out. Under expansion is another one, which is the last resort. It could be also quite effective. Thank you. I'd like to invite you for the next month's CHIP Summit meeting at the Goldstone Country, Cochin. Thank you.
Thank you, Dr. Jimmy. I think that was again showing that this device is so effective in all kind of we started with concentric calcium, and now we are treating nodules and plates and everything, and also bifurcation lesions. So let me have some insights from my other colleagues sitting here. Any thoughts on the use of IVL? So
a few cases where I got failed is nodular calcium. So it was a tough job. Even with IVL, I was unable to break the nodular calcium. Then I went through the literature and found that we can use a balloon on the side and overlap the IVL above the balloon to break the nodular calcium. Then I tried with few more cases in the same aspect, then I got the result.
So it's like two balloons together.
Yeah, correct.
That's quite interesting. I have never used this, but certainly, we do, we have to understand this, that IVL cannot break everything away.
Yeah, right.
And there will be many instances that, you have used a balloon, you have finished all the pulses, still there is some residual, and the vessel is not expanding. So in these kind of situations, I think many of us use additional devices, like cutting balloon, and use of cutting balloon to high pressures also is quite helpful in many situations.
Even orbital atherectomy also upfront could be
And
sometimes
rotational atherectomy prior to that is, certainly is something, which we do in those situations where we expect that, IVL may not cross.
Right.
Yeah. Any other, you want to say something? Yeah.
Regarding the IVL in under-expanded stents, do we have any do you have a data like long-term data to show how these stents behave in the long run?
I don't think, anybody has any idea on the long-term outcome of IVL in unexpanded stents. The data is positive, but long-term outcomes?
So it is not indicated actually, it is out of the box usage for under expanded.
Generally it's used as a bailout, but do we have any data like how these stents behave in the long run?
But the most important thing is when we are doing upfront, it is always better to treat the lesion completely before we put the stent, because many times we get stuck. Once we have put the stent, now what to do? So then we have to resort to these
Many times recrossing the constricted portion is very difficult.
In acute setting, this is contraindicated as such because the stent medication as well as the stent gets, destroyed out. So it's only a bailout thing. So the long-term data also may not be there. Like what sir was saying, that preparing the bed is the most important thing. Whether you want to pass IVL balloon or you want to pass in high pressure balloon.
And one of the things which I have seen in my practice is IVL hesitancy. You know IVL hesitancy? No. Okay, IVL hesitancy means that you have taken the patient on the table, you are midway, and your balloon is not expanding, and you don't know how should we go ahead and do the IVL because you have not discussed with the patient or the family, and this is an additional expenditure of the same amount of money which is going to be spent for angioplasty. Right. So there is a very serious issue here, and that is why I always think that see the lesion well, imagine whether the calcium is there or not, and then discuss with the family before taking the patient on table, because 50% of the times, if you find such a problem, you will not be able to use IVL during the procedure, and then it becomes a problem.
Most of the time, After IVS only we'll know the exact situation, sir.
Yeah, but before that also, you can still make some kind of a guess whether this patient may need IVL or not. You can tell the family that we may need IVL. Because I have seen that few times when we have not used IVL and you come out, tell the patient family that, there was a situation we could have used. So then they will say, oh, you should have used it. So better to discuss it
Yeah,
beforehand.
rather than using 3, 4 high pressure balloons, you're at ease, you're only dilating it to 4 atmospheres. And the chance of complications is almost negligible. So definitely you will be eased at that doing the complex case.
And there is no problem using cutting balloon or any scoring balloon even after
After
IVL.
that,
Should
right,
not be a
right.
problem.
Yeah, exactly.
I think.
So I have to share a case, a live case which was recorded earlier, and since the time is not really too much, I will fast forward it a little bit so that we don't overshoot the time. Okay, can we start running it? We need the sound also. Interesting case with you. And so Dr. Siddharth Varshne is going to introduce this case. And here I'm working in my cath lab at Medanta, and Dr. Nagendra Chauhan is on the right side. And he will tell you once the case introduction is done, what is the plan. So Dr. Siddharth, can you introduce this case?
Good evening, everyone. So this is a 67-year-old lady who is underlying case of diabetes and hypertension. She was admitted at peripheral hospital with chest pain. She had this chest pain on 22nd January, and she reached hospital on 26th January. She was a case of acute anterior wall MI out of window period and in acute LVF and in cardiogenic shock. She was taken up for angiography there. Her LAD was occluded, totally occluded in mid part, and LCX was normal, and RC had 95% stenosis. She was then referred here for further management. When she reached here, her blood pressure was 70 millimeter mercury systolic, heart rate was 72 per minute, and rhythm was silence. Her echo showed akinetic mid anterior septum apex. LVEF was 45%, mild MR was there. So, since LED was impacted, she was initially planned for medical management. She was taken in, intra-aortic balloon pump was implanted, and she was initially stabilized. Her creatinine was around 3.3, with over time gradually improved with medical management to around 1.5. Now she is planned for stage PCI to RC.
I think shockwave चाहिए होगा, shockwave.
Sure. Angiogram.
Hello. So you
Yeah, can you
already
see the
heard
angio?
about, yeah, so you cannot actually see the angio because the angio was done outside, and they are trying to, because they could not get the CD, so they got a
they will show it.
video
चल रहा
which
है?
is
They will show the
being
angio.
run now. Can you see it now?
Angio.
So in this patient, the interesting aspect was this, and this is very common with many of my colleagues, that patients come with angiogram, they do not have the CD, and the video is there on the phone or something like that. So based on the image which was seen on the phone or the computer, we were able to see that yes, this RCA needs treatment. But the problem was that we could not really do an angiogram because her creatinine shot up to 3.3, and we decided that we will not give any contrast whatsoever unless until it is very, very necessary. So this was the situation where we had to do it with a very low contrast, like almost zero contrast, and also the right coronary was very calcified. So the plan was to then take it up, and then we started doing this. As you saw already, that initially we tried to do an IVUS, nothing is going inside. And one of my colleagues, maybe he gave some little contrast to engage the catheter, which also we don't do most of the times. Three ka dena. And give me a balloon of 2 millimeters. Two ka balloon. So since the IVUS was not going, we decided that okay, we'll have to do some pre-dilatation, and then only we can do some imaging.
So you have
we went
engaged
ahead.
without giving a single drop of contrast, even without a
No,
single drop of contrast.
so no, we have just given 2 cc contrast, was given only because we did not have any index shot, so it is only 2 cc while the guiding catheter was saved. So we saved some contrast over there. Okay. Yeah.
Or you can do surfing. If you really do not want to give any contrast,
Yeah.
you can
Yeah.
take the guide near the mouth and start surfing with you.
Yeah, so normally we do that, but since he gave that contrast, we said, okay, let's save it. We are not going to take any angiogram. Okay.
Right.
So you can see that this is the angiographic image. Show the fluoro, please.
To the first fluoro
so
image.
you see, only just one, maybe it's one contrast. So the proximal part has a tight stenosis, and we are going to do a pre-dilatation. Give me a pre-dilatation balloon. 2.25. Yeah, 2.5. 2.5.
So what is the permissible contrast load according to the GFR?
According to the GFR. So in this situation, as you saw that we are now proceeding with the intervention here, and to take the IVL, as we saw that the IVUS did not cross, so most likely the IVL catheter will generally not cross. We have to pre-dilate, and usual practice is that we dilate with a 2.5 balloon, NC balloon, and try to see if we can negotiate the IVUS catheter or take the IVL catheter. Her load is about I think 20 or 25. Yeah.
Okay.
But we are not giving any contrast so far. Our aim was to do almost a no contrast with great difficulty. When she came here, she was in sepsis, cardiogenic shock, and the creatinine was high. She was put on a balloon pump to start with, and because Impella was not, and because of the cost issues, and then she gradually the proximal improved. Part of the vessel where and she was ventilated also. Yeah. This catheter went. So I'll try,
because plug and play 20 hertz or 45 hertz?
No, it is we have both 20 and 45, but in 45 you have to also do that injection and all that. In here in 20, it is quite simple and easy to do. And the images, many times people say that I don't like the images, but basically it's just a matter of getting used to. Give me a guide extension, please.
My lab, we have Philips too, and almost 90% of cases I use 20 hertz because easy to prep and plug and play, very robust catheters.
Yeah, very nice catheter, and in crossing.
Able to do pivot, now you can do it easily.
Video or not, I'm on the phone, so.
And this guideliner is crossed much beyond the balloon. See?
Yep.
And now we will be crossing the balloon. Okay, the balloon crossed now. Okay.
Nice. Okay.
Yeah. And now I will dilate it. Okay. Go up, please. 1, 2, 3, 4. And this is a high pressure balloon. 6, 7, 8, 9, 10. 10.
So what is the balloon that you're using right now?
This is a 2.5 into 12 NC, Apollo NC. Go up. 2, 4, 6, 8, 10, 12.
IVL or any other thing?
14, 16. We are using IVL today, deflate, because in this kind of situation, maybe I think the best, bet is IVL. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18, 20. Deflate. It's a heavy calcium, you see. 1, 2, 3, 4, 5. So there is some problem. Today we.
So which you next?
IVL in this particular scenario.
So after this pre-dilatation,
Dr.
with the help of this guide extension catheter, which is guide plus 2 always, we went ahead and did the IVL. You will see the IVL catheter now.
Hey, can we get the angio? Yeah, thank you.
Still it is not going. So we did some more dilatation using a cutting balloon. Push my guide extension deep inside. Oh, it's deep inside. Okay. Is it coming? Yeah. Today we are going to discuss. What is the problem? Can someone help in this? Because there is some issue of making it fast forward. Today we are going. No. I think there's somebody is doing it from there. I have to fast forward it. Yeah, that's right. Yeah. Okay. today we are going to discuss, a very interesting. Not 2 is now crossing.
Yeah.
So, in the fluoro.
No, it was on the small screen. Now they just flipped. It's good now. It's good.
Okay. So here you see even this is critical. It's quite okay. This is a cutting balloon you are using. And then, if and followed by in this, that's good. IVL after
Not
this.
that tough.
This is a
Calcium.
for now this is the IVL. वो saline चला दो उनका. हाँ ठीक. जाओ जाओ कर दो पहले नहीं. Rupture of the shockwave balloon sometimes. So we take out the air bubble
So
which
for those that are
forms
watching, that's
because
a
many
super
times
duper
these
important
bubbles
point.
lead to rupture of the balloon. So how frequently I see that happening a few
This is
times.
basically possibly because the air which is dissolved inside the
Okay.
contrast, it is
Go up.
now.
Shit. Again it's gone. Today we are going to discuss, okay, go up, 1, 2, 3, 4, yeah, 0.48, it ever, and now we are going to do another inflation with the same, because sometimes the compliance, etc., things change. So we'll do again, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10, 11. Okay, deflate. So we are pretty much done, I think. And we have to do one more dilatation with a 3.5 inside. So we have deployed the stent with those markers, to take this the calcium markers, and no injection was given. You see the guiding is jumping inside. So I can use again the guide extension to help me take the balloon out, okay? So what happens is
Ramdev,
that it doesn't
chat box,
injure the...
Dr. Chanda, Dr. Ramdev Jadhav from chat box. He has asked why not 7 French AL1. We have discussed that part. AL1 for good subit is good, but chance of ostial dissection is a concern. In your hand, Dr. Chanda's hand, definitely it will work better.
2.5.
Simple catheter like there with guide extension is not a bad idea. Dr. Jadhav.
OCT कर लेते हैं, OCT.
पहले 3.5 12 और फुला देंगे
हाँ, ऐसे फुला के OCT दे
उसके
दो.
OCT ready करो.
Okay, so we have not given any contrast so far, and we are looking at the hemodynamics. We look at the ECG, which means the side branches are okay, which means there is no perforation. And how much heparin has been given?
10,000.
10,000? Who has given? You have given? Just making sure. So now you see that the balloon is, because of that rigid calcification, balloon was having some problems, but it's gone inside. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18. Deflate. Dilate distally also. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 10, 12. My friends, colleagues in the department. So we use about 150 imaging procedures every month. Go up. 2, 4, 6, 8, 10, 12. It's so easy now. Deflate. So everybody does imaging. I try to do that, and many times we are successful.
So
okay, so I'll just use again the, in case we find some difficulties, yeah, we can.
Guideliner.
Use the guideliner again.
There is a new data of heparinized saline rather than only saline in CTO 2024 CRF. I do not know.
Oh, yeah.
In detail what is the advantage, but
no, but I think that's a good idea. Why not? Heparinized saline is a better idea. Why not?
No.
I totally agree with you, Dr. PK. You have good ideas. Thank you very much. हाँ और क्या? चलो लाओ, we are ready now.
थोड़ा सा गाइडेंस अंदर डाल दें. अच्छा दिखेगा. हाँ.
Right.
अच्छा दिखेगा.
So Dr. Nagendra is saying that we should push the guide a little bit inside. It will show better. Are we okay? Okay. Everything okay? Flush, please. So he is taking a 12, become too old now. I think it's quite good.
The proximal edge is not clear.
Proximal edge, shoot. Yeah, perfect. So this is a saline OCT to see whether the stent is fully expanded, edges are okay or not. And
Good.
after this,
Click
we
on
did the
inject
final
or no?
IVUS. And this is
Excellent.
the only one
Great
shot
job.
was given.
So
Brilliant,
this is
brilliant.
the
You see.
complete angioplasty with the just 3, 4, 5 ml contrast, and
3 ml.
that's it. And we
I think that is all. So thank you very much. And these are the kind of cases we can do with IVL without contrast, high risk situations, and of course, it works out quite well if if we do take the right steps. Yeah. Okay, Pramod.
I think it's a very challenging case, and nicely you have demonstrated how to tackle these things. But in general, if the kidney issue was not there, if our IVUS is not going, I think it's a better idea immediately to switch on to a rota in such cases. What is your opinion?
Yeah, definitely. If it is not going, then rota is a good idea. So we do rota shockwave or maybe just rota and cutting balloon, depending upon the situation. All those combinations are possible. And but in this case, as you saw, that the plan was to use absolutely no contrast. Yeah, so this was much easier.
I mean, guideliner is one of the best things. The guide extension catheters
Yes.
should be handy in all cath labs. Whenever there is any problem of pushing the gadgets downwards, they are really of great help.
Yeah, especially in these kind of difficult RCAs. Now, earlier we used to use too much of AL1 or AL2 catheters or more aggressive extra backup right. But now with these, this was a routine RCA, and if you use the guide extension, it just crosses the lesion very well.
I use 3DRC. That is one of the smooth
3DRC
catheters,
is very good, yeah.
and you can implant it without any problem.
Yeah, 3DRC is a good one. Yeah.
Also, it is
And
interesting
if there
to
is
see.
no other question.
Also, it's interesting to see initially the balloon was not crossing, whereas the guide extension catheter went inside.
Yeah, this is the guide. I mean, I particularly have used all of them, the guide liner, the guide Zila, and the guide +2. But I prefer the guide +2 because it is very soft. It doesn't injure the vessel wall, and it just crosses the lesion also quite easily, even if the balloon is not crossing.
Another telescope that is also very
Telescope?
soft,
Okay.
very good.
Okay. Thank you very much. I think we can close this session. Yeah, thanks.
Topic for this session is coronary physiology. The facilitator for this session is Madhu Sridharan. And the chairpersons for this session are Rajesh M. Dave, Vijay Samuel Thompson, Hemant Narayan Rai, Gopal Krishnan, Vikash Mujumdar, and S. Tamilrasu. And the panelists for this session are Srinivas Prasad, N. Sridhara, Shyam Kumar G, Mohan Mani, Madhi Bhanu Kiran Reddy, and Vipin Sinha. And the discussants for this session are Abhishek Kasha, Amit Singh, Chetan Jain, Shashikant Nilangekar, Sridhar Badhe, Kedarnath Karpe, Subramanian R, and Anup Singh. May we now request Dr. Rajesh Muralidharan to come on stage and deliver their presentation.
Good afternoon, everyone. Thank you, Pradap sir and NIC for this opportunity. It's a proud privilege to be presenting. I'll be giving a basic talk on the fractional flow reserve measurement, the do's and don'ts of an FFR measurement. Fractional flow reserve or FFR exposes the functional aspect of a stenosis and is affected by multiple parameters like the epicardial coronary anatomy, which is just one part of it, the extent and more importantly, the viability of the perfused territory, the microvascular function or resistance, the myocardial blood flow, which includes the collateral flow as well. Basically, fractional flow reserve is a cath study of the coronary arteries, and like in any catheterization studies, we should ensure that the transducer is fixed to the table at the reference height at the level of the aortic root, which is generally considered 5 centimeter below the sternum. Since we are using a fluid-filled system, varying the transducer height can alter the hydrostatic forces and influence the PA. As can be seen from the tracings, the red which depicts PA, when the fluid-filled system is higher or the transducer is higher, the pressure measured is too low, and when it is lower, the pressure measured is too high, whereas the green, which is PD, is actually remaining the same. We should flush the catheter before making any measurements as well as equalization, because this flushes away whatever air bubbles, blood, contrast, whatever is there in the system, and prevents the damping of the waveforms and gives us the best waveforms available. And we should ensure that the entire system is filled with there is a break to flush the catheter. Okay. Okay. The next is with regard to the choice of the guide catheter. The use of a diagnostic catheter for the measurement of pressure or FFR should be discouraged, because it doesn't give stable PA signals, and moreover, if the wire were to dissect, then we will lose valuable time to get a stent in place. So it is always recommended that you use a guide catheter, 5 French or above, but it should be noted that guide catheters also can produce some obstruction to blood flow, more so if you have some osteal disease, and which goes against the basic principle or the basic definition of fractional flow reserve, which means that we should ensure maximum flow so as if you are measuring FFR. So no diagnostic catheters for the measurement of FFR, guide catheters preferably 6 or 7 French. And it is also important that we avoid using side hole catheters, because the streaming of blood or contrast through the side holes creates a gradient in the guide catheter proximal to the side holes and distal to the stenosis, so that distal to the side holes, so that the true pressure proximal to the stenosis is not documented, but rather a mixture of pressures after streaming is documented. So it is important that we don't use side hole guide catheters, and if at all we are using a side hole guide catheter for measuring FFR due to some reason, which should be under IV adenosine and not intracoronary adenosine, because the true delivery or effective delivery of adenosine cannot be ensured intracoronary. Do not equalize with the introducer in place. This is another important tip. When your introducer is in place, it introduces a vent in the system, and as can be seen, there is a small subtle difference between the red and the green lines, or between the PD and PA, as can be seen at the arrows. So all connections must be tightened, no loose ends. We must probably use a New York Toohey so that there is no leak, and the introducer should be out of the system before equalizing. Hyperemia is the basic crux of measuring an FFR, and it is imperative that you induce maximum hyperemia. At the same time, it is important that we also know about the drugs that affect the adenosine metabolism. It is presently recommended that patients are, to ensure that patients do not take caffeine 12 to 24 hours before adenosine administration. And one of the upcoming controversies is with regards to ticagrelol and FFR, and using adenosine to measure FFR. Ticagrelol, as we all know, increases the plasma levels of adenosine by preventing cellular uptake, and this leads to higher levels of adenosine in the body. Now, this is a small study in which a ticagrelol loading dose resulted in a greater and absolute relative reduction in FFR compared to that of a clopidogrel loading dose. But whatever little studies have shown is that this doesn't affect any practicalities, and we can continue to use adenosine just like whether we are using ticagrelol or clopidogrel. But it is to be remembered that ticagrelol is associated with a slightly higher adenosine levels and probably a little lower FFR values compared to clopidogrel. Another confusion that we all have is where to keep your pressure sensor for measuring the FFR. For example, this is an LED lesion, and you can keep the sensor here, or where we can keep the sensor down there. So where to keep the sensor? For that, we need to understand the flow dynamics of blood. As blood flows through a stenosis, what can be seen is that the velocity starts rising just before the stenosis, and it keeps on rising and reaches a maximum somewhere close to the stenosis, after which the velocity falls again and the laminar flow gets restored. If you look at the pressure simultaneously, the pressure starts to fall just before the stenosis and is at its lowest point somewhere near the stenosis. The vena contracted, to take the analogy of the Doppler signals, and then it starts recovering. So this is the phenomenon called pressure recovery. That is, there is a rise in pressure after some distance the blood has traveled beyond the stenosis. And if you were to measure the pressure or the PD somewhere in this point, this is not a stable place, and that is not the right place to measure the FFR. So you must push the wire down as distally as possible. Now, this example shows elegantly that this is an LED lesion here, and suppose this is proximal and distal. As can be seen, if you measure the pressure just distal to the stenosis and then you push the wire down, the FFR value starts rising up. So where to measure the FFR? The transducer must be as distally as possible, at least 2 to 3 centimeter distal to the stenosis, or distal to where a surgeon would graft. Avoid a distal lesion and an accordion effect, and it is a prudent practice to document the position of the transducer with fluoroscopy. We all get excited when we get a value for FFR, but the more important point is to look at the tracings. Mind the tracings, that's more important. If you see the PD and PA tracings, they're almost identical, with the PD tracings showing less of a dichrotic notch. That's the usual thing when there is no gradient. When there is a minimal gradient, there is a gradient in diastole, there is no dichrotic notch, but there is no gradient in systole. When there is a moderate degree of stenosis, there is a large gradient in diastole, a small gradient in systole, and there is no dichrotic notch. And when there is a severe gradient, or when there is a very low FFR value, you have a very large gradient in systole as well as diastole with no dichrotic notch into the PD. This is the standard tracing, or this is a good fidelity tracing that is obtained. So if you get a value of say 0.60 and see some tracing like this, that means that it's not probably correct. So you must also mind the tracings rather than the values. Another thing to see for the tracing is to see whether the catheter is getting wedged. When you give nitroglycerine as well as adenosine, there is torrential flow that happens. The guide gets sucked into the coronary arteries, and the guide can get wedged, leading to ventricularization. So the practice, or the standard practice, is to just pull back the catheter or just push the wire so that the guide is coming out of the ostium, and when the guide is disengaged, you see the true FFR value. In this case, when the catheter was wedged, the FFR value measured was 0.88, whereas when the pressures are, or the tracings are normal, it is 0.66. So had we just gone by the FFR values, we would have missed this lesion. So it is important that you just disengage the guide after your hyperemia and ensure that the guide is not getting sucked in when the flows are at its maximum. This is something called a whip artifact, where the transducer is hitting onto the wall, and this giving rise to this physiologically impossible phenomenon. I would say to this degree of impossibility, that you have the PD that is much larger than the PA. So this is because of the transducer hitting onto the wall, producing a whip-like effect. This is another phenomenon called the drift, where you have the gradients in systole as well as diastole, and there is a dichrotic notch in the dichrotic notch that is noted in the PD as well, which is also not correct. And it can be actually as a result of a temporal mediated gift or a temperature mediated gift, which can be corrected. We have to redo the procedure actually. So what people usually don't do is how to end an FFR measurement. How should you end an FFR measurement? You should pull back the wire into the guide and see for the pattern of pullback, whether it is a diffuse coronary disease pattern, in which case a stent is not going to help, or if it is a focal coronary artery disease pattern, where you have focal step-ups, where placing a stent is going to take away that gradient and is going to help the patient. The pullback tracing should be recorded and look for drift. The PD by PA should ideally be 1 and should not be less than 3. That is the current recommendation. In case of a drift, we have to go through the painful process of equalizing again and redo. Sir, just last slide. It's also important that you read the angiogram carefully before making an FFR measurement. One of the things that we usually miss is an osteal lesion. So the catheter can get wedged or we may miss it. We have talks coming on this. Myocardial bridge is another phenomenon that we usually miss. You do an FFR measurement, but we should know about the intricacies of a myocardial bridge. And the third thing is that we should also remember that FFR depends not only a measure of the stenosis, but it is also a measure of the extent as well as the viability of the perfused territory. So this is also should be noted before interpreting a particular value of FFR. Now FFR is a bare number and ischemia doesn't occur as a dichotomous value. It should be noted that when the FFR dips from 1 to 0.9 to 0.8 to 0.7 to 0.6, the MACE rate subsequently increases. In these patients with the lowest value of FFR, who are at the highest risk of MACE, your intervention is going to give a benefit and that is going to produce a result. As the FFR value increases, the benefit of a intervention becomes lesser, and at this point, which we believe is the gray zone, the two curves cross over and probably medical treatment is much better or good than an intervention. So it is important to also know that FFR is just a value that would give you the clue towards what is the degree of ischemia and respond appropriately. Thank you for your time and patient listening.
Okay, in the interest of time, we'll now invite the next speaker, Dr. Sridharan, to discuss FFR in ACS. Should it be used?
Respected chairpersons and friends, we'll go on to the next topic. Please put it on. It's FFR and ACS should be used at all. Now, why this question? You got a huge data of FFR-guided angioplasty. It improves outcome and cost benefits largely due to deferral of angioplasty and avoiding revascularization of insignificant lesions. So why is the question? That's the first thing that will come to the mind. The data for FFR, you got DEFA, FAME, FAME2, Dynamic 3 Primalty, compare acute in stable and in ACS, and you found that FFR-guided angioplasty is definitely better than just optimal medical therapy. This is the DEFA trial, and the patients who were deferred did the best at 5 years, and it was maintained at 15-year follow-up. Now, then came FAME2, that the 5-year outcome of patients with stable coronary artery disease, and FFR-guided strategy was associated with a significant reduction in death, MI, and urgent revascularization at 5 years. And this is driven predominantly by a reduction in revascularization with no difference in MI or mortality. And a compare acute showed what Rajesh was talking about. It's just not a binary number, it's a continuum. There's a non-linear and inverse continuum of MACE. The lower the FFR, the worse the outcome. Now, physiology in PCI got a huge evidence of data. DEFA, FAME2 with hyperemic and defined flare and IFR sweetheart with resting index. It shows the safety of deferral of PCI. It shows the benefit of physiology-guided revascularization. and FFR should be taken as a continuum rather than as a binary number. So why is FFR in ACS different from stable angina pectoris? You got certain issues in ACS. You have reduced sensitivity of adenosine receptors. You have increased LVEDP, myocardial edema, enhanced sympathetic drive, blunted coronary vasodilatation, and of course, it's unable to detect plaques with unstable features, which you can do only with intravascular imaging. So you have a reduced hyperemic flow in non-culprit lesions, and this may underestimate FFR, and this is shown in the reduced MVI trial as well. The first trial which showed there's some problem with FFR in ACS is the famous non-STEMI trial. It showed there's an increase in the minor, not procedure-related MI on follow-up. Means it's not a procedure-related, but on follow-up, you had an increased number of MI in non-STEMI patients. And this was in 2015, and then came the study from Korea, which showed the prognosis of deferred non-culprit lesions. And you can see, as the patient was stable versus ACS, whether it's unstable angina or non-STEMI, you have more number of events on follow-up. So this one showed that the deferral or the deferred non-culprit lesions in ACS as compared to lesions in stable coronary artery disease, MACE rates were significantly higher in ACS. And this is consistently observed in all ranges of FR and all subgroups. And this is systematically increased risk of clinical events in ACS, and the recommendation was strict medical therapy. But why does it occur, and what happens, and what data do we have from RCT? There's a pooled data of IFR Sweetheart and defined flare, which show that in patients presenting with ACS, the MACE rates on follow-up was significantly higher. Now, deferral of revascularization is safe. You got a low MACE of 4%, and lesions were more frequently deferred when IFR was used. Whether it's IFR or FFR, the rates are similar and it's safe. But in deferred patients presenting with ACS, an event rate was significantly higher at 1 year as compared to stable CAD, p-value 0.04. Now, this is the revascularization deferral of non-culprit lesions on the base of FFR, more than 8,000 patients at 1 year follow-up. And this showed for the patients who were deferred, when they came with ACS, the events were higher on follow-up as compared to those with stable angina pectoris. What is important was revascularization deferral resulted in higher 1 year MACE as compared to stable angina pectoris, and the difference started within 1 month. And difference was due to higher unplanned revascularization in ACS. The 1 year outcome in patients who were treated as opposed to those who deferred were the same. So if you treat the patients, they had the same outcome, but if you defer the patients in ACS, they had worse outcome. What are the possible hypotheses? Intrinsically a higher risk of events in ACS. You got a vulnerable plaque, there's a triple L on imaging, large plaque burden, a lipid-rich small lumen which is missed on physiology, misdiagnosis of a culprit lesion. The FFR of the culprit lesion may be deferred based on a negative FFR, but that might be the reason why the patient has come with ACS. And a false high FFR in ACS due to transient modification of hemodynamic and microcirculatory status. These are the possible hypotheses. But what about the randomized trial? I mean, this is what we all look into. Does it relate or change to events on follow-up? You got the first one, there's a complete trial, which is complete versus culprit-only revascularization in patients presenting with STEMI. More than 4,000 patients, complete versus culprit-only, median follow-up of 3 years. And you find that the co-primary outcome of cardiovascular death or new MI was significantly reduced with culprit. And if you add ischemia-driven revascularization, it's even more, with a number needed to treat of only 13. So the conclusion was it reduced CV death and new MI by 26%, death, MI or ischemia-driven revascularization by 49%. And this was the largest trial of complete versus culprit only, more than 4,000 patients, and it conclusively showed that complete revascularization is better than culprit only PCI. And this study was based on angiographic stenosis of more than 70. FFR was used only in a minority when the lesion was 50 to 60. So it is predominantly an angiographic guided study. So predominantly angiographic guided, and it resulted in reduction in all endpoints. Now, what happens with FFR versus angiography for non-culprit lesion revascularization? You got 4 trials, Flower MI, Frame AMI, FIRE, and full revasc. Flower was the first one to show That is more than 1,000 patients, FFR guided versus angio guided, death MI and urgent revascularization. The primary outcome was similar in both. The strategy of using FFR to guide non-infarct-related PCI yielded no additional clinical benefit. This is from Flower. So in STEMI undergoing complete revascularization, FFR guidance did not have any significant benefit over just angio guidance. And however, there was a wide confidence interval for the effect and did not show for a conclusive interpretation. So this is in sharp contrast to the complete trial, and it questions the compare with ACS and primary and culprit with complete revascularization. And in frame AMI, you had a significant reduction in events when you did FFR. The FFR-guided PCI reduced the death, MI, or repeat revascularization at 3.5 years compared with angiography, and this was to be expected normally because you put lesser number of stents, and driven by lower death in MI in the FFR group, and FFR-guided strategy used fewer stents and lesser contrast media. And now, you look at this. This is completely different flower. But you must understand the frame AMI, the original sample was more than 1,200, and it is stopped at 562 with less than 50% of the planned enrollment due to 18.7, the primary outcome in frame, as compared to 5.5 versus 4.2 in flower. 562 versus more than 1,000 patients. And here it is entirely STEMI, and you had a combination of non-STEMI and STEMI in frame. So how do you reconcile the difference between the two? Both trials were underpowered. STEMI alone in flower, while non-STEMI and STEMI in frame. And if only the STEMI group is considered, probably there would have been no difference. Now, by staging the procedure, there was no increase in events in flower, and in frame, 60% underwent immediate angioplasty. So probably physiology protected against peri-procedural events in flower MI, and frame was terminated early and the benefits may be exaggerated. Then came full revasc, which is published just in April this year. And here again, it is comparing FFR guided versus angiography, and this did not reduce death, MI, or unplanned revascularization, did not reduce death in MI, did not reduce unplanned revascularization. And this is completely different from the complete trial, where you had significant reduction with complete revascularization, or the FIRE trial, where elderly patients, based on FFR, had a significant reduction in the endpoints. So in full revasc, more than 1,500 patients with STEMI or high-risk non-STEMI, there was no reduction in death, MI, or unplanned revascularization, different from complete or the FIRE trial. Subgroup analysis showed benefit in patients who had critical stenosis, 90 to 99%, and more importantly, you found increased stent thrombosis, restenosis, and TLR in the FFR-guided group. So putting stents, you have problems, though it is not significant. And a practical approach, this is from Dr. Koo in JACC Asia. If it's STEMI, critical lesions, do it. And again, same with non-STEMI. But if not critical, it's probably to go ahead and do a physiological assessment either with FFR or non-hyperemic and then proceed with revascularization. So putting it all together, we still do not have clear answer. We have different trials showing different things. FFR in ACS has issues. Deferral of non-culprit lesions may miss the unstable lesions, which can be picked up only on intravascular imaging. The complete 2 trial, that is comparing strategies in more than 5,000 patients with STEMI, non-STEMI, with physiology and imaging followed up for 3 years, will provide a definitive answer. It's still ongoing. Until the results of complete 2 trial are known, you can either use physiology or angiography, which both are reasonable. In critical lesions, more than 90%, probably you can do it at the same time, but if it's borderline, a physiology-guided stage revascularization in a second stage should be the way forward. Thank you.
Thank you very much, Dr. Sridharan, for that fantastic overview of all the current literature in acute coronary syndrome. I think that we'll continue with further lectures. And now we'll invite Dr. Hari Krishnan to speak on ostial lesions, left main, and serial lesions, tips and tricks.
Good afternoon, respected chair and panelists. Can I have the slides? FFR and ostial lesions, left main and serial lesions. So as already Dr. Rajesh has mentioned, we have to have a very good physiological assessment which otherwise leads to over-treatment or under-treatment. The FFR assessment of osteal lesions can be challenging because of problems in equalization, problems in hyperemia, and also gate catheter issues as we have already discussed. So in an osteal lesion, where will you equalize? It should be done in the aortic sinus, both for LMCA or RCA osteal lesions, because the distal placement may affect the basal FFR values. In turn, affect the final values. Hyperemia, it has to be intravenous. Intracoronary has issues because we cannot deliver the adenosine. Or engaging, you can have osteal spasm, which can contribute to the stenosis. And what is a standard procedure? Equalize the wire in the aorta, advance the wire into the distal vessel, intravenous adenosine, and disengage the guide always, and measure the FFR. Gate catheter related issues, Rajesh has already pointed out, as the gate catheter size increases, it can have inducible stenosis. And you should avoid the position of the guide, you should be very, very important. You should not cross the osteal lesion. If it is crossed the distal tip, then it will give the erroneous values. And gate catheter with side holes, this is already discussed. You should not use gate catheter with side hole, especially when you have an osteal lesion. Wedging of the gate catheter, this also is discussed. You can see that if you miss the initial part of the tracing, you might think that the FFR value is negative, but actually you can see the initial part, it is significantly positive. Again, another example, you can see the initial part, the FFR value given as 0.88, but the true FFR it is 0.66. So to summarize the osteal lesion assessment, intravenous adenosine, equalize in the aortic sinus, measure the FFR with the gate catheter disengaged, always look for wedging, and judicious use of nitroglycerin is very, very important. And branch osteal lesions, the FFR depends on the amount of myocardium supplied by the vessel. That is why when you assess FFR of a diagonal ostium and all, even if the FFR, the angiographically it looks significantly stenosed, you may not get a positive value. Coming to the second part, that is a tandem or the serial lesions. We know that physiological lesion length is significantly shorter than anatomical length, and the total strength deployed, if you use a physiologist, is usually less, and this can lead to better outcomes. As you see in this, as the stent number increases, the TLR increases. So more stents, more events. So physiological assessment lead to use of less number of stents, which leads to improved outcomes. So, So what is a tandem lesion? Tandem lesion is defined as a lesion which requires two stents, which will be interspersed by a normal looking segment of 10 to 20 millimeter, or you can define it as a multiple focal stenosis separated by segments without a significant pressure drop to be more objective. So this is one of our cases where we did, so when you have a serial lesion like this, what you have to do is to assess the significance of the whole vessel. That is the first thing to be seen. For example, in this case, we found the whole vessel. If you put the wire distally to this point, you will get the value, we got the value as 0.73. So the vessel is significant. So now we have to decide which lesion to be stented first. But the problem here is that there can be interplay of stenosis. One lesion can affect the other lesion. That is the problem of interplay of stenosis when we affect. So here what we have to do, we have to use the big delta rule. We have to find out on pullback which is the lesion with the highest gradient. That is so IV adenosine, full hyperemia pullback, and treat the lesion with the highest gradient. That is a big delta rule. So I will show you how it was done. So in this case, we did the pullback. We can see that the distal lesion, the pressure gradient was from 0.73 to 0.71. Proximal lesion was the highest gradient. So we have to stent the proximal lesion. So we stented the proximal lesion with a 3x18 stent, and subsequently assessed the FFR. Then the FFR value came as 0.72. That means that the distal lesion is also significant. So we have to treat the distal lesion. So we treated the distal lesion with another stent, and the FFR value came as 0.95. So this is the big delta rule. Stenosis A more than B, fix stenosis A. If it's stenosis B, fix that. Both are equal, fix the proximal stenosis. And reevaluate the gradient after fixing the first stenosis. If the FFR is less than 0.8, fix the other stenosis also. If it is more than 0.8, leave the stenosis. So is it fully accurate, the FFR measurement? But there is significant data to show that underestimation is more common but overestimation rarely occurs. So it is said that resting indices, the non-hyperemic pressure ratios are better in tandem or diffuse lesion due to the physiological issues I am not going to discuss because of the lack of time. So it is said that either you use any of the non-hyperemic pressure ratios like DPR or RFR or IFR, it is better in assessing a serial or a tandem lesion. So IFR, there are softwares available where you can, the machine will give a virtual pullback and you can see the lesion with the highest gradient. You can stent that and then reassess. Even you can see this, the angio co-registration, I think some of you may be using that. The higher the height of the tower, the tighter the lesion. So you can stent that and reassess. Even virtual stenting is also possible with this software, and you can see what will happen if you stent the first lesion and see what happens to that. So this is the algorithm of the assessment of a serial or a diffuse lesion. If you have a focal lesion, you have to go with a PCI. If it is a serial lesion, you go by the big delta rule, PCI the lesion with the highest gradient and then reassess. Mixed lesions, if it is a type 1 mixed lesion, consider imaging. So these are the serial lesions with the multiple pressure gradients. If it is a diffuse lesion, as you see here, you keep the patient on medical follow-up. If it is a mixed lesion, you go accordingly. So depending upon, if you have a tight lesion with a higher pressure gradient, do that and leave the other lesions alone. So coming to the third part of the talk, left main assessment. So isolated left main lesion, for example, a mid or an ostial lesion, with no significant disease in the LAD or the circumflex, you can wire either the LAD or the circumflex. If the value is less than 0.8, go ahead and fix the left main. If it is more than that, keep the patient on medical follow-up. If it is a true bifurcation involving both the ostial lesions, you have to wire into both the LAD and circumflex and take the lowest value and stent the left main if it is significant. Take the lowest value, which is you are getting by putting the wire either in the LAD or the circumflex. So you know that left main stenosis are rarely isolated. So it is usually associated with lesions in other vessels. For example, if you have a tandem lesion in the left main and the LAD, how will you assess? This is a very complex situation because you have interplay of the stenosis. So it is said that if the lesion is borderline and if you put the wire in the circumflex, this LAD lesion can affect the lesion. But it is said that it is found that if the lesion is proximal and severe, then only the LAD lesion will affect. So if it is the LAD lesion is not significant or the circumflex lesion is not significant, you can put the wire in the LAD or the circumflex and you can assess the FFR. So how will you objectively assess? For example, if you assess the combined FFR. So for example, if you have a lesion in the left main and LAD, you put the wire in the LAD and see the combined FFR of a left main and LAD lesion. If the value is more than 0.65, that means that the LAD lesion is not that significant. You can put the wire in the circumflex and assess the FFR. If the value is more than 0.85, you can safely leave the patient. The left main lesion is unlikely to be significant. If it is less than 0.8, you have to go and revascularize the left main lesion. If the combined combined FFR value in left main LAD is less than 0.45 or some studies say 0.5, you have both lesions are likely to be significant. Left main lesion is likely to be significant. You have to revascularize both. Here you have an option. You can revascularize the LAD lesion and reassess the left main once again. Then also you will get ideally if the value is less than 0.545 or 0.5, most likely both lesions are likely to be significant. So we have seen all the three situations. To conclude, physiological assessment helps in avoiding unnecessary revascularization, which lead to better outcomes. Following the steps meticulously is important in ensuring accuracy and meaningful results. Ostial lesions, look for wedging, nitroglycerin judiciously, disengage guide during measurements. Tandem lesions, big delta rule. Non-hyperemic pressure ratios may be better. Left main lesions is a complex subset, needs good understanding of the concepts. Thank you.
Harry, just a question. If you have ostial disease, you said, you put the wire into the sinus and then do it. Instead of taking the wire out, can you just put it into the guide and take and equalize?
No, guide, you have to put it into the sinus only. You have to put it into the sinus.
No, you have to take the wire out.
Yeah, wire out in the sinus.
Another technique there is to put a sepal wire. You will have two wires, then you have more control. So what generally I do is put a sepal wire, and then I first put the FFR wire straight in, then you put the sepal wire, and then you have the control to come back and then do it. Because isolated, if you have only one wire, to normalize becomes an issue.
Easiest will be to put it in the sinus and do it.
My question is, because essentially you are equalizing the septal, the proximal and the distal. But when you are putting in the catheter, the guide, the wire, if the catheter is so large, so the wire should be the same, isn't it? Why do you have to take the wire out?
So the problem is the tip of the PA is measured at the tip of the guide catheter. When we are using the FFR value, the PA is measured at the tip of the guide catheter. So we will be equalizing proximal to that. So that is why the transducer has to come out. And when the problem with putting another wire is that the TUHI will produce a leak.
That is a thing usually, but you normally, if it is a snug fit, if it's a good hemostatic, it shouldn't make a difference because you're renormalizing. So that shouldn't worry. Because the practical point, even if you use IV, we've encountered this, where especially when aorta or still disease, however much you try to normalize, because there is something which you put in the aorta, there's the whip artifact. Especially this is more common with the IFR system than with the FFR.
See, we are measuring very borderline lesions. 0.78 or 0.82 is going to make a difference. So we have to be very, very meticulous in measuring the FFR. And always, as Rajesh has suggested, always pull back and to the guide and make sure that the value is 1 at the point where you have equalized. That is the most important step. Unless you have done that, you have not done the FFR correctly.
I have one question. Do you routinely give nitrate before measuring FFR in the coronaries?
Yeah, absolutely. You have to give nitrates to dilate the epicardial vessels, and we have to give adenosine to dilate the resistance vessels. That is essential.
And in fact, the most recent study tells that the most common cause for variability in FFR measurement is not giving proper nitrates. And it's not 100, it's 200 mics.
No limit unless the pressures are holding.
Thanks, Hari. We'll go on to the next talk. What have we learned from the current trials of FFR, Vimal Raj?
Good evening, everyone. I would like to thank the organizers for having given me this opportunity. So I'll be presenting about the current trials of FFR and the lessons learned from it. So first, I would like to start with the COURAGE trial. In patients with chronic coronary syndromes, PCI did not reduce MACE when added to optimal medical therapy. So angiographic-driven PCI is inadequate for patient selection in chronic coronary syndromes, and we need to do better. So I would be dealing my lecture into FFR before PCI and FFR after PCI and the trials and lessons. We all know that there is a discrepancy in angiographic and physiologic significance of a coronary stenosis shown in various trials. The first FFR was performed by Andreas Grunzig during the first angioplasty in 1977, where he used a double lumen catheter. One lumen was used to measure the pressure before and after the angioplasty, and the success was measured by improvement in pressure as well as the improvement in the angiographic appearance. The DIFFER trial previously discussed showed that differing patients who had an FFR of more than 0.75 at the end of 15 years, there was no significant difference in mortality. Even in the case of a proximal LAD lesion, when the FFR was more than 0.80, the study showed that there was excellent outcomes and survival at 5 years compared to those who had no CAD if the FFR value was more than 0.80. The FAME1 previously discussed showed that FFR-guided PCI is superior to angio-guided PCI. FAME2 5-year follow-up already discussed showed that when the FFR was more than 0.80, optimal medical therapy alone is associated with a worse clinical outcome than stenting with optimal medical therapy. Now, previous speakers have spoken about imaging and FFR. This trial, the FLAVOR trial, compared intermediate lesions, 1,682 patients, FFR or IVUS to decide on PCI and to assess the PCI successes. FFR was not inferior to IVUS, and interestingly, there was a 32% less PCI in the FFR arm. So both ACC and AHA for assessment of intermediate lesion, FFR class 1A indication, whereas in multi-vessel CAD for assessment of usage of FFR is a class 2A indication. Now, Dr. Madhu had elegantly quoted various trials. I had a the other side of the coin. So we all know that in non-culprit lesion assessment for ACS, yes, the FFR changes from acute state and during follow-up. The value is statistically significant, yes, but the numerical difference seems to be small and probably it is clinically irrelevant. How do we say so? FFR positive lesions are associated with more rise in inflammatory markers. And also there is a CT FFR study which showed that the FFR positive lesions had more plaque vulnerable features compared to those who had an FFR negative lesion. The flower MI study previously discussed compared FFR and angiography guided PCI in ACS. It showed that 38% less PCI in the FFR arm, yet no difference in outcomes. The frame study was also previously discussed. So now we go into the next entity. After we measure FFR, we do a pullback. The previous speakers has told that we have to look for drift on the pullback. There is a new marker which has come out called as the pullback pressure gradient, and that is calculated using the pullback pressure gradient index, the formula of which is displayed outside. The software installed in the FFR machine does this computing. So this trial, they showed, this was presented last year in TCT, nearly 1,000 patients. They showed that a pullback pressure gradient of more than 0.73 was associated with a more focal lesion, and a pullback gradient of less than that was associated with a diffuse lesion. This gradient was used to predict the post-PCI FFR and thereby the delta FFR and also the plaque vulnerability. In this study, they showed that there was some correlation with plaque vulnerability and the FFR significance. Those lesions who had an FFR value close to 1 had OCT features of a 360-degree plaque and more tick fast compared to those who had a pullback gradient of 0. So we all know that if the vessel has got an FFR of less than 0.80, then the vessel has to be treated. Now the pullback pressure gradient seems to guide which modality of treatment would be able to give a good post-PCI FFR, and probably which modality of treatment would be better for that particular vessel. Now in case of discordance, I have the study with 840 vessels on 596 patients. In all the vessels, FFR, IFR, CFR, IMR, and RRR were all measured. In this study, they found that the most important message is when there is a discordance, there is no difference in patient-oriented clinical outcomes at the end of 5 years. That's the important message. And now, if you have an IFR which was significant and the FFR was not significant, this study showed that it is probably associated with microvascular dysfunction. So if the IFR is significant and FFR is not, probably go ahead and fix it. Whereas if it is the other way, that is the FFR is significant and the IFR is not, then maybe we have to decide based on the clinical scenario. Now, the lessons learned in chronic coronary syndrome, FFR-guided PCI is superior to angio-guided PCI. If significant, PCI is better. If not significant, differing safe up to 15 years. Non-culprit lesion, yes. Important things are, it is complete revascularization is better than culprit-only PCI. FFR-guided non-culprit lesion PCI is superior to culprit-only PCI. FFR-guided PCI reduces the number of stents we used and reduces the number of PCI which is being done. Pullback pressure gradient can be used to predict the post-PCI FFR, and when there is a discordance, probably going by IFR would not be a bad idea. Now, there are a lot of trials which are coming on this post-PCI FFR space. So you see, first we start with, after a crossover stenting, you assess the jailed side branch. You see the FFR values, you see angiographic stenosis, almost all the lesions appear significant, but not the FFR values. Now, can we go by this? We have this elegant trial which showed that 5-year outcomes after the target lesion failure was lesser if the FFR value was more than 0.80. There was no significant late catch-up seen in this study. And also if the FFR value was less than 0.80, treated either by doing a kissing balloon dilatation or by putting a DEB or by using another stent. So irrespective of whichever you do, you get it over 0.80, you get better MACE compared to those if it remains less than 0.80. So the value of post-PCI FFR started with Nicopil's evaluation, which showed that lesser the low post-PCI FFR, more will be the events. So in this meta-analysis of 5,277 patients and approximately 6,000 vessels, it was shown that a post-PCI FFR of more than 0.86 was associated with better outcomes. Importantly, if your post-PCI FFR remains less than 0.80, then there is increased mortality in that subset. Similarly, another meta-analysis of 4 randomized control trials and 5 observational studies showed that the post-PCI FFR value could be vessel specific. For LAD, it was 0.86, and for non-LAD lesions, it was 0.93. This study also showed that if the values are below the cutoff value, then the MACE events could be higher. So another entity called as the trans-stent gradient. So if the gradient across the stent is going to be higher, it's more than 0.04, then it is associated with increased events. Now let's say if you don't get a good post-PCI FFR, if you still have a trans-stent gradient, which is going to be less than 0.04, then the outcomes in this study was found to be equal to having a better post-PCI FFR. So this is the target FFR study, which used the pullback gradient, especially the trans-stent gradient or gradient across lesions to guide angioplasty. So in this trial did not meet the primary endpoint, but it significantly reduced the number of lesions which had an FFR value of less than 0.80. So this is a probable algorithm which says if your FFR is going to be, a post-PCI FFR is going to be more than 0.86, then look for the stent. If the trans-stent gradient is going to be more than 0.04, use imaging to optimize the stent. Or if it is outside the stent, probably stenting it would not be a bad idea. Whereas if it is going to be diffuse, then optimal medical therapy would be the way to go. So the lessons from post-PCI FFR are that FFR-guided side branch intervention seems to be feasible, safe, and effective. And better physiology post-PCI is strongly associated with reduced events. And there is a difference between the post-PCI FFR cutoff value varies with various vessel. And the value of physiology-based optimization post-PCI is being currently evaluated by the defined GPS study. To summarize, in chronic coronary syndrome, FFR-guided PCI is superior to angio-guided PCI. ACS non-culprit lesion, FFR correlates with plaque vulnerability. We have some studies which show that, and it obviously results in fewer PCI, fewer stents. Pullback pressure gradient, a new entity which has been found. A cutoff gradient more than 0.73, more focal disease, better to treat with PCI. Gradient less than 0.73. And in this study, it was found that the post-PCI FFR improved well if it was pullback pressure gradient was more than 0.73. And these patients had a better post-PCI FFR. And it can be used to select the modality of treatment. And in case of discordance, probably IFR. And post-PCI FFR strongly correlates with event and is vessel-specific. Physiology-based post-PCI optimization is currently being evaluated by the defined GPS study. Thank you very much.
Thanks a lot, Vimalaj. I think there's a live case going on, and I think the organizers are asking for that. So we'll ask the chairpersons and the panelists from the next session to come in, please.
Topic for this session is live case coronary physiology. The facilitator for this session is P.K. Asokan. And the chairpersons for this session are P.K. Asokan, Manish Doshi, Sura Kishore Mishra, Subhasis Roy Chaudhary, V. Murugesan, Vijay Shankar Sharma. And the panelists for this session are S.K. Ziyarat Islam, Sanya Bose, S. Gopalakrishnan, A. Srinivas Kumar, Shubham Singhal, Anil Kumar. And the discussants for this session are Aditya Sakre, Rahul Mahade, Rahul Balekar, Nilay Patel, Vivek Ampore, R. John Satish, S. Gokulnath.
Yeah. Good afternoon. Welcome you all to this exciting live transmission from University Heart Center, Freiburg, Germany. And without ado, we'll move over to Dr. Ferenge. Dr. Ferenge, can you hear us?
Yeah, well, can you hear
Yeah,
you?
live.
Very
Can
well.
see you.
Very good.
We can hear you well.
Yeah, see you. Hi. Very good afternoon to you.
Special
to
greeting from
Chennai.
Cardiology Society of India, NIC, 2024 from Chennai. To you and your team.
Yeah, thank you so much. Warm welcome to you from University Heart Center Freiburg Bad Krozingen. We are small town in southwest part of Germany, but we have a really huge center with 400 cardiovascular beds as university heart center, and we have 15 cath labs, so it's a high volume center. With me is Dr. Rahimi. He is one of senior operators, and we presented for you, I think, quite interesting case. And maybe with us is technician Veronica here, and we start now with a case presentation. Ari, start, please.
Yeah, good day. Also, a warm welcome from my side. I would like to start immediately with the case presentation. Next slide, please. It's about a woman, 75 years old, without any really pre-existing conditions. She has got just some risk factors, and she's complaining chest pain and dyspnea since a couple of months regarded to low physical activity. Next slide, please. The laboratory investigation, ECG, didn't show any relevant pathologies. The echo could show a mildly reduced left ventricular function with a wall motion disorder inferior lateral. Next slide, please. And here are the imagings of the coronary angiography. You can see on the left side, the caudal view, severe stenosis of the circumflex, and also the LAD on the right side seems to be quite diseased. Next slide, please. And on these two following imagings, you can recognize that even the ostium of the circumflex is severely diseased, and it's nearly a subtotal stenosis. So we have got this two severe stenosis. Next slide, please. And here the imagings of the right coronary artery, also diseased, but the stenosis does not seem to be really severe. Next slide, please. So we would like to go for the intervention of the circ. And our idea is doing preparation with IVL and doing imaging before and afterwards, of course, and then to decide regarded to the results of the imagings if we want to do another plaque and calc modification or not. So what's to you?
Yeah, thank you for this nice introduction, Farid. So we now go to our first picture from the cath lab. Now you can see on the right side, this is now current view. And of course, there is a very tortuous coronary segment with some partial aneurysm, like as you saw also in the right coronary artery. And that's make us a bit problems to be sure which diameter we should have here to choose the right diameter of the stent. And definitely we need some optimal lesion preparation. In this projection, you see this lesion is really subtotal ostially, and the question is, can we place the stent at the lesion, at the ostium of the circumflex, or should we overstand the ostium of the LAD, which is very tortuous and not severe stenosed? And you see distally a very, very tortuous vessel segments. So particularly here, the LAD is really very tortuous. So our approach was clear. We wanted to have, we have 7 branch. We have, in this case, femoral approach. Heparin and double antiplatelet therapy is now started. So we go now with floppy wire to LAD to have security for the LAD, and go with run through hypercode to circ. And our first step was to go with imaging. And maybe, Thron, you can just go to the right on the right. Okay, so here you can switch to IVUS. Now we have first IVUS run. You can see that's a vessel diameter of around 3, and it will be in proximal part even much bigger because there is also partial aneurysmatic disease like here. And but we would start with lesion preparation from here around. You see, there is a now also calcified vessel wall, and this was aneurysm. And now our topic, the distal lesion, will come. There is a fibrocalcific wall lesion, so there is no circular calcium. That's why we personally believe we have choose here IVL as a first step. So we perform predilatation with 2.0 balloon just to be sure our shockwave balloon is coming into the vessel. And you can see if you switch now to the angio, yeah, go to angio here. Pierre, could you switch to angio? Yeah, so you see here the IVUS was a very long run. So, and finally, we predilated the lesion just to be sure we have sufficient channel to cross with a bit bulky 4.0 shockwave balloon. And then we started in this proximal segment. So this is our area of interest, and you can see this osteal lesion and this curve is stretching, and we don't have now any flow in the circ. We had partially also ST elevation. So the question is how to approach. We went used all energy, 120 impulses to prepare the circ, and in proximal part, in this proximal lesion, we use it 60 impulses. So now, after lesion preparation, patient was a bit unstable with chest pain, so we could manage this with some analgesics. So this is now the current view. So the next step will be definitely to go with NC balloon. And maybe we can show IVUS before we, after shockwave, yeah, we go to IVUS. Pierre, switch again to IVUS. And yeah, we had some improvement, definitely. Yeah, go. So you see now IVUS, that's a quite distally. Yeah, from around this point. And we have now definitely some signs, some signals that we were able to crack this fibrocalcific lesion. And not maybe sufficient at the moment, but the next step is definitely lesion preparation with NC balloon. And if this will be insufficient, then we would go with 3.5 cutting balloon. So this is our idea, because in this case, there is no option to perform a debulking technique like rotablator use or orbital atherectomy. So if you now go ahead, we go now to angio, please. And this is now a balloon in osteal LCX. Okay, Farah, you can go here with around 18 atmospheres. This is now NC balloon, Acufos 3.5. And we plan here to go with Onyx stent. This next step.
Dr. Ferenc and Dr. Srinivas Kumar here.
Yeah.
Can we have some discussion?
Yeah.
1 minute. Actually,
Yeah.
we appreciate for selecting a very complex case and for ectasia and followed by critical stenosis with calcification. I think most of the steps of predilatation, imaging, you're finished with because we're running slightly behind schedule, I think. But
yeah, you can discuss.
And the good thing is LED ostium seems to be okay here. Even if you put a crossover type across that, still LED may be okay. That's one positive thing. But what is that IVL balloon? Which size one you're taking? Later on, you're taking a bigger NC balloon now. IVL balloon size,
Yeah,
what?
exactly. Now we had a 3.5, 20 millimeters long NC balloon. And this is now the current picture you see. So we need probably to cover all this segment with two stands. We plan here to use it 4.0 Onyx stands. And as you suggested, as you mentioned before, I think we will be able to stand ostially because LAD ostium is not really involved. So if possible, if not, then we have to prolong the stand into the left main pod, then rewiring, kissing final pod. So this is what we now plan to perform.
Could you see any cracks in that intravascular ultrasound? That I was run was
Yeah, we
really
could see partially cracks in this proximal lesion, but not typical picture like in OCT. But I think this was the good choice to perform here. I was because of maybe left main involvement. If we have to stand left main, then it's probably easier to see the to perform imaging with IVUS. So we would go ahead here with 4.0 34 Onyx stand. So from my point of view, we have till now sufficient lesion preparation, and now the next step will be Onyx 4.0 34.
So what is the size of the stand? 4 into
34.
34.
Onyx.
4034.
Yeah.
34 is.
And we would start distally, yeah, this should be enough.
From doctor, the IVUS images clearly showed that there were segments of 5 or rather more than 5. So how do you plan to take care of those segments?
We will go, after stenting, we will go ahead with 4.5 balloon and then perform again imaging and can partially go up to 6 millimeters with post-dilatation.
Would it be possible to take, do you have balloon more than 5 size coronary balloon available with you there?
We have 6.0, 6 millimeters balloons here. And if necessary, we would go to angiology department. So they have all sizes of balloons. So we go now.
That is actually that first choice and the best choice is IVL. What other options in this case you suggest, apart from IVL balloon?
I think option will be to use here scoring or cutting balloon, but don't forget it is very curvy segment. So we have already, we had here in background orbital atherectomy, just in case if we will be not able to cross with 2.0 balloon, but it was possible. So you can see now 4.0 stand is crossing very nicely. We are a bit too deep now, so I would start here before this bifurcation. And patient is at the moment nicely stable. Okay, go 2 for 6. I think it's very important to start very gently, so stepwise, not to overstretch the vessel. So give the vessel wall time to stretch, not from 0 to 18. So we go very gently now for 6. We have now 6, go to 8. You see there's still some problem. Now we have how many?
8.
8, 9. And balloon is now nicely open. But I fully agree with you. We have definitely, yes, negative. So we have over 10 seconds. So negative, and we need one more stand for a proximal part. just let balloon in the position and make some safety check. If there is, if in case you would see some perforation, then we can block and go with a ping pong approach ahead, right? So this looks not bad. Definitely we will see which balloon size we need for this aneurysmatic part. And now we need one more stent to cover this critical osteal lesion. And my suggestion will be to take minimum 15.
The mid and distal portion is very well opened.
Yeah.
I was initially thinking probably just beyond that mid ligament lesion should be okay, but he went up down this before till the bifurcation. Anyway,
okay, 15.
Idea is to avoid overlapping stents
15,
in the point of lesion.
Onyx
That's why I think
4.0,
we should have it placed either distally or proximally. Don't have stent overlap at exactly the point of lesion. It is just beyond the lesion, that's okay. And the stent tracked quite well, Onyx stent was tracked quite well in spite of tortuosities and calcium. That's the advantage of having the better trackable later generation stents with thin stent struts.
Exactly. Yes, exactly.
So what is the size you're taking now?
The next size will be 4.015, and then we take 4.520 and C balloon.
What did the left main diameter was? I was showed what was the diameter of left main? Nowadays you have 5 also in Onyx, I think, if you want.
Yeah, over 5, yeah.
So what was the diameter of left main in IVUS? Suppose if it was 5, then probably.
Yeah. Yeah, can you just take a look? So first of all, stent. We are waiting for stent. Stent. Onyx 4,515.
That's what I'm asking him.
So we just can. Nee, das ist jetzt der richtige. Ja, okay. It's okay, it's okay. Nee, it's okay. It's okay. So. What we need as a next step will be 4.5 and C. It's maybe too short. So what we can use it is here clear stent function. It's okay. So clear stent function or stent boost, this is something what we use routinely in our cath lab.
It's a very good way to check whether the overlap is there or not at the distal stent.
Yeah, exactly. So I'm going a 0.5 millimeter forwards. Okay, go.
4, 6.
Pushing a bit the stent, because sometimes a stent can jump backwards.
6.
8, 10, 12.
12.
14. 16. Negative. So we go now, so we had now 16 atmospheres. Going gently back, make a safety check. Okay. And now we go as a next step with 4.5 and C balloon post-dilatation. And then I would suggest it will be time to check the result with IVUS and perform some correcture to correct if there is some malapposition.
You have a pot balloon there with how much is the length of the pot 4.5 balloon? No, we need to take a shorter one.
Now we take longer one.
Not much of stent left in the left main. You have to see how much is there.
Yeah, we go maybe now to epicaudal projection.
4.5, 10 you are taking? What is the balloon?
At 4.5 at the moment 20. Because we will.
So you'll go into the other stent also.
Yeah, exactly. There are really long stents now. And you see in this distal part, there is definitely fix here. There is definitely probably malapposition. We will postulate gently and then check by IVUS, and if needed, go ahead with shorter and bigger balloon. I'm just going a bit back, and Farah is just going now with a bit more pressure. So 10, not more than 10.
10.
This is NC balloon, 10.
What is the
10
pressure you are
seconds.
inflating? What is the pressure now? Inflating?
10, not too aggressive, because we have still imaging and can manage
I think it's
this.
still circumflex. I don't know whether it needs more high pressure, higher
He's
pressure.
preparing, he's doing it now.
We are going very gently, 14. Proximal, we take 14, it's 4.5, 14, negative. And one more 14, 16.
16.
So we have now 1, 6, 1, 8, 18.
Slipping.
And I think this should be fine. Okay, negative. Wait a bit.
Srinivas, do you go
Between
for a
patient
digital
is
optimization
stable.
in this case?
Proximal.
Before port?
Proximal optimization.
Yeah, before port, you go for a digital optimization.
That's what he did. That
Yeah.
ectastic portion he wanted to dilate before. But
Okay, it was-
left main portion you would like to dilate with a bigger balloon, because whichever is there.
No, I think we just could, we check now by IVUS how it looks, because I tried to go with a stand ostially, not to cross the left main or the origin of LAD. So I'm probably right, but I'm not sure. That's why we do imaging. And if we have a gap or over protrusion, then we would go ahead with one stand more to the left main, then port, wire recrossing, kissing, and final port.
Dr. Farang, there's a question. A distal vessel is
Yes.
ectatic. How are you going to take the reference vessel here?
Sorry, what do you mean?
Distal vessel is ectatic. Distal segment is ectatic. So what will be the reference
Yes.
diameter?
We had diameter, stand diameter was 4, right? And we believe we are now accurate with our stand size. But we checked this by IVUS. We will see. So we are now distally, and now going back to. So I hope you have this IVUS picture, and we are going back to proximal part. I think they overlap with a stand. It's now Boston IVUS HD. So you see now the stand.
stand
I
starts
think the
after.
overlap, yeah, stand overlap is nice. So at the moment, there is no huge malapposition. The stand shape is, here we have probably malapposition.
That's in the proximal portion, I think, left main.
No, this is now still
in the
distal
ectatic
third.
segment.
We are
Ectatic
still,
segment.
yeah. So this is here quite nice. I think we are very, very accurate. And now there is a bit oval shape, but lumen is not bad. And probably very soon we will see here the ostium of the LAD. Yeah, you saw we are now a bit to bit. Stop here. What? Okay, can you switch on? Können Sie da nochmal aktivieren? Ja, das grüne drücken. Da, nee, das war, ja, das hier. Okay, press here. So we can go back, Pierre, to imaging. IVUS again, because we are now in the guiding. So this is left main. I'm going a bit forward. Can you help me here?
Yeah, okay.
No, we just lose it position. Just wait a second. We were just
Proximal
in the
OST left
outer.
main is free of disease.
So we have to make this one here. Okay, so now switch here. So we are going very gently by manual.
Entrad, LAD.
Like to see focally the lesion of the ostium of LCX. Can you flash? So again, could you? Okay, switch to, I don't know why we don't have picture. Flash.
Das ist vielleicht abgeknickt. Das
Ja,
funktioniert
vielleicht we have here some technical issue.
abgeknickt.
Yeah, maybe. Okay, so can we have, so the IBUS doesn't work at the moment. That's why we cannot, so we need new one, IBUS. Yeah. So we have to be sure there is no malapposition. I do between, I'm just checking by angio, and we can see. So I think there was, can we go to, yeah, third, and Pierre, could you go to IBUS? Okay, switch. Yeah, okay, switch. So now we have IBUS picture just performant. What we could clearly see, there is very soon the stent coming, distal stent. I think here, starting just here in this position. So I think this segment is quite okay. Stent shape is round. There is, at least in this area, this is probably an aneurysmatic segment, and here we would like to have maybe a bigger balloon, 4.5, but not without aggressive postulatation, maybe 10 atmospheres, something like this. And we go back. This is, I think, very nice round shape. At least here in this area, we don't see huge malapposition. I think this is very clear. And we have here definitely round shape. Now a bit less lumen, but still enough. And I personally believe we prepare the new guiding IVUS catheter, and I would like to have 5.0 short balloon just to focus. Pierre, go to current image. So I think the good option will be to go. I hope you can see here.
Can we take one LAO caudal picture also, see how is the LAD ostium?
Yeah,
Because we did see how is the LAD behaved after stent.
And this is quite good position to check this. And we will do this. So from this point of view, we have.
I think it's quite okay. LAO cranial view, I think it also showed the separation better.
Yeah, we will do this. First, we have epicaudal projection, one more.
Epicaudal cranial.
Yeah, exactly. And this is now important to be sure the LAD is okay. If not, we have to do.
One more other thing is the guide went into the stent, Dr. Ferenc. I think a transition of the stent and stent-free area into left main, we couldn't see clearly in IVUS because the guide came straight from the stent to guide. So what is that stent-free period in the left main? Also, I think it looks okay here. That is another thing which
It
needs
looks
to be
okay.
checked.
What we can do now, we definitely should go also with imaging to LAD, and then we can have much more clear information how it looks. So we go now again with to LCX.
Dr.
One
Ferenge,
shot,
we
then
have only
yes.
1 minute left now for the live transmission. And before you just tell us what's your plan now? What you're going to do this?
We check. We can check now LAD. Maybe this is more important for you to see how it looks with LAD, and then if we have any trouble with LAD, if there are struts hanging in the ostium, then we would definitely prolong the stent from LCX to left main, then pod, then kissing with LAD after wire recrossing, and then final pod. You come with me here. So we're now going to LAD, and I think this will be also interesting to show how it looks. Okay, do you see the live picture? This is now pullback from LAD, coming back to the left main. Probably we see here, of course, some plaques, but not significant. And now we will probably have picture of struts. They are a bit hanging over. Okay, stop here. Could you go to IVUS 4 and start again? And a bit more forward. Yeah. Okay. Go ahead. Go ahead. Yes. Okay. Stop. So you see,
I think it's okay.
there are few struts hanging. What I could imagine, the good option to manage this will be to perform gentle kissing with the LAD, and then to we'll repeat the IVUS for LAD, and probably we will have very good result without overstenting of LAD ostium. But I think there are a few struts hanging, so a gentle kissing will be fine. So our next step will be post-dilatation of the stent in distal LCX, then kissing, then final imaging.
Dr. Ferenge, I think stents are well opened. Are you planning for a kissing now?
Gentle kiss, that's what. I think we need to be a little gentle, because if you do aggressive kiss again, you land in trouble. I think gentle kiss just to stabilize the struts out, and then probably that will be a good crossover. Thank you, Ferenc, I think, for showing an excellent case of ectasia and calcific vessels.
Big round of applause.
Big round of applause.
From India.
And we have seen how it can be tackled when the LAD is free from disease, probably crossover stent and good image guidance, and to demonstrate the stent apposition well and the LAD ostium. Also a few stent struts which are being, hopefully will separate it out with the gentle kiss. And finally, as we know, data is good with provisional stenting approach with one crossover.
Exactly.
I think we could manage this complex case successfully. Bed preparation with IVL was obviously very important. That's how the stent could track in easily. The latest generation Onyx also went very well. Thank you for excellent demonstration.
Okay,
and
thank you.
For your
thank
time.
you to my team, and see you soon. Thank you so much. Bye-bye. Okay, also, die schalten jetzt nach New York.
Out in the next session, I think we have one more live case, I think.
Okay, also wir bekommen jetzt wir bekommen 5-0 kurz, genau, kurz. 5-0-12, das ist das.
May we now request Dr. D. M. T. Sarvanan to come on stage and deliver their presentation.
Thank you. Thanks to the organizer for giving me the opportunity. Slides, thank you. It's not a very complex case or anything. It's just a good case for discussion, mainly. This is a 70-year-old man who has chronic kidney disease and dialysis, creatinine about 8, and he was breathless on exertion, and he was planning for a partial transplant surgery. And the LV function was good. You could ask why he is transplant at 70, but there is enough data from kidney doctors saying that whatever the age, transplant, they do well than dialysis. So he was had a angiogram done outside, which showed a LAD and circumflex disease and a mild RCA disease. So the plan was to do a pressure wire guided PCI. So that's the angiogram. You could see circumflex and the LAD.
Can you put this mic on? Okay. Just 1 minute.
Yes, sir.
Sorry to interrupt you.
Yeah.
Can I request Dr. Panja and one more senior person to chair the session, please? Requesting you to chair the session. One more senior person, if you can find somebody. No, I sit. Because that doesn't look nice when I go there. Dr. Sinha, please.
That's the LAD. You could see a tortuous LAD, but diffuse disease. Disease here, here, and bit here. And you can also see a calcification, spotty calcification almost in the track of LAD. So the plan was to do pressure wire guided PCI, and pressure wire was first placed in circumflex, and that's the lesion, and it was intracoronary adenosine, 60, and we tolerate 150 micrograms, and it was only 0.95, so that lesion was deferred. So the same wire was put back in LAD, and it was put in distal LAD. A small tip in intracoronary adenosine is the guide has to be engaged, or else the adenosine will not enter distally. So as long as it's not wedging, the guide has to be engaged like this. So a check injection to check the position of the guide, plus also the position of the wire with a normal contrast will be very useful. If you're doing RFR or IFR, you have to flush the contrast and wait for a few minutes and then check the IFR of RFR. If you're doing a pressure FFR, there's no need. So adenosine was again given, RFR was 0.86, and I believe FFR more than RFRs, but I just document RFR every time. So adenosine was given and was a good hyperemia achieved, and it was 0.67. Quite ischemic, there's no doubt it's ischemic. Then I used RFR for pullback. So how do you pull back? You put the lesion here and you move it one quick action to see and stop there, and then you will go gradually and then go across the lesion, because you're doing a pullback to see which area to be stented. So you don't need to be very slow. You just need to be pulling back. That's the one here. Pull back here and stop, and then wait, and then pull back across the annulation. So this was the first pullback from distal, from here to here. Small step was there, but from there to there, it was a much bigger step. And so decided to fix the proximal part. IVUS was done. I will just quickly go to the still images. So IVUS in this distal area was clean vessel. Plaque was starting here. And there was more calcified plaque in the distal area. And there was one normal area here. So as intended, I was planning to do only from here to here. So there was one good landing area. And there was more calcified plaques in the across septum. And that was the most tightest part with calcium. And the diagonal, you could see very nice, clean diagonal. That was LED. So I didn't wire the diagonal. So this is the proximal landing zone. So this was the intention of planning. So from here, good landing zone to good landing zone there. It's about 2.9 here and 3.25 there. So took a, dilatation was with the NC balloon at 24 atmosphere, 2.5, and had a reasonably good dissection. You could see the flow was compromised. So, and then stent was taken. Took a biodegradable polymer coated stent because we are planning to stop clopidogrel shortly. So in this situation, I use biodegradable either Synergy or Ultimaster type stents, which are reasonably good in healing. So here a stent was deployed, good expansion, and then 30 atmosphere inflation, and was good angiographically. I'll just quick shift. So this was distal edge, and this was the worst area. But here you can see there is a little nodule there. I don't think I could get anything better than that. But it was a reasonably good, acceptable lumen area. And that's across the diagonal. Although it looked pinched, the diagonal looks reasonably okay. That was proximally okay. The stent was itself okay. Keeping that same wire there, I put a pressure wire there, distally. And the pressure wire is a 0.83. Normally, when you stent, you aim for at least 0.94 to see the stent, but here it's not the looking the feedback of stent. I'm looking at the second lesion. It was not ischemic. Here, normally situation, I may possibly have gone for another stent, but here I want a very short DAPT because if I want to cover this area, normal to normal, in another 38 mm or 2.5 mm stent, it will not be good, and it's elective patient. It's not a ACS. So I deferred that lesion, decided not to stent. So the diagonal was done because a little pinching, although it didn't have much concern, but I just checked it, 0.98 as expected. It was not a problem. So this was the final angiogram. Reasonably deployed stent there, and plaque here, plaque everywhere, here and there, but not a major issue. So that's the end result there. And yeah. So post-procedure, this was done about 8-9 months ago. He went home on clopidogrel and aspirin twice daily for 2 months. And then clopidogrel was stopped after 2 months. He was continuing an aspirin, 75 once daily. 2 weeks later, he went for renal transplant surgery with aspirin during surgery time and uninfilled surgery. And he came recently follow up and is doing well. LV was good, asymptomatic, creatinine is normal. So this is kind of strategy because we have a large renal transplant unit, and all ischemic patient, definitely if it's proven to be ischemic, has minimal short stenting with image guidance and a short DAPT, and they go for surgery. I have about 22 patients with this type of things, and they're all doing very well, and none of them had any issues when stopping clopidogrel. So message was pressure wire and image guiding this best outcome in the coronary intervention. Thank you.
Thank you. Very excellent presentation. So you see kick of CKD, and with the 10M lesion, really the physiology is very important for the intervention procedure. And deployed the stent also. So thank you very much. One, Dr. Srinath, took any comment?
For a patient who is planned to undergo transplant surgery, 70-year-old male patient, coronary angiography with physiology is a very important affair. And it's a good thing to see that the circumflex was not, visually it appeared to be somewhat significant, but the FFR came out to be negative. So that was left alone and has an uneventful post-transplant period, because the post-transplant period is a very stormy period where DAPT is stopped, only single antiplatelet is used, and a lot of medicines are used. The patient is in a highly inflammatory state. And thankfully he has, due to proper arrangement, he got a good recovery. Thank you.
Thank you, sir. I want to comment about one previous session. There was equalizing the guide pressure wire in the aorta. When there's aorta ostial lesion, whether you should do equalizing in the aorta or can we do it in the guide. Dr. Madhu asked, and I initially, almost everybody does it equalizing in the aorta, but lately I'm using in the guide. Although you have wedge pressure, you can equalize few inside the guide, because the machine just simply equalizes the blood pressure. It doesn't know whether it's aorta, it doesn't know it's a wedge pressure, anything. So equalizing a wedge pressure inside the guide is equally acceptable, and there is no issue at all, because sometimes when you engage the guide, it wedges, you disengage, you put the wire in the aorta, and then re-engage, it's all become too cumbersome. So you engage the guide, even if it's wedging, it's fine. You equalize the guide, so equalize the pressure, few inside the guide, and that's perfectly acceptable and nothing at all. It's scientifically proven, no problem at all. Thank you, sir. Thank you very much, sir.
Anyone? I don't know the procedure. So, okay, thank you very much indeed.
Topic for this session is live case complex coronary. The facilitator for this session is J.S. Dugal. And the chairpersons for this session are D.P. Sinha, R. V. Shiv Kumar, Vijay H. Ran, Pramod Kumar Uchulakanti, Ajit Mullah C.S., Pratap Chandra Rath, P. Shanika Sundar. And the panelists for this session are Dinesh Doshi, Refai Shoka Khadi, Mohan Mani, J. Harish Kumar Ayankar, Shyam Sundar. And the discussants for this session are Kaushal Thakur, Rajkumar Bhattacharji, Ritvik Ghosal, Prithviraj Bhattacharji, Anish Kumar Khan, Shilanjan Roy, and Sakthi Velha.
Kerala. Okay, we're live, so ready to go when you are. Just tell us when we're tuned in.
Just wait. Welcome to this interesting live case session. And since there are few chairpersons are not there, I can see two of them right in front of me. Raj?
Sridhar.
We're on. We're on. Hello, NIC 2024, can you hear us? Hello?
So, hello, are you?
Hello.
Are you ready to telecast?
Oh yeah, we are. Yeah, we've been ready for a while.
Yes,
No
but
problem.
we can see your. We can't see you.
You can't see?
Now we can see you.
There we go. Excellent.
Yeah, there we
Good.
go. So
Take that
this
back.
is the first session.
Okay.
I am Dr. Vijay Bang, the chairperson. I will introduce you the chairperson. Dr. Sinha is with me. He's our Secretary of Cardiological Society of India. Dr. Raj Dave is there from USA. He's also chairing a session with us. And Dr. Pramod Kumar is also there to chair the session.
Dr. Refai Shaukat Ali from Chennai Apollo.
Yes. So we are
Nice to see
there,
you.
and we would like to hear, you can begin with your presentation of your first case.
Thank you. Good evening, everyone. At NIC, it's good morning from our side here in Canada. My name is Sanjay Kara. I'm one of the interventional cardiologists here at the Petermont Cardiac Center, Toronto General Hospital. I'm here with my esteemed colleague, Dr. Vlad Javik, who, as you all know, is an expert in bifurcation PCI. And we're here to present this complex case to you. To start out with, I'd like to thank you very much for the generous invitation to join you, and thank my team for coming in this morning at 5:30 to help put this case on for you. We have Lance Ng, who is our interventional fellow. This is RJ, that's Lauren. Our MRT here is Yelena. Out on the keyboards is Francesca, and circulating in the room here is Ayelet. Also, many thanks to the rest of the cath lab team throughout Toronto General and our cath lab manager, Lindsay, for really helping to facilitate this. Maybe we'll switch over to the slides and we'll show you what we have for you today. We did get going given the timing, but we floor restored everything to show you. So let's go forward. Next slide, please. So this gentleman is 94 years old, which is obviously fairly old for complex intervention, but he lives alone. He's fully independent of his activities of daily living and instrumental activities of daily living. So does his banking, grocery shopping by himself. He has the usual cardiac risk factors, and he presented to hospital 2 weeks ago with a history of dyspnea, with heart failure on arrival and a troponin rise with a component of chest pain. So it was sort of one of those heart failure plus minus ACS type diagnoses with an echo ejection fraction of 48%. But in the setting of moderate AS, severe MR, and then on dobutamine stress, very limited to no contractile reserve. Next slide, please. So he was diuresed, and then this is to show you his films. This is his right coronary artery. As you can see, lots of calcium, lots of diffuse mild to moderate plaque, a focal critical lesion towards the distal RCA. Next slide, please. And then these are his left system shots. So initially on the left side of the panel, you can see in this AP caudal shot, it's a little hard to appreciate the severity of disease at the circumflex. There's clearly a lesion in the proximal LAD, just beyond some tram-trax calcium in the mid-vessel. And then in the right panel, you can see in this slightly more LAO view that osteal circ is in fact super tight. It's, you know, sort of a 95% calcified lesion. Next. This is the cranial view of the LAD that shows you how, you know, how deceiving some of the caudal views or some of the cranial views can be with respect to the proximal vasculature, because you don't see much here, but you see in the caudal views how bad it is. You've got severe calcification throughout the LAD, 3 very large diagonal branches, a 60% lesion that's calcified in the mid-LAD. And then on the right panel, you see the other challenge, which is the cobblestoning of his iliacs, the typical findings you might see in a 94-year-old when planning a case that might need some sort of hemodynamic backup. So next. So with that, these were just some basic discussion points that we thought we would give to the panel, and we turn it over to you for discussion and your thoughts on how we should proceed.
Sanjog, Raj Dave, how are you?
Hi Raj, it's nice to hear from you.
Good,
Hi,
Raj. Nice to see you. So, you know, his EF is 48% and the iliac arteries look really bad. So why not to try to do this without hemodynamic support?
That's exactly the same thought we had, and so then we did a right heart cath. Do you want pressures? I can give you his right heart pressures. His CVP was 7. His PA pressure was 48 on 11. That went up quickly to 60 on 16 once we got the guide catheter in. His PA saturation is 47%. Just leave it here. And his hemoglobin's 8. So that gives us a total cardiac index of just south of 2.3 off support.
Okay.
Yeah, very good morning, Dr. Sanjog Karla. This is Dr. Sridhar Kasturi.
Good morning, my friend. How are you?
Yeah, fine. Nice to see you again.
You too.
This is a severely calcified coronaries, right coronary very, very tight. Even LC exhaustion too critical. Suddenly LC closes it. There could be sudden hemodynamic compromise. and which is the vessel which you are going to do. Yeah, almost porcelain aorta. Entire aorta is calcified. Root, everything is calcified. Even aorta iliac junction, severely calcified vessels. So in these cases, what is the block modification strategy you are thinking? I think LCX difficult to cross with IVL. Rota has to be done. Right coronary also. I think first thing, are you going to do the right coronary to give some backup to the left, and subsequently are you going for which is the vessel you are going to tackle first? Are any MCS support are you planning for this patient?
Great thought. So Vlad and I, and I'll ask him for his comments. We had discussed this. I think our initial plan was to go with the RCA first to give ourselves some hemodynamic backup. But in engaging the left system and getting our initial pictures, we felt that the LAD lesion was about 70%, so it wasn't ultra critical. And with good rota technique, careful wiring through the circumflex, we thought once we got access to the circumflex, the critical lesions on the left system would be essentially post-luminal gain. And then we'd give ourselves whatever sort of berth we needed to be able to get the job done on both sides. So though I think there's a very solid rationale for doing the RCA first, I think it's reasonable to do the left system first as well, so long as you can accommodate the patient's hemodynamics. The iliacs can accommodate perhaps a balloon, because his culprit, the problem spot here, the biggest bang for your buck, if you will, I think, was at the left main bifurcation.
I am asking because there is a valvular lesion. MR is there, AS is there, moderate, and previous heart failure is there. So any PA pressures are you checking before procedure?
Yeah, we have a PA of 60 on 16 with a mean of 34, a wedge of 7, and a CVP of 7. And interestingly, the mean wedge was 25 on a CVP of 7, all by a big V wave.
There's
all
one
from a giant V wave from
Sanjog, Dr. Bang here. Sanjog.
Hi.
Sanjog, just want to make a point that LAD does not have any critical lesion as such. So hemodynamic support may be, withhold for a time being and just try. What is your plan?
So why don't we show you what we are so far? We can switch over to the floor for a quick second. So there's his wedge. Yeah, so his current wedge right now is 18. That's down from about 24. So this is the challenge with calcium and angiography, right? So you can't really be sure what you're seeing. So we'll show them the floor here for a second. This was the right heart cath, and we actually chose to put in a balloon pump, and his right iliac accommodated the balloon pump without any difficulty. And so what I did, this is your initial setup shots. So you can see that super tight circ.
And actually, in this view, the LAD does look tight.
It looks pretty tight
and very calcified. It looks like there are nodules there. We'll show that right away with the IVUS.
Right. And so what we ended up doing was, so this is a Xi'an black wire with a Turnpike LP microcatheter that was actually pretty easy to get into the circumflex, right? As many of you where we've worked together, I've said many times, it's better to be lucky than good. I'll take lucky any day of the week. Okay, so interestingly though, when we tried to put the microcatheter forward, this is just the Xi'an black wire going all the way down. Okay, when we put the microcatheter forward, it didn't go all that easily. We actually backed the guide out. So there was a very calcified lesion there. So this was the microcatheter that was down once we were able to push it through. And then this is a rotowire that came down. And there's a single operator rota that we did that we can go over if you'd like. And this is a 1.5 burr being delivered to the tip of the guide. The speed we chose was 180,000 RPMs. And this was what it looked like going through. So there was 2 or 3 runs there, and then finally it popped through. And we were pretty comfortable taking the rota back and forth because it's a decent sized vessel. There you can see that the guide even backs out. And then you'll see that the subsequent runs we did, we used the rota wire bias to our advantage, right? So you can see that the guide's pushing back at that wire bias. Then we changed the guide angle a little bit so that the wire occupies the lesion differently. And then we changed it yet again, right? And you'll see that with this push on the guide, it's pointed upwards. Now the wire comes off the greater curvature onto the lesser curvature, and then we're getting another part of the lesion, right? So really, opening up the calcified segment right at the ostium of the circumflex. And the beauty of the rotopro system is actually when you've pulled the burr back into the guide, you know, this is just a quick puff after having done the rota. Okay, you can see that there's pretty good luminal gain right at the ostium of the circumflex. That you can actually then push the Dynaglide and the brake defeat buttons at the same time, and you can just pull the wire back, and this is rewiring into the LED with the rotoburr inside the guide. Okay?
Okay.
And that's
Sanjog, how about considering orbital atherectomy for osteal LCX lesion? Because then you can cut to and fro.
Yeah,
so
it's
you
a
would
good
have
thought
got
as well.
a better lumen, larger lumen.
Yeah, I do a good deal of orbital atherectomy, and I've proctored for them as well. The truth of orbital atherectomy is it's an excellent device. The problem is if you've got a super tight lesion, your orbital won't pass. And what you end up getting is orbiting inside of the ostium of the vessel, and you end up coring out that part of the vessel. So these are these super tight lesions, you need a front cutting tool, right? If you core out that vessel, you effectively create an Ellis class 1 perforation, which happens with atherectomy from time to time. So you do have to be aware that not all of these devices, you don't replace one with the other per se. I think your points of big lumen, lots of calcium, big luminal gain goal, these are all good points. It's just for that particular lesion, you need a front cutting tool. And the proof was that even when we put a 1.5 burr there, the guide got pushed out, right? So we rotated the LAD, and then we actually rotated the mid LAD as well, right? And it was pretty impressive how much, as you can see there, it's getting stuck at the proximal lesion. It was pretty impressive how much calcium there was in the proximal part of the vessel. But we took our time, right? This is a hemodynamically tenuous guy. He's elderly, and we wanted to make sure we got him a good result. Recognize that dissections are pretty rare after rotational atherectomy, so we did it in the mid LAD as well with the intention of potentially a DCB there if he can take that. And now we'll reconstruct the proximal part of the left main.
Maybe we're past the mid.
There you go. Okay, so this is now post-rotablation in both directions. Good flow with a PA pressure of 62 on 16, aortic pressure of 147 on 37 on a balloon pump at 1 to 1.
I think there's another road.
With no noradrenaline anywhere. This is just that mid LAD. This is sort of a lower speed wobble run that we did. Okay, and then a little bit more. Yeah, see, he's getting caught again at the LED. Yeah, there's a lot of calcium there. I was impressed by it.
Yeah.
Okay.
Guys, what's the bifurcation stent strategy after the plaque modification?
But before that, we'll have to do a cutting balloon?
I think before that we should do an IVUS and figure out what we're dealing with.
So I have it on the LAD right now.
Yeah. So why don't you
Sanjog, you may require IVL for the osteal L6 lesion because it's not opened up here.
Yeah, let's see. Let's see
first.
Okay. So I think that
let's go to the
rather than
cranium.
guess,
Go to the cranium.
Yeah, rather than guess, let's measure. Are you on the LED?
I am. Strategy because if the fractures are there, no need to go ahead with IVL because
precisely.
Modification is there.
Right. The idea is to prepare the plaque. I couldn't agree more. If you got fractures everywhere, you're not really going to achieve anything else with IVL, right? If you don't have fractures, that's certainly a reasonable option. Okay. So, okay, we'll come down to the
just 1 sec. Okay.
Actually, choosing the rota is the ideal option. L6 is too critical. If you use the orbital, it can lead to spiral dissection. It moves along the periphery. It may not enter the tightest portion. It can create the spiral dissection at the LM junction. That is a hazardous. Though sometimes it can cross. Sometimes if it is able to cross, you can do the reverse cutting, not forward cutting. That also it can be done.
Okay. And can we just sneak in here and we'll feature the IVUS now?
You can't see the
For the
IVUS
tight
images.
lesion,
Yeah, you're going to see it right away. They're going to
discussion
you
was
focus it
necessary.
on that, please.
Can you focus
Turn
in
it
on the
towards
IVUS
a
a little
bit more.
Just turn the screen towards the camera a little bit.
Okay, perfect. Good.
And that's good. Can you all see the IVUS there? And we'll just
It's kind of bright. Looks kind of bright. Can you focus in on the IVUS a little bit more of a close-up, please? Can you zoom in?
There we go.
You can't zoom in.
Okay, there we go. So you see that we're starting to pull back.
Please.
Okay. And we're going to learn a lot about this now. There, you've got cracks here. Okay? Cracks. Crack. Crack.
Yeah, good.
There's one crack there.
That's just
but
from Rhoda.
That's fairly thick calcium.
That's just from Rhoda.
Okay? There's no cracks here, so we'll cine there. Or whatever, we'll flow restore there, yeah. So that's an area that we may have to subsequently treat with either a larger burr or with IVL. But the goal is not like, that's the whole point, right? Is we don't guess, we'll measure and
What was the size
just make
of that bar? 1.5?
1.5.
This was a 1.5, it was small, right? Because it was the initial sort of sweep. So there is certainly room to take a bigger burr too. But you can see there are cracks all over the place. This is the osteal LAD coming back into the left main.
There are a lot of
And there you go.
Yeah, I think 2.0 bar in the LAD with a couple quick runs will really do a nice job with it.
Also reasonable.
Sequential.
Also reasonable.
Higher bus size. It's a good idea.
IVL would be better. IVL would be better idea.
Go ahead. Go for it. Okay. Oh, sorry. Yeah. Okay. And we're going to just IVUS the circ while we're at it and get an idea of where we are.
What is the strategy next, Sanjog? Are you planning
I'm
to
just
use
going to IVUS the circ. We're going to IVUS the circ. I think the LAD is obviously going to require some more plaque prep if we end up dealing with the mid-LAD. But I think it's worth mentioning that, you know, the bad lesion in there is just at the prox, right? And this man is 94 years old, and he's got a big open LAD in that section of tram track calcium. So I don't think it's unreasonable just to leave that. I don't know what the panel's thoughts are.
Which, the mid?
Yeah.
Given his age and all the comorbidities and valvular disease, the less complex the procedure is, the better.
I couldn't agree more. I couldn't agree more.
But the left main bifurcation is complex.
I think considering his lumen area, would it be a good idea to DCB and come out from the LAD and just enter across from left main to circumflex?
Loving that idea. I think it's a very interesting idea. We've been kicking around the same idea the last couple of hours.
Sizing the bar is not ideal option. Why? Because already high risk patient, morbidities, more debris, more slow flow, no flow. Instead of that, if you are to upsize, go with IVL because slow flow, no flow less. Otherwise, simple cutting balloon and.
Yeah, we're right there.
Oh, look at that.
That was beautiful.
Yeah. So what are the panel's thoughts on that, IVUS? Sridhar? I know you're an IVUS expert, so you can give us a lot of feedback here.
Yeah, better to go with some Wolverine or angiosculp, high pressure inflations. Most of the time.
I'll show you the circumflex IVUS, and I'm not sure if there's much else that's necessary beyond an NC balloon.
But I think L6 is opened well. It's a
Yeah,
nice.
look at this.
Yeah.
So this is fine.
Still very
And
severe
then-
calcified.
CT. There. So completely cracked.
Yeah.
This is coming back
Nice
to the left
fracture
main.
is there. Nice fracture.
Right?
Cracks are there.
There isn't really much to do beyond.
I think a 3 mm NC balloon would do the job more than this for the circumflex.
Yes, I actually already did that. I actually took a
Cutting
2.5
balloon is
and
required here.
pressure.
I would.
You know, you could. The only thing that gives me pause. There is calcium, and then there's a bit of fibrotic plaque there too. So I wonder about maybe taking a cutting balloon. But I mean the 2.0, the 2.5 went up so nicely, yielded fully. I'm pretty comfortable with this at this point. I think it's just it's time to stent this.
I agree. I think stented. Yeah, I think it's fine. It will expand well.
Okay. This is the size of your circ. It's not small, right? It's 28. And going back to the LAD, let's discuss sort of what the approach is here. Because I think I'm in the camp of keeping this simple, right? We wrote it through this, but there's no dissections there. Okay? And if you look here, this is a tight lesion. I think it doesn't make sense to do a proximal lesion if you have this kind of lesion beyond it because you're outflow limited anyway, right? This, I think, will require more prep, right? It looks like a tree trunk, if you will, with so much thick calcium everywhere. Yeah.
Sanjog, I would favor doing Wolverine to circ ostium. I would do that.
I don't think that's unreasonable. I think that's something that we were kicking around here. Can we get a 3.0 Wolf, please? I think a rotocut strategy
3-0
there
Wolverine,
is
please.
very, very reasonable and gives us
3-0 Wolverine.
gives us a lot of safety in terms of how to approach and make sure that we've got appropriate expansion. The other nice thing, I've had the privilege of working in many labs in India, and I thank you all for that privilege. One of the things that I like most about doing these complex cases, as you'll notice between Vlad and I, is we switch back and forth seamlessly. So nobody gets tired, right? We did very long cases yesterday. The morning case was a left main LAD CTO that was retrograde, circ subtotal RCA CTO on an Impella in a young man with an EF that was in the 20s. It was a long case, right? But with two operators, you go back and forth, you're not overly tired. The next case was a 70 millimeter super calcified mid to distal right CTO, also epicardial retrograde on that one. And it was a very difficult case, but with two operators, even at 8 o'clock, it was not painful. Right?
Sanjog, you have 8 minutes more. So
okay.
Can you just tell us the strategy? Your bifurcation.
So our strategy is going to only be a DK crush at the left main. Okay.
That looks good.
It's going to be important
idea.
to prep the mid LAD because there is still fairly heavy and thick calcium there. The preparatory strategies at this stage are probably going to be either 3O please, high pressure balloon or IVL in the mid LAD because we've already got wires down both vessels. And I don't want to deal with having to put a 175 burr in after cutting balloon osteal angioplasty to the circ. Because I'll have to lose that wire, right? And I think this is where, in these severely calcified lesions, you have multiple strategies that can win together, right? They all have their own role.
Correct, I agree with you.
So
DK crush is a good idea because it's true bifurcation. So
it'll be a long step.
It's not just a true bifurcation, but it's a complex true bifurcation.
Yeah,
right?
Complex true bifurcation, I agree.
Yeah.
Calcified lesion.
And complex by progress criteria actually. So it truly is one that has good evidence base to do as a 2-stent and specifically DK crush technique.
Yes, that's the preferred technique for true bifurcation.
Doesn't want to go that easily. That's good. We're good.
Yeah.
Okay, we're going to just take that wolf at the ostium of the circ. 2, 4, 6, 8, 10, 12, 14, 16, 18.
What is this, NC balloon or cutting balloon?
This is the Wolverine wolf. And we're at 20 atmospheres, and that looks lovely. Would you agree? That was a Wolverine.
Cutting balloon.
Take that wolf right there again.
Yeah.
Okay,
Okay, we'll go 18 again. 8, 12, 16, 18.
20. And then if you want to look here, the other thing that's important on this is when you come down on a Wolverine, we've got athertomes deployed, right? So you can come down quickly to 6, and then you go slowly down from 6 to 0 so that your athertomes fully wrap. That allows you a lot more ease when you deliver and re-deliver the balloon, right? And it doesn't damage the other intima. So you can see now
Goes beautifully now.
It goes no problem, right, through that calcified lesion. This is a real NC emerge balloon.
Why don't we do this in the LAD?
We can do that in the LAD.
Yeah, let's do this in the LAD.
Why not?
Are you going to use the same cutting balloon in the LAD, ostium?
Yes, we are.
Why not?
Yeah.
Why open a new one when this one will do? Perfect. Thank you.
Actually, adequate preparation of the side branch is key for success because if under-action is there in DK crush, MACE rate is almost 42% versus 6%. So there we should not leave any scope for under-expansion. Lesion should be prepared adequately. So that there is
the biggest trouble is that circumflex ostium, isn't it?
Why don't we disconnect it? Oh, it's okay. Not a problem.
So that's good. We'll just deliver here and then.
Okay. Nope.
I have one more question, Sanjog.
Yes, sir.
Negative.
How are you going to confirm that you are crossing through the proximal strut?
How will I confirm that I've crossed through the proximal strut?
You mean in the DK crush after you crush the side branch stent? Is that the question?
Yeah, that's the question.
We tend to look at it in different views. I don't think we need to do imaging necessarily, but
There's a bit of
I think
cramp in the
we
ground.
also have, we also have stent boost.
That's not
And,
gonna work.
it's not working?
It's not going to go. There's wrap in the guy.
Okay, okay.
Just
okay.
take. Can we get a long NC balloon, please, first for the LED? Like a 30.
3030.
We have 3030, 15. Yeah, I'll take that first. We haven't even NC'd that yet. So.
No. We did. The
Not
prompt?
the LED. Not the LED. We
Right.
just did this, sir.
Right, right. That's
so-
why this isn't going.
Yeah. You were answering that question, Vlad?
I was.
Yeah. So we use high-level fluoroscopy, so you can use stent boost, these kinds of things, just cone in, and then if you're really, really stuck, you use IVUS across the other branch, and you can see where the wire is going in. And that becomes quite clear.
Sanjay, while you're getting the balloons ready, I just want to make a comment, if it may, just a little controversial. I mean, this
Yes,
guy
sir.
is 93, has got a good blood pressure, I assume. And we're going to do well, I know it's a complex bifurcation PCI now, but initially it was planned to be a left main to circumflex and possible mid-LAD. I just wonder whether IABP preemptively is important here. One of the things I tend to do nowadays, I just put a 4 French sheath on the left, whatever the access site is.
Oh, yeah,
In case
yeah.
if you see compromise in the hemodynamics, I tend to put
Yeah.
IABP rather than prim. Is there
Listen,
any
I-
evidence to suggest in protected PCIs, we need to put IABP earlier on rather than during the case? Is there any evidence about this?
So yeah, there is. So I have a couple of comments about that. First,
will as well.
yeah, and first I think we knew that we were going to treat the proximal LAD as well because there was that tight lesion that needed rota.
Yes.
So this was going to be a left main bifurcation with a long stent across 3 diacs.
What we want
So
to
that's-
see is the decay
so-
crush fast as possible.
Yeah, we're not going to get that to you in 8 minutes, I assure you.
What is your plan for RC? Are you going to do it in this same sitting or are you going to do
We'll see how things go, probably. But just to finish answering the question that was asked, there is evidence, right? That evidence was in the BESIS trial, where a large segment of patients had bailout balloon pumps put in. Those people, that's one of the major criticisms of that trial, actually, is that they didn't actually put in hemodynamic support up front, put it in too late. And by that time, you were already in
That
trouble.
was in the control arm. And in spite of that, there was benefit at
Yeah,
5 years.
Absolutely.
Okay, ready?
Yeah, up you go.
Okay.
And-
Mid LAD.
And what we learned was
3030.
also that there was less VTVF, less CPR in that group. Done. All right, that expanded very nicely.
And so, also 94, the myocardium has much less reserve. The senescent myocytes don't work as well, don't recover as well. What also gave us pause was a severe MR. And for these reasons, I often do what you do as well. I often put a 4 or 5 French sheath in the artery, but in this case, because of the hemodynamics we had, because of the overall situation, we felt that to put the balloon pump in up front was the ideal thing.
I mean, I think your question's a very good question, right? Like, this is a constant debate, right?
Yeah.
Even in the Impella literature, it starts to show that the earlier you put it in, the
LAD
better off you
may-
are, generally speaking, but
18.
it's the messy data, right? It's not clean data because that's not systematically studied. But I think you can actually rely on the BESIS data set because it was systematically studied. It was a randomized trial.
And whereas that study's criticized as being negative, it wasn't
not.
negative.
It's
It
not. It was
absolutely was
positive
not
studies,
negative.
yeah.
Even at the 6-month mark, you already had a separation of the KM curves. And as Sandroke says, the complications were much less frequent. It was
Yeah.
10% versus 1%, I
Yeah,
think,
I mean,
with interprocedural serious complications. So,
We know that sometimes you got to wait, right? Look at Stitches, right? Stitches was negative for the primary outcome at the beginning, but you wait enough time, there's a mortality benefit, right? So it's an important piece. Okay. All right, we'll take a little picture here, show you where we have, and then we'll get going with our DK crush. All right, ready? Go.
We
Looks
have
pretty
a
good.
time up for you. So if there is a time after the second case, we will come back to you.
Sure.
We'll try to come back.
Sounds good. Very good. Sounds like a plan.
Finally, before we
Can I
close,
have a
you
regular
got a
Xi'an
good
wire, please?
results with this. Would you take the balloon out in the cath lab or would you send the patient to?
That's also a good question. So our approach to weaning, we actually have a weaning protocol in the institution, but our approach to weaning is largely driven by hemodynamics, right? So we look at his starting PA saturation, we look at his starting PA sat, we look at his starting wedge, we look at where he is, we look at whether or not they're on any support. What we've learned is that just the blood pressure is not an adequate measure. of whether or not you should keep someone on hemodynamic support or not.
Yeah.
The blood pressure does not take into account the intracardiac pressures, doesn't take into account any of the pulmonary capacitance, none of those things. And so we do have to be.
Sanjog and Vladimir, good job.
Excellent. Thank you so much.
Give them a big hand, please. Applause.
Thank you. Thanks, everybody. Thanks very much.
Thank you very much. We will see you if time permits.
You bet.
Okay, just generous, but it's.
May we switch to the another case? Yeah. Yeah, Ziad Ali is here. Hi, Ziad. This is Vijay.
Hi, guys. How are you?
All well?
Good morning, Ziad.
All well, thank you. Can you hear me?
Yeah, we can hear you. We can see you as well.
Great. So we're going to share with you a case in the box. The main reason is, as you know, it's the 4th of July in New York. So it's very hard to get staff into the hospital. It's a big, big national holiday here. But without further ado, I'm going to share my screen. And then what I'm going to do is actually start our case, which I think you'll all find very enjoyable. Can you guys hear that okay or no?
Yes.
How's the audio for you guys? Okay. Are you able to hear it now? Wonderful. So we have an interesting case for you.
Very nice
This
video.
is a severely calcified right coronary artery. Typical thing that we'll see, and this is going to be an OCT guided orbital atherectomy with a lot of the tips and tricks.
For orbital atherectomy. Not unusual, a big, severely calcified right coronary artery. It's got a couple of distal calcified nodules. The midsegment is heavily diseased. Alan and I discussed whether we thought the OCT catheter might go and might provide us more imaging for the M of NLD max, but to be honest, I'm not sure. It's pretty tight. So what we're going to do is go ahead and do orbital atherectomy. It meets every criteria, calcium on both sides of the artery. Alan, just
let me stop this here. You guys see how it, even without moving, you see calcium on both sides of the vessel. So that's the angiographic definition of severe calcium.
So I went to 6, and I'm going to get Alan to just do a cine of this. When the angiogram is completely still, okay, like that, and you see calcium on both sides of the arteries, that's severe calcification. When you see calcium on both sides of the artery only when it's moving, but not when it's frozen, that is moderate to severe calcification, okay? And then moderate would be calcium that's on both sides of the artery, but not in the lesion. So this is severe calcification because you can see when we freeze it, there's calcium on both sides of the artery in the mid part of the section of the vessel, and that's probably about 8 or 9 millimeters, okay? So it meets criteria. So next up we're going to do is we're going to set up the orbital atherectomy system.
8 or 9 millimeters, you mean in length?
Of the severely calcified segment. Just
Yeah,
the
at least,
transcript.
no?
Yeah, at least.
Yeah.
Maybe more. Okay, so as you know, orbital atherectomy comes in 2 flavors: the classic crown and the what I like to call the house, right? At the eccentric crown, the only one in the U.S. is really the. Okay, so this is what I typically do, right? I actually open it upside down, all right? And when I open it upside down, I just put the whole thing open with the tray, and all my gear is out.
Let me have the.
Okay.
And
So this is what you've got that comes in the kit. You've got the electrical cord. As you know, this is an electricity-based device,
CSINIC.
not a gas-based device. And so what I do is I take these rings off which are designed to, create a lot of stinging on your fingers. I think that's why they made them like that. I think all the interventionalists can resonate with that. And then you just take your black cord, right, and you throw it over. All right? So that's not my problem anymore. So that's number one. So the other things that are on here are, of course, the liquid line. So this is the line through which the orbital flush is going to go through. And it comes with a connector. Can you show my hands? Perfect. Okay. And I just pass that over too. And what I typically like to do is I like to put a stopcock in the side. Okay, so can I have a high pressure stopcock? And the reason I like to put a stopcock is because it just makes it very easy. Oh, here's one. Perfect. It makes it very easy for me to turn on and off and not make a huge mess on the floor. Okay. All right. So what I typically do is I will leave the stopcock off until the fluid starts running to get all the gas out. We'll let that run. And then what you've got is you've got the Diamondback system yourself. Diamondback is a 1.25 millimeter crown. It's got two run rates, which is 80,000 RPM and 120,000 RPM. And it's got a system called Glide Assist, which is actually 40,000 RPM. And 5,000 RPM. And to get to that, all we have to do, which is kind of the OAS version of Dynaglide, is we just press and hold the first button, and then it's going to start flashing, okay?
Yeah.
But let's go back to our first step here. So what you're going to see is the liquid is starting to come out, okay? You can see this here. It's draining. All the air is coming out. So I'm just going to let it drain. Okay, and now I'm going to go on here, and what we should see, what we want to see, is we want to see this start dripping onto my hand, which it is, which means now I'm flushed. Now the next step is to wait until.
Hand it over.
Have you wired it with the Viper wire?
Yeah.
Okay, all right. So now, hang on, we're not going to hand it to you yet. Right now, this is the advancer knob, right? So as you can see, if I pull the advancer knob back, and we want to get to about 1 finger breadth, we turn, and now it's locked, okay? And then if we want to test, we're going to test on the wire. And so all I'm going to do now, while the liquid is on, is I'm going to hand it back to Alan. The brake is on the back. I'm going to release the brake so that we can feed the wire through.
So that's one of the important things to note about this device, which makes it so user-friendly, I think, is the brake. It's like really intuitive. It's easy. It has a brake at the end. You don't have to put on, the torquer to kind of secure the wire and so forth. It's just very easy. So obviously, right now we just want to pass through the device, so the brake is open. When the spinning occurs, obviously it's closed.
You open the OCT? You're going to do that?
All right. So why don't you put the brake on? Why don't you lock it?
Okay. So I have the wire on the back now. All right. So I can see it right here. I'll turn on the brake, and now we're going to do some testing, right? So the first thing we'll do is we're locked, is I'm going to press this button, and that is 80,000 RPM. Okay? Then I'll stop, and then I'll press the high speed, and you'll hear the change in sound. So
now,
it's like
in all fairness, except for demonstration purposes, at least I only test like once, make sure it works, and put this thing on. But it's nice to do that right now. But generally speaking, you don't need to go through this.
Okay, so what we'll do is also, just for your for demonstration, is I'm going to press and hold the front button, and you see that it started flashing. If you can see that it started flashing, now listen to the sound. There basically is no sound now. This is your Glide Assist.
Tesla mode.
Okay, this is Tesla mode, exactly. Now, we're going to go in the body. So the way we're going to go in the body is I'm going to lift the brake, lift the device, and Alan is going to advance this just like it was like an over-the-wire balloon.
1 second.
So you're on Glide Assist?
I want to just go forward a little bit. Brake go. And then want to come around the bend.
It might not come around the bend. You might have to Glide Assist a little bit to get it down. Okay, that's pretty good, right?
Not bad.
Okay, so now there's a couple ways to do this. right? So let's talk about this. One is to just go on directly and start burring. The other way is to do something called retrograde. Retrograde would mean we'd sneak past the lesion on glide assist and then get the lesion on the way back. We don't need to do that here. So now Alan's ready to go, and all he's got to do is press the button. It's good to just let the nurses know the blood pressure, 131/67. Remind everybody that there's heart rates in the 60s. And now this is a very slow motion. Now, you might be able to hear that sound.
So I parked it distally now. So my plan is to do the retrograde, you know, as a next run. Typically, the rule of thumb is the amount of time that you spin, you rest, right? So we did this for 30 seconds, so we rest about 30 seconds, which is about now. We'll look at the hemos. CKG has some slight changes, but his pressure is good. So we're ready to roll for another round. And it's a very, very slow, you know, coming back. You kind of hear this. I don't know if you guys hear this, but it's kind of a high-pitched sound as I'm moving through the calcium. So I certainly have contact.
Okay, let's not talk for a second. Let him hear. So that was a 20-second alarm, by the way. That beep, 25 seconds.
So at the end, basically, I think we're pretty polished.
I think we should do one high-speed run.
Yeah.
Okay?
Let me just make sure we're good here.
So look, it's good practice to just go ahead and take a little puff, right? And we've got some atherectomy, but I think we've got a little bit more work to do.
Yeah, let's do
right?
a higher run.
And so we're going to do high-speed run, okay? So we gave a 30-second break. We're going to go high-speed run. All we did is press the button, and Alan's going to do some burring again.
So there was a little bit of a pause, an AB block.
Now let's talk about a couple other things. That is the flow rate. Okay, the flow rate that comes out of an orbital system is 4 times as high as a rotosystem. And the advantage of that is it flushes a lot of the debris along the time. So you get less pacemaker need and less AB block. And you saw very little pause when he went into high speed when you're in the tightest lesion creating some debris. Second thing is, remember the crown here is 1.25 millimeters, and usually the most commonly used crown for rota or burr is 1.5, so it's more likely to plug the artery. And so when you plug the artery and you create atherectomy, you're more likely to get a bolus of schmutz going down the artery than you are with 1.25.
I'll do one more run, and then I think we're good.
Let me talk you through how to walk it out, okay? So there's one way is to turn on the glide assist. That's a little bit more elegant, which means that the crown doesn't get stuck on anything. Now, Alan's only job is to open the TUI, okay? He's going to open the TUI.
I like the easy jobs.
And I just walk this back just like it's a over-the-wire balloon, you know, like you do in a peripheral or anything like this. It comes back very, very smoothly. And I like to have the glide assist on, which means it doesn't get caught on stuff like the tip of the guide, because if it does, it'll just, you know, basically come right out. Okay, and then when Alan has...
All right, good. Turn it off?
Yeah, I turn it off, you press the button, and we're good to go.
All right, good.
What we're going to do, because the creatinine's high, is we'll do run with OCT. So Alan, after it calibrates, then it tells you what to do. Press and hold Cine. Nice run. So that's a great example of a good saline run. You got to tell the nurses. You got to tell the nurses there's going to be severe EKG changes. That's the a little controversy about whether that's, you know, very rapid hemolysis of red cells which recovers or a little bit of ischemia distally. I'm not sure it matters. In probably 1,000 cases, we've had 1 VT. So, all right. So let's go take a look. and see what we got here. So I'm going to walk you through so now, by the way, for co-registration here, it's probably not going to work, right? And the reason is because there's no contrast. So the way this works is normally it tries to find a region of interest from contrast. Sometimes
it might stay on the line of the wire.
Yeah. And so on occasion it will work, especially in the right corner when it's completely clean. And admittedly, we haven't tried this so much with Ultron 2.0. So it worked nicely. All right. So let's get started from the beginning. Okay. So we're going to do M. So for the M, right now we see a big segment of orange right in the middle. Let's take a look at it. Right. I like to take this eyeball out so we can actually see what we've done. So in the tightest, you see that right there? That's, if you measure this right here, right, you will measure this and I will bet you this is going to be 1.5. Look at that. Right? And so that, you know, the crown dug into that space and made that area. So it's, you know that that's actually crown related. Okay?
And it looked like it thinned it out, at least that part that is less than, 0.5 millimeters now, and so we can probably crack it.
Okay, so let's see where we started, right down here. So let's talk, Alan's going to talk you through some morphology. So M here, lipidic plaque. Alan, you want to talk about what this guy is?
Yeah, so there is actually a nodule kind of on each side. You see calcification starting at like 1 o'clock to 5 o'clock, and it's protruding into the lumen. It looks almost like a ball. And the same on the other side, starting like at 6, 7 o'clock to maybe 11 o'clock, also a deep layer of calcium. Good news is the area is 5 or so, which is plenty, so I don't think that we need to deal with this.
Right, so what we're saying is lumen area is good. This is, you can see on the co-registration on the left where we are, we don't want to be here. We want to stay away from this nodule, right?
So if we go just prox to that nodule, let's see if we find the landing zone. See, so that's actually pretty good here, right?
There's another
nodule here. So there's a difference in the nodules. You want to talk about the difference in the, so you see this nodule? Right? You see the so the nodule here is now is around 3 o'clock, right? And you see the surface now is completely different than the other nodule that we looked at. So these are two separate type of nodules with a little bit of different implications for each of them.
Right, so typically what this looks like is an eruptive nodule because it looks like a plateau and there's nothing beside it. This should be completely deformable with a non-compliant balloon. We should be able to just push it out of the way. Okay, so what we're going to just quickly peruse through this, show you what work we've done. So this is the tightest segment, which is pretty tight. Yeah. Okay, we did a lot of thinning here. We probably shaved off the top of the nodule here. You see that right here? And so our next step is going to be, there's some more atherectomy here. Now this is pretty thick.
Yeah, I know.
So we're going to have to see how we did here and whether we can modify it. Yeah, this might need some further preparation. And then there's another nodule here. A great example of, most common area of nodules is in the right coronary artery. And then you can see more atherectomy. Ooh, this is going to be a problem. Okay. So you see how there's very, very little space between the catheter and the wall. And so what's happened here is that the burr has kind of spun inside and bounced off the normal tissue. So we're going to have to see how that responds to a balloon. And the predominant mechanism of a lesion preparation there is going to be dissection. All right. Now, one thing you'll notice is that where's the EL, right? You can't see the EL, and that's because we took the eye off. When we took the eye back on, what you'll notice is the EL, we have some EL here, right? So that's a good place right there. And then if we go proximally, there's some EL here, okay? That's 26. If you press and hold the proximal, you can just make this a commercially available DS. Now, I don't think we want to land there, right, Alan? That's like maybe a little bit better to go either proximally or distally. So let's see what happens if we put a 33. Distally, if you look at our EL artery is huge. It's 4.83 millimeters. So I think we can prep with at least a 3.5 NC.
For sure.
You want to use 4.0 or 3.5? I think 3.5 is okay.
3.5 is fine with all those nodules.
Yeah, absolutely.
And then maybe use a 4.0 stent, and then we can make it a little bit.
What we're going to also show you here is dynamic angio, okay?
So we used the 20 cc syringe, and that basically gave the whole thing.
There's some serious tricks to this. Number one is, you see we injected here. Can you show my hands, Craig? We injected at the assist interface. You cannot, the closer you get to the TUI, the better your picture. Because remember, saline has very low viscosity. So the more tubing you have, the worse you get, the more you get a jet stream. So you get saline going right in the middle. So you want to be as close as possible to the guide. Often what Alan was actually asking me was, do you want me to disconnect and inject through the TUI directly? That is the optimal way. All right, so I'm going to go back on the OCT. I want to show the dynamic angio. Okay, now what you see on the OCT, on the Ultron is the balloon on the left across from the co-registered image of where all the calcium is in orange.
Very well
Right.
organized.
There's no way we can miss it. Also, you'll notice if Alan puts this together, when he cines this, I'm going to dilate the balloon. You'll be able to see whether or not the calcium fractures because this is a higher. Let's go. Want to do it? Yep, go. And there you saw it yield?
It's a great example of how thinning the calcium will let you fracture it. This is the mechanism of work.
Yes, agree with you.
Another run, see how it looks.
Okay, so look, let's just take the eye off, please. Okay, and then show us, just go through the calcium for us. Okay, so you see the fractures?
Wow, that's pretty nice.
It's smashed over. Okay. There's like a bunch of, there's a fracture at 3 o'clock, there's a fracture at 6 o'clock, there's a fracture at 9 o'clock.
Thing is like a, it's
Keep
like
going
a
through.
bomb, man. It's,
Yeah, it's a bomb.
completely.
Look, big, deep fractures and others.
Yes, Chair, can I ask a query?
Sure.
Keep going.
Dr. Deepak here. How commonly do you see fractures following orbital atherectomy with high speeds and low speeds?
I think fracture without non-compliant balloon is relatively uncommon. I mean, there's some discussion about the vibration effect of it, but really, as you all know, that is not a dominant mechanism of fracture. Fracture that happens with vibration really happens from eggshell type 2 calcium, not really deep, thick calcium.
Thank you.
Yeah, nice case.
Okay,
And
and if we
best part is, this is, monologue. Nobody has to talk anything.
Well, that's the case in the box.
Yes, that's the case in the box.
So you can see this is all saline OCT guided. We tried to provide a lot of tips and tricks on how to deliver, how to perform this effectively.
Okay, we'll have the stent now.
Very nice case. Very nice demonstration.
Now you're looking, look at the OCT, guys, so you can see what Alan has his eyes on that, and so do I.
To come back, right?
This
So
dynamic
come back a
angio
little
is
bit.
really excellent. So we'll just place the stent in between the two markers here.
Yeah,
Off
really.
or, let's just see.
I don't think we need it, but if you want to, you can. I like that.
Pretty good.
Okay, I'm gonna take it, yeah?
Yeah.
Okay. That is
Nice expansion.
Yeah.
Then
little
one
dent
second
in the
before
middle,
you come
right?
down.
In
every
the
come down.
midpoint.
You see what Alan is gonna, we're gonna use this to advantage again, so Alan's gonna bring the guideliner
You're
down.
right. So right in the midpoint, co-registered with the severe calcium, there's still little dent.
For our winged NC balloon. The real advantage of this balloon assisted tracking technique is it keeps you off of the metal that's been kind of sticking out a little bit.
So just some post dilation here. This is the key segment, right?
Mid portion it requires to be optimized.
And now look, you see, do you notice how the wire is still pinned against one side? Which means that there's some eccentric calcium there that really isn't yielding.
22.
And so what we expect to see in the final OCT at that area is going to be a D-shaped stent, but the areas will be very large.
Was it right?
Yeah, I'll take you in a
Did
little
I
more.
get the?
You have a little more. You want to take a drive? We have this too.
Yeah.
You're still in.
Still in?
So this is a wonderful technology, stent boost device detection.
Stent boost, yes.
I mean, we use this for literally every single case. You notice the wire in the middle of the balloon? This means that the lesion is prepped. If the wire is pinned towards the one wall, that means the lesion is unprepped.
Not a bad run.
So you see the speckle? You'll always get speckle when the artery becomes huge.
So what I was saying there is when you, after your stenosis is gone on a saline run, you will always get some
So
speckle
you
in
see
the
on the screen
artery.
now there's a lot more red because it's not sure. But we're going to do this qualitatively. We don't co-register these usually at
Yes,
the end.
in lesion like this, after you expand fully and you still feel there may be some problem, do you do FFR and see some functional?
No, very rarely.
Let me give you a P2.
You know, this artery is going to be so big. The minimum lumen area is going to be well above 8. So
Yeah, I see it skipping a little
I
bit,
would
so
not.
we'll just skip it. Okay. So you'll see that it's not calculating right. So we take the eye off. Right? Yeah, we do have a proximal edge dissection.
How big is it? Are we seeing this enough, or do we need to?
Yeah, prox stent edge looks good. So come back.
I mean, that's a small.
No, this one's big though.
Where?
Here. Or is that might be a lesion? So we'll teach you a little trick, guys.
I'm not sure it's a dissection.
So what we're going to do is, the trick is that you can image through the guide extension. So we're going to take a contrast OCT run through the guide extension, the first 3 millimeters of guide liner, and what's the telescope, you can image. The Boston you cannot, because it's all plastic. So we'll put this into the very ostium, and then we'll do an OCT run with contrast.
It's a nice tip. So that this is how you do just a verification run. If you're using OCT,
stenosis on.
the first 3 millimeters.
Your stent looks great.
Yeah.
What
See
do
the
you
deep
think in the mid portion, Ziad?
There's a very deep dissection.
Yes. That's what we
So-
also think, that there is a big dissection there. How do you tackle
Right.
this?
Oh, we'll see it on the OCT, but here we would do nothing because the stent is already placed and the dissection is within the stent.
Yes.
Now there's your guide liner.
Does that invite a problem long term?
Lumen is actually
I'm
pretty
not
big.
sure.
I would leave.
Honestly,
That's
I'm
what.
not sure.
That's what. Nobody has revealed any
So go to the ostium, Craig, for a second.
study in this respect.
No, not sure.
No,
All you
okay.
can say is that the area is large.
It's fine. That's
And it
What
makes
do you
sense
do
with the
when you
amount
have
of
a
damage.
dissection beneath the stent?
What I want you to do is focus on what looks
But
like a
seems
flap.
to be significant one. It has compromised the stent area.
That's what you're talking about.
MLA is
flap.
compromised there.
Well, I think the area, because the artery is so large,
Yeah,
is
very
going
large.
to
It's a
anyway.
4 point something, 4.5.
Yeah.
Watch
But
how it's
now
gonna-
what we're seeing is right at the ostium. You see, look, the guide liner is trapped, right? But across from another proximal nodule.
Yeah,
And
next
so-
to guideliner, there is a nodule between it.
There's a big nodule. So the
big
question
nodule.
is, what do you do
But
here?
regard to the guideliner.
Right, here you go.
There you go.
Okay, so watch it. You see how it disappears?
Nodule is a permanent problem.
To
It
anything.
keeps on recurring. I had
Between
one patient, we did the same thing and it had a nodule and
There is a
then it
dissection
kept on coming back with a fracture stain.
Yeah.
What do you have to say, Zayad, about this?
You're talking
About this nodule, so
prox edge.
So
Nodule
when you
coming
have
back
this
with a
situation-
fracture stain.
Short.
What's that?
Fracture stain, nodule coming back long term for fracture stain.
Yes, so it's an eruptive nodule has about a 20% 2-year event rate and about 12% for a non-eruptive nodule. So it does fracture the stent. The event rates for these nodules are much, much higher, and they're typical in these very large right coronary arteries.
I had one patient where 3 times he had a stent fracture. How many layers of stent can you put? Only single vessel disease.
All right, so let me come in here.
No, you can put another layer of stent, but the
But 3
footprint
layers
of
are
a
already
conventional
there.
One little, it doesn't look good. Well,
well, the footprint of a conventional stent, like say Abbott, is only 18%. So if you put a stent with a bigger footprint, then you might be able to hold it back. But to be honest, we published this extensively. The nodules just keep breaking through. And so there really isn't a good treatment strategy for this just yet.
One little trick we'll do here is right when we're at
So in the end here, we decided to IVUS it because the OCT simply couldn't see the osteum.
So this is your calcified nodule. We're sitting right on it.
See, that's the
at 6
bubbles.
o'clock,
That's how you know where you
5
are,
o'clock.
what's lumen, what's not.
This is how a nodule looks.
Ziad, any message you have to give? Only 17 minutes are left with you.
Oh, so I
sorry.
thought
17 seconds. Sorry, I take it back. 17 seconds are left with you.
So my message would be, you can do an imaging guided atherectomy. We showed you the steps of orbital atherectomy step by step, showed you fractured on calcium OCT, and it really guided the whole procedure and made it much more seamless. But OCT does have its caveats, like the osteum. Here we had to use IVUS to make sure that everything was okay. And when we did IVUS it, you can see that actually the areas are really very good.
Okay, that's very nice. Give him a big hand. Thank you very much, Ziad. Nice case.
Thank you, guys.
That's the end of the session. We close this session.
I think it's good.
What is that?
So without further ado, let's invite the chairpersons and the panelists for the next session. Dr. Garg, Dr. Vivek Bose, Dr. Goel, Dr. Subramaniam, Dr. Madhwan, and Dr. Kalaichavan. Also, we have some panelists. Hi. Dr. Sudarshan Kumar Vijay, Dr. Manokar, Dr. Deshpande, Dr. Meena, Dr. Gupta, and Dr. Subbu Ramakrishnan. So whoever is available, please join us.
So we are going to start this keynote lectures on orbital atherectomy. There are actually 2 lectures. First is by Dr. Darshan Doshi. Okay, Dr. Darshan Doshi, please. Understanding the rock calcium modification with orbital atherectomy.
All right, thank you so much for having me. I think this is going to be a great session. I think that Abbott has done a great job of now trying to bring a therapy for an unmet need. And I hope to explain to you what some of the gaps are in our current armamentarium and how orbital atherectomy may be able to help us. These are my quick disclosures. So calcium is present much more than we think it is, okay? So if you look at studies of DES, both from the early era as well as contemporary studies, you find that severe calcification is present in about 30% of PCIs that we do. Moreover, in this study of ADAPT-DES, which was a image-guided study, what you find is that that number is pretty constant, again, at around 30 to 31%. Now, in an analysis of acute coronary syndromes, acuity, and horizons AMI, again, that number was around 32%. When you go to STEMI, that number is about 38%, and NSTEMI, it's a little bit less. Moreover, when you look at the frequency of heavy calcification, so if you look at the syntax trial, if you had triple vessel disease and or left main disease, that number was up to 50%. So calcium is present much more than we think it is. Now, what we also know is that outcomes are worse, and there's multiple reasons for why they're worse compared to cases where you don't have severe calcium. Firstly, it changes the safety profile of the intervention. We know that there's a greater risk of major dissection as well as perforation. The calcium also impedes stent delivery, so you can't get your gear where it needs to go. And then the third is, even if you are able to get your stent where it needs to go, what happens is that the calcium prevents full expansion. So if you look at this study, looking at stent expansion at 16 atmospheres, if the greater the arc of calcium, the less likely you had expansion. And by the time you get to 270 degrees of calcium, you basically get less than 50% expansion. Moreover, the arc of calcium forces you to use something else more than just an NC balloon, which is the predominant treatment modality in a lot of severe calcium cases. This is data out of Europe, specifically looking at patients that had severe calcification. You can see that in red right here, and those with no calcification, or sorry, no severe calcification, and you can see that in blue. And essentially, there was 4 times the stent thrombosis rate. You also had a higher level of target vessel failure, nearly double that of patients that did not have severe calcification. Just to show you again and again that the data is fairly compelling on adverse outcomes with severe calcification, this is the MACE trial, which is Samin Sharma's trial. And again, they quantified patients by no or mild calcification, moderate calcification, and subsequently severe calcification. And what they found was that the MACE rate was nearly 25% at 1 year with severe calcification. So 1 in 4 patients has an adverse event due to severe calcification. The other aspect that I want to impress upon you is that intravascular imaging is paramount for detecting calcium, and then you can derive your strategy to treat that severe calcification. This is a study by Gary Mintz and Marty Leon, where they assessed multiple different angiograms and found that IVUS detected calcium significantly more than just angiography alone. Now, when you use intravascular ultrasound, it can definitely detect calcium, but you have to understand that IVUS uses sound waves. So those sound waves can't penetrate through calcium. They reverberate off. On the other hand, if you use OCT, it's light. The light actually penetrates through, so you can get things like calcium depth. Now, there's different types of scoring systems which are beyond the scope of this lecture, but essentially you can use certain aspects of your intravascular imaging to determine whether or not you're going to need something more than just an NC balloon. For OCT, probably one of the simplest scoring systems is the rule of 5s. And so what you do is you look at the maximum calcium angle. If it's more than 50% of the circle, then you get 2 points. If the thickness is greater than 0.5 millimeter, you get another point. And if the calcium length is greater than 5 millimeters, you get another point. So if your score is 3 points or more, then you really should consider something more than just an NC balloon. Now, the other aspect is that not all calcium is the same. So there's deep calcium, there's superficial calcium, and there's concentric calcium, eccentric calcium, and calcified nodules. So as we learned from Ziad in the last live case presentation, essentially there is nearly 4 times the event rate from eruptive calcified nodule compared to any of the other calcium subtypes. So this is a particularly challenging area. Now, which calcium modification tools do I use, and how do I figure out what I should be using? So the most commonly used balloon and the most commonly used tool for about 80% of these cases is NC balloons. Cutting and scoring balloons can work. However, they really work more for fibrocalcific disease, not very severe calcium. And then intravascular lithotripsy is fairly versatile, but there's issues with being able to deliver it exactly everywhere you need to go. And you have to ration out your pulses. Atherectomy-based modalities have been tried and true. So rotational atherectomy has been around for over 25 years. Laser atherectomy is also effective with calcium. However, laser atherectomy uses photochemical, photoacoustic, and photomechanical pathways to treat the calcium, and it's unpredictable on how it's going to do that. Whereas orbital atherectomy is probably the new kid on the block and has some potential benefits over the other treatment modalities. So a couple of things about the Diamondback 360 coronary orbital atherectomy system. So there's a couple of things that I think I should highlight, and then Raj is going to follow and show you some cases and expound upon this further. So the first thing about this system is that, one, it comes in 2 speeds, okay? It comes in 80K and 120K. The second thing is that there's only one size crown, which is a 125 millimeter burr. This burr is sort of slightly offset, and that's helpful, and I'll show you why in a little bit. And so the other aspects of this is that there's an on-off switch here, there's a brake at the end, and on top of that, all you have to do is connect it to the saline infusion pump and to the Viper Slide lubricant. There's no need for a tank of helium to be bought in. The setup is exceptionally quick, and I'll show you some of the mechanisms of orbital. So the way orbital essentially works is that it starts off with a circular motion, but as you wait over time, that circular motion gets bigger and bigger and bigger, and it essentially is able to address the entirety of the vessel wall. So unlike rotational atherectomy, where you are contingent upon wire bias to create the cutting, this circles around and will touch the entirety of the wall. It's also time dependent. So if you wait, the orbit gets bigger and bigger, and so as a result, despite the fact that it only comes in one size, you can use it to address the entirety of the vessel along most of the vessel sizes. And here you see the mechanism of what orbital is doing. So it's basically shaving off calcium, but it's doing it in this circuitous motion right here. Now, the other aspect of the CSI Viper Wire, the Viper Wire Advance is the wire that comes with it. So it's a nitinol-based wire, so it's very supportive. It's an 012 that then becomes an 014. The 014 part prevents the burr from ever coming off of the wire. And it also has this nitinol body, so again, a lot of support. The other aspect is that, again, it comes in 2 speeds. It comes in 80K and 120K. As you increase the speed, your centrifugal force gets bigger. As the centrifugal force gets bigger, you have a larger orbit. Moreover, because the burr is offset, you really don't plug up the circulation. So as a result, there's blood flow through the inner portion of the vessel while you're doing your orbital atherectomy. So it minimizes the risk of no reflow and slow flow. Now, again, like I told you, it's a time-dependent mechanism. So if you go on, say, at 80K, but you go a lot slower, then what happens is you have a much larger size of the pass. If you go on 120K and you go much slower, you have a much larger size of pass. So again, as you wait, the orbit gets bigger and bigger and bigger. So really, you want to try to go for a 1 millimeter per second traversal. There's also substantial data, so I think many of the people on this stage may have been part of the Orbit 2 trial, and essentially it looked at the safety and efficacy of orbital atherectomy and led to the FDA approval in the US. So if you look at the primary efficacy endpoint, it way past its performance goal. If you looked at the safety endpoint, again, way past its safety end goal as well. So which do I use and when? So I use atherectomy in 3 scenarios. The first scenario is if it's balloon uncrossable, because if you can't get a balloon through, the only way you're really going to be able to affect the calcium to allow your stent to be delivered is with some form of atherectomy. The second scenario is if you have nodular calcium, and I'll explain why in just a moment. And then the third scenario where I use atherectomy is in long diffuse disease. So if you have a very diffusely calcified right, just for procedural efficiency, using atherectomy can help speed up the procedure. Now let's come back to nodular calcium. So why is this effective in nodular calcium? Because essentially it allows for volume reduction. So, there's the top of the nodule and there's what's behind the nodule. So if you want your stent to expand appropriately, you really have to take a lot of the top of the nodule off. And so if you use rotational atherectomy, it's really contingent on the wire bias. So if the wire is abutting the nodule, then you'll be able to get some sort of ablation of the calcium. On the other hand, if it's on the other side, you're going to have unfavorable wire bias, and it may not be as effective as debulking. Whereas orbital atherectomy, you don't really have to worry about it. What you can do is you can put your wire, you know that the orbit over time is going to get larger and larger and touch the entirety of the vessel wall, so you don't really have to be contingent on wire bias to be able to take care of these nodules and to debulk them. So let's start off with, let's finish off with a case and kind of show you some of the effectiveness of what orbital atherectomy has to offer. So this is a 68-year-old male with a prior CABG, has a lima to the LAD, has an SVG to the RPDA, has an SVG to the DIAC. The circ is not revascularized via CABG. So this patient presented with unstable angina and then was found to have this as the culprit. So the proximal circ, as you can see, is diseased. It has calcium. This is going to be the area that we're going to have to focus on. And so the plan was for this patient to go image-guided PCI of the left circ. So this is OCT, and here you can see sort of the type of calcium. This is a quick run, so I promise you I will show you exactly what we find. This is co-registration where you have pullback, but you can see that there's a significant area of stenosis with areas of severe calcification that start to come into play. And not only is there severe calcification, there's different morphology of calcification. So here, when you look at the morphology, what you see is that there's areas of concentric calcification more proximally, and then nodular calcification in the mid and distal part of the lesion. So again, concentric calcium, there's different modalities, but for nodular calcium, I do think that orbital atherectomy is one of the best. So ultimately, a 125 classic crown was used. 2 runs at low speed were performed, and then 3 runs at higher speed were performed. And then as you start to see this pullback, what you do see is that you have luminal gain and ablation. And so ultimately, once that was confirmed by OCT, pre-dilatation was done with the 3.5 NC, a 3.5 18 stent was placed, post-dilated with a 3.75. And then ultimately, you see that there's massive luminal gain. So in the same areas, so the area that had nodular calcium, you see this perfect, nearly circular type of stent here. You have pretty substantial expansion in that mid portion, again, markedly improved MSA here, and then in the concentric area, again, markedly improved MSA as well. So in summary, we know that coronary calcium is present much more than we think, anywhere from 30 to 50% of cases. It goes higher the more complex the case is. The outcomes are worse because there's a higher risk of perforation, dissection, and stent under expansion. You really should be using intravascular imaging when possible because angiography markedly is suboptimal in detecting calcification. And then if you use intravascular imaging, it can actually just help guide you. You know whether or not you need to do something more than use an NC balloon. Moreover, it tells you if your calcium modification tool worked effectively. And then I use orbital atherectomy for balloon uncrossable lesions, very long and diffuse calcific disease, and nodular calcium. Thank you so much.
Thank you, Dr. Darshan, for that nice overview. I think we can have Raj stop also and then have discussion at the end.
Sounds great.
Well, thank you very much. I've been told that our chief guest is here, so I'm going to try to accommodate the meeting and try to shorten this lecture, but I will give you a good sense of where orbital atherectomy is and how versatile it is in terms of complex disease. So let's try to, I'm going to forward some slides here and show you a couple of things. So this is a Japanese autopsy study of calcified lesions treated with drug-eluting stents, And in the autopsy data, what's shown here is maximal interstrut distance. Maximal interstrut distance means you have more space and there is a distortion on the geometry of the drug-eluting stent which leads to restenosis, and it's seen at the most in severe calcification. So here's an example, and I think that Dr. Bang was talking about this exact case where you have a large calcified nodule and you have a stent implantation, and which leads to stent fracture and then ultimately restenosis, and you have a problem like that. So what constitutes a versatile, efficient calcium solution? First, it's easy to be used. Second, there should be low rates of complications and a minimal learning curve. And the capital investment should be very minimal, and it should be widely applicable for different calcific lesions. So let's see whether this makes sense for you in next 7 to 10 minutes. So this is an 82-year-old patient who was admitted to an outlying facility with congestive heart failure and non-STEMI. I'm going to show you his diagnostic angiogram, and I'll tell you what they did with this patient. You can see this diffuse disease, calcified LAD, and there is a moderate to severe calcified proximal RCA stenosis, and a severe left ventricular systolic dysfunction with a high left ventricular end diastolic pressure. So they actually implanted a Impella device and attempted to do balloon angioplasty of this LAD, and you can see that on balloon angioplasty, even a 2.0 balloon was not able to be expanded. So they stopped at that point, and this is what the final result was. There were some linear dissections in that proximal segment of LAD, and you can see there's a very critical stenosis immediately after the septal branch, and the patient was then transferred to my center, and then this is one of the advantages of orbital atherectomy, because it allows a continuous flow of blood and reduces your risk. So after stabilizing the patient for 24 hours, patient had a groin hematoma from Impella device, so we had to take the Impella out. And after the groin was stabilized, I did the procedure on this patient, and you can see this is the orbital atherectomy run in the LAD, and this is 3 Zion stents, and the LAD looks really good. We also did an FFR of the RCA. FFR of the RCA was 0.74. So we also did an orbital atherectomy run there and implanted a Zion's stent there in the right coronary artery with a very good result. Here's another patient, 73-year-old, prior history of bypass surgery, had a episode 2 months prior to this admission where a vein graft to ramus was stented, and then patient presents again with a non-STEMI. He has multiple other comorbidities, including he's diabetic on dialysis. And you can see his vein graft to OM was totally occluded, and he has a extremely angulated, heavily calcified AV groove circumflex coronary artery. The vein to ramus, where the drug-eluting stem was implanted, is still widely patent. So we did an IFR of this circ, it was 0.51, just to confirm, to make sure that we're doing the right thing. And we went ahead and did an orbital atherectomy as shown here. You can see that it takes this type of angulated turn very well. Several runs were done with a low as well as high speed, and followed by drug-eluting stent implantation of the circumflex and a left main, an excellent result thereafter. This is a IVUS after stenting and IVUS after post-dilatation. You can see that there is a substantial improvement in the MSA. Here's a last couple seconds, 75-year-old patient with a severe intractable angina, failed vein graft to circumflex, patent lima to LAD, and a patent vein graft to RCA, a heavily calcified distal left main. This was then treated with orbital atherectomy, followed by stenting, and a very nice result. Here's another left main case, extremely complex, very difficult. I would not recommend that as your first orbital atherectomy experience. You can see this was done with a long run in the left main as well as in the LAD, followed by a long 2 stents and acceptable result. So where would I do orbital atherectomy? Patients with hemodynamic instability, where I prefer that because you can have a continuous flow of blood. You can do fairly distal and multiple lesions in one shot, fits to a 6 French guide. So let's skip final thoughts in great detail, but they're very similar to what Dr. Doshi has already talked very eloquently. That when the balloon doesn't cross, you already know that you need to do a atherectomy. Also remember that there are other factors that you should take into consideration, such as tortuosity, diffuse disease, guide support, availability of other accessory devices such as guide extenders, lithoplasty balloons, super high pressure balloons, those things are useful in the case. Where it's not great, it's extreme tortuosity, a lesion that cannot even be crossed by a microcatheter to exchange for a wire, where you may need rotational atherectomy, a front cutting device to create a lumen. Under expanded stents, we do use it sometimes, but under expanded stents, the utility can be somewhat limited until you gain some experience with it. A rotablator also has some disadvantages. It's high risk in patients with hemodynamic compromise and LV dysfunction. There is higher risk of stuck burr because it only cuts in a forward motion. So if you go too fast through a tight lesion, and then you may not be able to come back, and that leads to stuck burr phenomena. So I hope this is helpful in getting you an introduction to how orbital atherectomy can be utilized in complex scenarios. And with that, I will end it here. Thank you very much.
Thank you, Raj, for that nice presentation. I think we are short of time, but I'll just have one question. What percentage of cases is orbital used upfront in your practice, and what percentage is after you fail balloon? That is, can you tell that? You need to press.
It's a great question. So I think that I would say that given that imaging has become so much more popular now, that doing atherectomy after failed balloon angioplasty is declined, because usually we're doing IVUS or OCT or something like that in a complex disease like that. In Orbit trial, fluoroscopy was also one of the reasons how patient could be enrolled. So if you see heavy calcification in both surface of the artery in 2 different views, you know the lesion is very calcified, and we try not to push a balloon in there. So it's less, but I would say 10-20% of the time it happens, just like in this case that I showed you, where we try to push a balloon in there and it fails, and then you have to do atherectomy.
Yeah. So good to use it up front then.
Crossable. Wire crossing, balloon not crossable.
Yeah. So this is where orbital atherectomy really shines, because their Viper wire advance is an excellent wire to cross through even a calcified CTO lesion. So that has increased our utilization of this device, because it's a really good wire for crossing that type of complex lesion where you can't even get a microcatheter across.
Okay.
And what percentage of cases you will have to use orbital plus something else?
Yeah. So that does happen. I would say maybe 20% of the time we would end up using a high pressure balloon, like an OPN. There is OPN balloon now approved in US. We also use angiosculpt balloons. There is a device called Chocolate, which is not available in India, but it's available in US. So I use both of those. I do use a little less of a cutting balloon, and I tend to be very conservative in opening a lithoplasty balloon, because lithoplasty is very expensive in US. So it becomes very cost prohibitive to have atherectomy, then lithoplasty on top of that.
Dr. One more question. Do you think, or have you seen bigger or higher incidence of side branch closures with orbital atherectomy And do you do anything in particular to prevent it, or you try to avoid it?
Yeah,
It's
so
no difference.
I have not personally seen that, but maybe Darshan might have. Yeah.
No, again, you have to understand that just like rotational atherectomy, it's hard on hard. So unless there's a massive dissection that's been created, the likelihood of side branch closure is slim to none.
How much is the effect on the deep calcium?
Yeah, so I would say that deep calcium is not necessarily a problem. So I think that what you have to understand is it's thick calcium, not deep calcium that you have to worry about. Deep calcium has really no problems as long as it's not thick. So this is one of the things where I think a lot of people don't understand. But as long as you can expand your stent and your balloon and the calcium is very deep but not thick, you shouldn't have any problems.
Maybe I can add one more thing to that, is that with orbital atherectomy, because the device wobbles, it also has pulsatile forces. So it does affect fractures the deep calcium to a certain degree. So it's helpful. Okay.
Okay. I think we can now.
I think we will wind up. The chief guest is.
Please.
Thank you very much,
Okay.
Raj. Thank you.
Good evening, everyone. On behalf of CSINIC, it's my honor to welcome everyone for the inauguration ceremony. I would like to request all the dignitaries to join us on the stage. Our chief guest, Dr. Sridhar Bambu, CEO of Zoho Corporation. Guest of honor, Dr. S. Gurushankar, Chairman, Meenakshi Hospital, Tanjore. Dr. P.C. Rath, President CSI. Dr. Sanjay Tyagi, President-elect CSI. Dr. N. Pratap Kumar, Scientific Chairman, CSI NIC 2024. Dr. D.P. Sinha, Honorary General Secretary, CSI. Dr. V. Murugesan, Organizing Chairman, CSI NIC 2024. Dr. B. Keshavamurthy, Organizing Secretary, CSI NIC 2024. I welcome you all, sir. I would request everyone to rise for Tamil Tharikal. Every function should start with the lamp lighting. So I would request all the dignitaries to come forward and light the traditional lamp for CSI NIC inauguration. Thank you, sir. Now, I would like to request our organizing secretary, Dr. P. Kesamurthy, sir, to felicitate our chief guest, Dr. Sridhar Venu, CEO of Zoho Corporation. We welcome you, sir. Our chief guest, our guest of honor, Dr. S. Gurushankar, Chairman, Meenakshi Hospital, Tanjore. Dr. P.C. Dutt, President CSI. Dr. Sanjay Tyagi, President-elect CSI. Dr. N. Pratap Kumar, Chief Scientific Chairman, CSI NIC. Dr. D.P. Sinha, Honorary General Secretary, CSI. Dr. V. Murugesan, Organizing Chairman, CSI NIC 2024. Now, I would request Dr. N. Pratap Kumar to welcome Dr. B. Kesamurthy, sir, to felicitate Dr. B. Kesamurthy, sir, Organizing Secretary, CSI NIC 2024. Now, I would request Dr. V. Murugesan, Organizing Chairman, CSI 2024, to share a few words.
Good evening to everyone. Esteemed guests, distinguished colleagues, and honored participants. It gives me immense pleasure to welcome you all to this National International Council meet here in Tamil Nadu, the cultural capital of India. This gathering marks a significant milestone in our shared journey towards advancing the field of interventional cardiology in our nation and beyond. The National Interventional Council has always stood as a beacon of innovation, collaboration, and excellence. Since its inception, it has played a pivotal role in shaping the landscape of interventional cardiology in India. Today, as we convene for this annual meet, we are reminded of the remarkable progress we have made and the promising future that lies ahead. Over the next 2 days, we will engage in thought-provoking discussions, hands-on workshops, and insightful presentations. Our agenda is packed with sessions that cover a broad spectrum of topics from the latest development in coronary interventions to the evolving landscape of structural heart disease treatment. I encourage each one of you to actively participate, share your experiences, and exchange ideas. It is through these interactions that we can learn from each other and collectively drive progress in our field. I would like to take this opportunity to acknowledge the efforts of our organizing secretary, Dr. Kesavamurthy, and the rest of the organizing committee, volunteers, and sponsors. Your hard work and unwavering support have been instrumental in making this meet a reality. A special thanks also to our esteemed speakers and presenters who have prepared diligently in share their knowledge and expertise with us. Thank you, and we wish you all a productive and inspiring National Interventional Council Meet 2024. Thank you.
Thank you for your welcome address, sir. Now I request Dr. D.P. Sinha, Honorary General Secretary, CSI, to share a few words.
Malai Vanakkam. Good evening. Welcome to the NIC International Council meet at Chennai, a city with a history dating back to the years of Chola, Pallabs and Vijayanagara empires. In such a culturally rich history, we are here, we are experiencing an unique academic feast lasting over 3.5 days, encompassing the best faculties from all over the world, from within and outside India, on all topics, all facets of interventional cardiology. Interventional cardiology is an ever-expanding field with innovation and ever-increasing and ever-demanding skill set. And I believe the feast that is here for the last 1.5 days that we have seen and 1.5 days that are remaining will be of great benefit to all those who are attending, either a practicing cardiologist with an established practice or a student who is learning. It will be beneficial to everybody. With these few words, I congratulate the organizers for a beautiful organization. Like any other conferences of such a big size, there is always be some hitches. But I apologize for those hitches because I am the General Secretary. But I think that we have overcome all those hitches. Thank you, everybody.
Thank you, sir. Now I request Dr. P.C. Dutt, President CSI, to share a few words.
Good evening. Namaskar and Vanakkam. Mr. Chair, guest of the evening, Mr. Sridhar, and honorary guest, Dr. Gauri Shankar, Dr. Sanjay Tagi, guest Dr. Kesavamurthy, Dr. Sinha, and others in the dais. It was NIC meeting is one of the most important meeting of CSI, and we always look forward to attend this meeting, mostly the cardiologists, because a lot of learning happens here. And this time, the scientific program was designed by our convener, scientific NIC chairman, Dr. P.K. Sahu. Unfortunately, his mother expired, but he put a lot of effort for the whole year, made a beautiful scientific program, and he was not able to attend. But he gave the responsibility to Dr. Pratap Kumar, who readily accepted because he was also associated. From CSI side, our brief to Dr. Pratap Kumar and Kesavamurthy was, the NIC meeting is the best interventional meeting in Asia Pacific region. It should remain as the best. And they kept the promise. I think there is more than 1,500 attendance. And yesterday the fellows course hall were packed. And I can see the people are not leaving the halls, all the hall, 3, 4 halls, all are scattered, but everywhere attendance is full, and scientific program is excellent. And this is in keeping with the latest trend in interventional cardiology. I think all of us will go back with a lot of knowledge, and this actually this is what the meeting is meant for. And I hope you'll enjoy this meeting for next 2 days, and you'll have some free time to move around and see the beautiful city of Chennai. And I wish you very best and have a nice day in Chennai. Goodbye.
Thank you, sir. Now I request Dr. Sanjay Tyagi, President-elect CSI, to share a few words.
Honorable Chief Guest, Shri Vembuji, the guest of honor, my dear friends on the dais, the Professor P.C. Rath, Dr. D.P. Sinha, Dr. Keshav Murthy, and other faculty members on the dais and off the dais. At the onset, I'd like to congratulate Dr. Keshav Murthy and Dr. P.K. Sahu for the wonderful organization and the facilities that they have created for this NIC 2024 meeting. I think this brings the best of the international speakers and the Indian speakers for exchange of ideas in the front of the cardiologist, thus giving an opportunity to exchange their views and the techniques, the latest being in. This will certainly enhance the practice of cardiology for the patients in India. As you all are very well aware, coronary artery disease is the most important cause, and the most patients in India die due to coronary artery disease. And also India is the diabetic capital of the world. Therefore, the cardiovascular disease are the most important area where for affecting our health. So I think this conference, the interaction at this conference would go a long way in improving the treatment of a large number of patients over in our country, and we all will be benefited. So I congratulate the organizers again, Dr. Keshav Murthy, Dr. Pratap Kumar, Dr. Sahu, for this wonderful organization, for giving opportunity for great interaction and organizing this great conference. Thank you very much and wish you all the best.
Thank you, sir. Now I request Dr. N. Pratap Kumar, Post Director and Chief Scientific Coordinator, CSINIC 2024, to share a few words.
Chief guest, guest of honor, and all the dignitaries on and off the dais. I'm standing actually on behalf of Dr. P.K. Sahu, who lost his mother last week, so he cannot come to the CSI because of the spiritual reasons. He actually did a lot of effort for the last 3.5 months to make an excellent scientific agenda, which is distributed over 6 halls. And Keshav Murthy arranged a hall which is having a capacity of 1,200 in every hall. So 1,200 into 6 will become 7,200 people. That many cardiologists are not available in the country. That is why some of the halls looking empty, because basically if you take the number, we actually exceeded 1,500 cardiologists today. And yesterday in the fellows course, actually, he expected only 200 people, but it was exceeded number. We put 340 chairs. People were standing and appreciating even the last moment. We started the program at 2:30. We could finish by 9:45. There is a real hard effort taken by Dr. Anil Dal to create the fellows program. So we 4 course coordinators, me, Anil Dal, Diman Kahali, Samit Dani was helping him, but Sahu took a lot of effort to create an excellent scientific agenda which consists of nearly 32 international cardiologists came for this meeting. We could have a registration of more than 2,500 cardiologists in this meeting, and 1,200 CDs came for evaluation. We could only accommodate 300 CDs, and that indicates the people's enthusiasm to come this meeting and present their cases. What we actually achieved in this meeting is structural heart disease, congenital heart disease, electrophysiology, interventional cardiology, lipid management. Everything was taken care in this meeting. And it was one of the wonderful meetings where I couldn't do the scientific agenda for the last 2 years, not this year. I was partially helping Sahu. On behalf of Sahu, I'm standing here. That means it was done a wonderful job, but CSINIC is one of the meeting which every cardiologist in the country looking for. All the young cardiologists is appreciating the scientific content. Since it is distributed over many halls, there are 6 training villa. If I calculate 100 people in each villa, each place, then again the number was too high, and it was an excellent scientific agenda. Moreover, I have to appreciate Keshav Murthy, who was looking every individual from the beginning to the last, arranging travel, accommodation, and excellent food. He was telling that, sir, did you like the food? The food was excellent, and Tirunelveli Halwa, nobody can forget. Thank you, Keshav Murthy, and the team for arranging an excellent organizing program. Thank you very much.
Thank you, sir. Now I request our guest of honor, Dr. S. Gurushankar, Chairman, Meenakshi Hospital, Tanjore, to share a few words.
Hi friends, how are you? Generally, when I go to any conference and when you see doctors, unfortunately doctors are bad patients. They don't take care of their own health. It's so common to see doctors who look much more aged than their biological age. But the exception are cardiologists. Most of you here are fit. In fact, this is the same question I have when I go around my own hospital, when I go to Meenakshi Hospital in Tanjavur or Meenakshi Mission Hospital in Madurai. When I see Dr. Sivakumar or Selvamani or Dr. Keshav Murthy, I always wonder, how are these guys more fit and more health conscious than the rest of the team in the hospital? And then I realized the answer is because of the patients whom you see. Earlier, you used to see patients with heart attack who need PTCA. They used to come to hospital around the age of 40 or 50. Now someone comes at 30 with a chest pain, then you kind of decide, okay, we can't just rule it out as a gastric problem. So probably because of the people whom you see, you take care of your own health, which is good. But that also brings to my other point that we have a huge responsibility here, especially after COVID. The amount of cases where we get in cardiology is just so high. People at the age of 30, 35, they are coming with a serious problem in their cardiac health. And as a healthcare entrepreneur, one of the main reasons I decided to build a hospital in Tanjavur. So my job is to build and run a hospital. I'm not a cardiologist. And when I decided where should I build a hospital, 13 years back, in the year 2009, I bought this land in Tanjavur and I built this hospital because Tanjavur didn't have a single cath lab at that point of time. So if someone had a heart attack, by the time you ship the patient to the nearest center, which is Trichy, they would die. But after the Tanjavur hospital was built, thanks to Dr. Keshav Murthy, I met him in Madras. And you wouldn't believe, I met him and I convinced him to come and join the hospital. At that point of time, there was no hospital. I only had a land. I had a plan of how I am going to build the hospital. And I met him in a hotel. I think it is Trident Hotel. And I spoke to him and I said, sir, we are going to build this hospital. This is going to have these facilities. We will get all these infrastructure. And you have to come and join. We are going to start a clinic straight away. I mean, I rented a place, a small a spot in Tanjavur, and we started it. We made amazing results in Tanjavur. We were the first multi-specialty hospital with NABH, first to have a cath lab, first to have CTS department. I can keep on going about it. But that is not what I am so happy about. More than 20,000 angioplasty and angiogram were done by him, and a lot of them were emergency cases. Thousands of lives were saved by Dr. Kesav Murthy and his team. It's a great achievement. Because of him and the whole team, this happened in Tanjavur. He is a superstar for Tanjavur. Now in Madurai, we have bigger superstars. We have Sivakumar, Selvamani, Sampath, Dr. Ganesh, and 200,000, 2 lakh PTC and Anjo in Madurai. The difference we made in that region is just phenomenal. We do a lot of charitable work. For people with money, we charge them, but people without money, we make it free of cost. Madurai has a different model where there's so many charitable work that happens in that hospital. The real happiness what we get is the social difference we make to the society and to the people we serve. See, if not for these hospitals, if not for each and every one of you here, you are all real life heroes. You have been saving people. And you are like an army guy who protects this country from the enemy. You protect people from cardiac diseases and you save them. So we should be proud about it. In fact, in Madurai, I used to say that if I walk into the OP, outpatient area of cardiology, and if I toss a coin, the coin will not fall on the floor, it will fall on someone's head. தரையில் விழாது, அவன் தலையிலேயே தான் விழுகும் அப்படின்னு சொல்லுவான் தமிழ்ல. So many people are there. That shows the amount of trust people have on our doctors and have on our hospital. And that has given rise to another cause, another reason, and we have built this new hospital called Meenakshi Super Speciality Hospital in Madurai. We are going to inaugurate it next week. I need all your blessings so that all our patients who come there get the best possible outcome. And it's going to be inaugurated on July 12th. And we are having 4 cath labs in that hospital. There is a huge social responsibility and social cause in each and every one of us, especially as India is a young country. And for some reason, especially after COVID, there's a huge incidence of cardiac problems. Cardiologists like you have to fix this problem and save these people. We need more Kesav Murthy. We need more Sivakumar, Selvamani, Sampath, Ganesan. We need more Meenakshi hospitals. And we need them in rural areas. We need them in small towns so that people get the best possible care available to them in their doorsteps. And that is where conferences like NIC and meetings like this and seeing colleagues and learning from each other helps each other. When I saw doctors here, sometimes, you go to a conference and you see one enlightened mind, you get so thrilled. Here, I just went around the stalls and I met a couple of enlightened minds. I met the doctor who has been doing amazing number of cases in Ayushman Bharat. I'm like, wow, that's great. That's something I would like to learn from him. That's something I would like to replicate. We should learn from each other, replicate, and create a much better environment for our country and our people. So best wishes for all the organizations, especially for Dr. Kesav Murthy. I call him superstar because whatever he does, he will win. So congratulations to everyone and a big success and best wishes to all of you. Thank you.
Thank you, sir. Now I request our chief guest, Mr. Sridhar Rannu, CEO of Zoho Corporation, to share a few words.
Vanakkam, Namaskaram, good evening. I'm the only non-doctor here. With all the cardiologists, all the doctors assembled. I run a software company, so I'm going to share my real. My father was a patient of Dr. Kesav Murthy, and he saved his life in March 2023 in Tanjavur. I want to tell you that story because how important it is. My father he just passed away last week, but he had another extra year and a half life thanks to Dr. Kesav Murthy. Because he had the heart attack in my native village. In fact, that's where I came from this morning. And that village is about 55, 60 kilometers from Tanjavur town itself. It's very much in Tanjavur district, but it's quite in the outer edge of it. And our nearest city, bigger town is Kumbakonam. And when he had the heart attack, our driver took him to the nearest hospital there and they couldn't treat him. They said, this is more serious, take him to Tanjavur. We went to Meenakshi Mission, and Dr. Keshamurthy saved him. I mean, it was maybe, he had maybe 10 minutes. And he had an extra year, maybe a year and 3 months, thanks to him. And he had a very good time. I mean, I think I spent a lot more time realizing that, he had this, made us, all of children, spend more time. And that precious gift was, because the hospital was there, Meenakshi Mission, I want to thank Dr. Guru Shankar for starting that hospital there 11 years ago. Like he said, he would have had to go to Trichy, that would have added another 30, 40 minutes of time, and he was probably gone that day. So that was because he was just in the last thing, and so this is the real work you're all doing as cardiologists, and how vital it is to have these hospitals, how vital it is to have Dr. Keshamurthy there in Tanjavur. He's a real hero for us there. And without him, the whole region doesn't have all these facilities. The hospital itself and a doctor of his caliber, that world-class doctor there. And I live in a small village in Tenkasi district, which is further south. Tanjavur is from here maybe about 350 kilometers, 400 kilometers approximately. Where I live is about 650 kilometers from here, so even further out. And Madurai is the closest city for us, Tirunelveli, and again it would be an hour, hour and a half, 2 hours to go there. Meenakshi Mission is there in Madurai, so that was the big blessing for us. And so this is the, what our nation needs is very many of these hospitals, in, like Dr. Guru Shankar pointed out, in our rural areas, and we need a lot more talented doctors of the caliber of Dr. Keshavamurthy in these rural centers. And I'm going to, now our company is planning to build some ourselves wherever we are present, but we need the talent to also serve that. It's one thing to build the facility, but the other thing is we need the talent and really good people serving in these. And with people and Meenakshi Mission, I also want to add how I was there, and we spent 3-4 days in ICU when my father was there. So I was there very much, and I saw the patients. I was very moved how this hospital is serving all these patients who have almost nothing. In fact, I offered Dr. Guru Shankar that a company like us could maybe build facilities adjacent for taking care of their stay and food, all that for poor patients in particular. So we have to do these kind of partnerships where somebody builds a hospital and somebody else comes and adds food delivery wing or something, so that the poorer patients in particular, the patient attenders, all can have a place to stay and meals, all that. So these are some of the ideas that after that experience, I felt we must do these things. And so I want to really thank Dr. Keshamurthy. It's very personal for me. That's why he came. He asked me, and just yesterday we finished the final thing for my father. Yesterday was what they call the Shubham. So I could travel. The first day I traveled, I came here. So a year and a half extra for my father's life is very precious for us. And he had a good, he had a good time. All of the family was around him. The grandkids were there. So that's the real role you're all doing as doctors. Because what you see is a patient, but what is a family member, my father, all of that, right? Grandfather, all of that. So I think that's the very valuable. And Dr. Keshavamurthy also was kind enough to come to my father's funeral because he felt an attachment to him. He came from Tanjavur to our village a week, 10 days ago. I was very moved by that. So I'm so happy to felicitate him today, and it's indeed an honor for me to be present here. It's a personal story, personal thing. All my siblings, all of us are very grateful to him. And the whole region, I want to add. Then you come to the hospital, you'll see the people, the hordes that are coming there. And I want them further success. I want many more Dr. Keshavamurthys to be in our nation. Thank you very much, doctor. Thank you. Thank you for listening to me.
Thank you, sir. Now I request Dr. B. Keshavamurthy, Organizing Secretary, CSINIC 2024, to propose the vote of thanks.
Good evening. At the outset, I would like to thank our chief guest, Dr. Mr. Sridhar Vembu, sir. He has accepted our invitation and in spite of his busy schedule and his father's demise 12 days back, he has made it. I wholeheartedly thank you, sir, for that. And I also thank our guest of honor, Dr. S. Gurushankar. He is chairman of Meenakshi Hospital, Tanjavur and Madurai. For gracing this occasion, and he has been for his financial support for this program as well as manpower support. You always feel as a consultant, he makes you feel that hospital is ours. I'm not alone. I used to feel that I'm sitting on a big elephant. You can see there are almost 100 people he has sent from a hospital as volunteers. That is the force which moves this program. So every hospital chairman supports the consultant like this. That will make a lot of difference. And I thank Dr. P. Sirath, who was my guru in Hyderabad, and he's the president now and of CSI, and Dr. Sanjay Tyagi, president-elect, and Dr. D.P. Sinha, general secretary, CSI, and Dr. V. Murugesan, sir, our organizing president, organizing chairman, and I thank the executive committee of CSI Tamil Nadu chapter for giving me opportunity. We are celebrating 75th year of CSI, and I should thank the founding fathers of CSI, because the democratic nature of CSI has given an opportunity for a person like me from a tier 3 city to organize a conference. Not other conferences are run by same people years, so they're experienced. But this is a new experience for me. I have gained a lot of experience. But next year, somebody new from either Jaipur or Guwahati will run it. He will learn. That is the beauty of democracy. So I thank the CSI as an organization. I thank for that opportunity. And my special thanks goes to Dr. K. Kannan, our Stanley Middle College professor, and he has shared all his experience which he gained in CSI Con, right? The same hall with me. Without his help, the cost would have doubled, definitely. So it was almost like a repetition. So I saved a lot of money with his guidance. I thank our senior executive member from Chennai, Dr. M.S. Ravi sir, who is always behind me as a big force support. And I should thank Dr. P.K. Sahu, who couldn't make it because of his mother's demise. He has been a part organizing secretary. He helped me so much in getting finances from various companies. He's so powerful, and without his help, I would have not made it. And he has made an excellent scientific program. And Dr. Pratap Kumar, my long-term associate I'm a long-term associate of Dr. Pratap Kumar. He took over for the past 4 or 5 days and before the conference, filled in the gaps with all influence. He knows every cardiologist in the country. So wherever there's a Lucknow, he could do it. So this program has become a big success. And all the scientific co-chairs like Dr. Anil Dal, Dr. Viman Kahali, Dr. Samir Dani, who has helped in fellows program and forming this scientific agenda. They helped me a lot. And I must thank the national, international faculty who has come all the way and to run the program. Without their help, it would have been not possible. From administrative side, I thank our General Manager Marketing of Meenakshi Hospital, Mr. Sivakumar Sanmugarajan, and my sincere thanks goes to my secretaries, Vadivu and Devapriyan, who have been working almost day and night for the past 1 week to book 700 tickets and book so many hotels, so many changes. They didn't sleep for 7 days, so my sincere thanks goes to them. And our sponsors, I should thank our sponsors for the prompt payment and for their support. The program of this size, they're called academic partners. Without support, it could have not been happened. And our audiovisual, excellent audiovisual arrangements by Promax. Promax stands for the prompt and services in audiovisual area and for all the conferences. I thank them for their big support, and they came within 48 hours. They direct all this, and there is without any lacuna they could do it. I am thanks goes to Samir and Anu and our event manager, Mr. Mastermind. Yes, 2 days back, you would have seen this place. It was just empty hall, that exhibition hall. Exactly 48 hours before they hand over this hall to them, I came, I saw 1,000 people working. 1,000, just literally 1,000 people working. And they made wonders. You could see what you could see. It's an empty place. They have made it. And Mr. Anish told me a conference like this helps 1,000 families for 2 days. It's a big satisfaction for us. And our catering services by Madambatti Group, Mr. Rangaraj has come here. He's known for his, he's a celebrity chef, and you Google it, we know that how famous he is. He is accepted, and he has already delivered. Afternoon lunch was very good. I expect gala dinner to be much better. I thank him for personally coming today for the function. And I also thank the management of Chennai Trade Center, who are very cooperative, very cordial, absolutely no interference. They help me a lot. And with all that, if I have not forgotten somebody, please apologize for that. I thank one and all. And I would like to finish saying that long live CSI. Thank you. Thank you.
Thank you, sir. As we come to the end of the inauguration ceremony, I would request everyone to rise for national anthem. for joining. You all can join us for the gala dinner in the food area.
Hi, good evening, everybody. I take the pleasure of inviting you all for the Modern PCI Symposium on Calcium Management in Complex PCI. This evening symposium sponsored by the Boston Scientific. And I would like to invite our chairpersons, Dr. Yoshifumi Kashima, and I'll be moderating, and Dr. Sanjeev Roy. And we have in the expert panel Dr. Anand, uh, Dr. Arun Gopi, Dr. Debadatta, and Dr. Kavita Tyagi. So, yeah. So I think we would like to move on with the first presentation, that is by Dr. Girish. He will be discussing on the stenting strategy for the calcified lesion, focusing on the stent design, the overexpansion, and the radial strength consideration. Over to you, Dr. Girish.
Thank you, Rajib sir. Can somebody play my slides? It's been a wonderful gathering. You can still see the enthusiasm among the organizers and the volunteers. Been a wonderful evening. I've been asked to speak on an important topic called how do you treat a large calcified vessel such as left main with special reference or understanding of design of the stent, overexpansion implications, and the radial and longitudinal strength. Next slide, please. Okay, I will do it, sorry. So I would show you a case, 57 years old, he's actually 77 years old male, unstable angina, preserved ejection fraction, 55%, had an angioplasty stent to LAD in 2011 with a 3.5 into 28 for the proximal LAD in 2011, diabetic and hypertensive, currently unstable angina. This is the angiogram, large left main, anomalous right coronary artery, which is non-dominant, dominant circumflex, and circumflex ostium shows 90%, proximal about 80-85% stenosis, left PDA has some disease, and this was the IVUS. LAD ostium seems to be fairly all right. When you look at the MLA, it's reasonably just 3.7 at certain areas, the distal edge of the previous stent. This is a cipher which was done in 2011. That's about 12 years ago when this procedure was done. Now, when you look at the circumflex ostium, significantly calcified. And when you look at the left main, it's tremendously huge. So now, when you treat a left main, I think it's a different zone altogether. People call it God zone. So when you enter there, you better be sure about it. One of the papers by Dr. Kirti Punamia says that IVUS determination of normal left main stem artery size and plaque burden, when you look at it, in Indians, the average is about 5.53 plus minus 0.63 millimeter square in men and women when you look at it. So, how often did we have stents which could be taken to 5.5 millimeter squares? Why is it important? Large proximal vessel clinical data, it shows that significantly worse outcomes when stent strength is compromised, as by the Excel left main IVUS sub-study shows that when there is acute stent deformation, which occurred in about 6.5% of the cases, the MACE was 28% versus when there was no stent deformation, when the MACE was more than half reduced, that is 13.4. This is where I think a custom designed, purpose built, large proximal vessel stent, even for a calcified vessel. What used to happen contemporary, just before the introduction of this new platforms, we voiced the need for a better stent for large proximal vessel, especially if it is calcified or fibrotic. So for the contemporary design, when we overexpanded, stent would expand, scaffold, but you never know how it would perform. What would happen to its radial strength, drug delivery, tissue prolapse? We do not know. So what was the need? High radial and axial strength. Fibrotic lesion in the proximal position can be more resistant and require extra radial strength. Maintaining stent integrity when adjunctive device interact with the stent is critical. That means it could be a guide, the balloon in the side branch, which requires extra axial strength of the stent. You need larger overexpansion range because the left main, especially in case of a dominant circumflex, can vary greatly in sizes. Ability to size to the distal vessel so that it does not dissect and can be overexpanded with confidence to the proximal size. And optimized scaffolding at larger diameters means the amount of metal that comes in contact with the vessel, that's what is called scaffolding. It needs to reduce lumen loss due to tissue prolapse. If very short or very small percentage of the lumen is scaffolded, more tissue can prolapse in those cells. Then when you look at the placement accuracy, you need better visibility, especially because you want to position precisely in left main, either ostium or proximal part, or you do not want to cross the distal bifurcation region. So that's why I think somebody heard in Boston created a beautiful scaffold, Synergy Megatron, custom built for this. What is the advantage? Purpose built for large proximal vessel. Look at the strength. The radial strength is crazily high, almost 2 times, both axial as well as the radial. Axial means the amount that foreshortening can happen, or radial is around the vessel. And what is the great thing? The overexpansion limits. It can, these these sizes 3.5, 4, 4.55, all of them can go up to 6 millimeter in diameter. That is tremendous gain. Look at this picture. Distal 3.5, proximal 5. And how did it look? Is there any difference in the stent architecture? Hardly anything changes in this compared to what we saw here. This we were doing. Now we can sleep with peace because this is how it's going to stay. And also it has better visibility due to the platinum content in it. And what is more important is the design, the way it is done. You wanted less tissue to prolapse. If you can see in this, when there are 9 peak prototypes, there is a significant amount of tissue that prolapse between the struts. When they made this 12 peak design, it was reduced by about 30%. So there is so much mind has gone into building a custom design. So the first 3, first, second, and third, these zones have 4 connectors. Beyond that, there are 3 connectors. And when you open these struts, what you will realize is you can side branch, you can go up to 5 millimeter. Even in a dominant circumflex, if you stent the left main, you can put a 5 millimeter stent in the circumflex and a 4 millimeter into the LAD. So that's the great advantage of this custom built stent. So what did we do in this case? Pre-dilated the cipher stent with the 3x12 NC balloon, and then cutting balloon 3.512 was used to open up the the tissue that had grown into the stent, ISR, and then the ostium of the circumflex was again used, slightly calcified, you had seen that. So we just used Wolverine cutting balloon. We passed multiple directions to get multiple cuts, and there's a decent lumen gain that happened. This is the I was demonstrating. And we used a Megatron 4x32 from left main into circumflex, and another stent from circumflex below to cover the whole lesion. And then the thing of interest is the proximal part of the left main was dilated with 6x8 mm NC emerge. We would have never done this in the past. Although if we saw this on an IVUS that it is 6 millimeter, we didn't know what to do. So this is the confidence that this platform has given. And look at this passage of a 2.5 into 12 NC balloon going from left main to LAD without any effort. So that is the access through the cells that you have in this platform subsequent to that second zone. And finally, as usual, you do a double kissing and pot, and this is what you have gained. In LAD is about 8.2 millimeter square, the distal about 10.48, but look at the proximal edge of the left main, 29. The diameter is 6.4 at some place, 5.77 at some place. So just said, I think I congratulate them for bringing this absolute needed custom built design, which makes our procedure, I feel stent failure proof if you really can, without distorting the stent scaffold integrity, giving a large side access, proper stent scaffolding, proper duct delivery, all is guaranteed for such large vessels. So I just wanted to show this, and if there any question, I think we should take it. Thank you.
Thank you, Girish. You can come over. We can have a panel discussion here. And let me start with Dr. Anand. I mean, before the Megatron or similar kind of stents that we have in the market where the overexpansion limits are such great, the scaffold are very good, what stents would have you been using earlier and what was the challenging limitations that you faced?
I think before this stent, if the left main was 6 and the LAD was 3, I would send them for surgery. Because I don't think we had a stent that could open up to 5.5 and 6. Then probably at a later time when the diameters are probably 5, I would use a 3.5 or a 4, go up to 4 atmospheres and pull out the balloon, and then use 3 mm balloon in the LAD and then a 5 mm balloon in the left main. So it has always been a compromise. So I think this specific design, the custom design for left main, I think makes a lot of difference. And the last IVS that you showed, it's amazing, like how much the stent has expanded and opposed clearly well to the left main. So I think more this brings into the portfolio of what we can do with the really large left mains and the smaller distal branches.
What do you think of the side branch access to making this rewiring after implanting this Megatron?
Yeah, it is much better, much better.
I think what you said, I mean, when we were using a 4 millimeter stent or 3.5 millimeter going up to 5 or 5.5, what in images we used to see is the ghosting effect in the stent rendered in the OCT. We never could see those stents struts in the longitudinal view, although in the cross-sectional we could see these silhouettes of the stent. So possibly that could have led to, imperfect drug delivery. That is one, plaque prolapse, tissue prolapse. I think we had so many of challenges on that. I think life has become more easier. Any comments from your side, Devabrata and Dr. Arun?
I think I have a question. So the last 3 connectors, you have more connectors there, and it is 12 cells instead of 9 cells, right?
12.
Okay. So if you have a really large left main, okay, and the whole of it is, the left main, it is not very diseased. There will always be some atheroma there.
Absolutely.
But you need to make the whole of it 6.
Right.
Okay. But you have protection only for the first 3. You do not have for the rest. Now, my question is that if it is a 3.5 stent, okay, however much, whatever design you use, the area of drug delivery per square millimeter cannot be the same as what it is in the LAD. It cannot be the same. Whatever you use, this is partially circumvented by the alteration in design, but it is only the first 3. So, So how do you look into, I mean, what is your
Does
comment on that? Yeah.
absolutely two great observations. If I have to rephrase the question, that these four connectors are there in the only first three zones, and beyond that there are only three connectors. So does that make a great difference? Not really. The purpose of not carrying on those four connectors beyond the first three segment is, within these first three segments, the side hole expansion, the side cell, you can only get up to three. You cannot go beyond that. But you get great radial strength. That is required mostly at the ostial, means where it arises from the aorta, where there is greatest need.
Understand that.
Yeah.
I understand
Next,
that.
can I?
But
I understand.
it
Can I finish?
It doesn't solve your drug delivery
No,
problem.
can I complete that question? The second, it's a great observation. You need to factor in many things when you do this. Second, as you start going beyond, the radial strength does not significantly come down, but definitely it's not as great as the first three segments. Next, when comes to the drug delivery, it is from the point of scaffolding and around which you deliver the drug. The how much of the vessel you scaffold is more important. Since you have 12 connectors, your ability to scaffold the left main is more in this compared to areas where there are stents which have 9 connectors or 8 connectors. Second, they also give you so much more radial strength. The more connectors, if you just go back and look at it, it gives you slightly more radial strength, and also the longitudinal deformity is much lesser if you have more connectors. Thirdly, in a vessel which is 5 millimeter, I don't think you really need a drug-eluting stent. Drug-eluting stent makes a sense when you have probably 3 millimeter or lesser, because the restenosis in a left main, when you have achieved some volume like 20 millimeter square.
That is only if you do not have a lot of plaque burden. If you do not have a lot of plaque burden, it doesn't matter.
I
But
showed
if
you
you
the
have,
tissue prolapse is so
yes,
little.
so no, what I'm saying is, taking up your point that it doesn't matter if it is 5 millimeter. Yeah, it doesn't matter. But in your case, it doesn't matter. Where if there is another case where there is a very tight disease in one segment even, there it matters.
I agree, it may not be
I
perfect,
think
but
on
this is
that
the
note,
best.
let me understand. I mean, what you have said, the four connector system will prevent the longitudinal deformity. Point taken. That point taken. Now, I'll ask just a corollary to it. Since the cell size in this first three segments, because of the four connectors, is less, so does it mean that when you are doing a clot, you need to come more proximal, and so that there is more number of layers? So what happens to those extra number of metal layers that you are putting, because you are having too much of overlap when you're doing a culotte? Does it make sense? Or you have in the culotte, you'll use this stent as one of the, let's say, main branch, and use a stent with a lesser number of connectors for the other part?
Absolutely, maybe you can use the XT. The reason is the first three segments, you want the maximum radial strength, and you don't want to cross through them as the major left main branch, either a lady or a circumflex. Keep it beyond, and in most often, those are in millimeters, will always be beyond those three connectors. So rarely we'll have to, unless left main is 5 millimeter or 6 millimeter, will not be in that situation.
Yeah, what about
Absolutely
your...
right. I mean, it is going in to the side branch that he is saying, that it is much easier. If it is crowded, then it is much more difficult to open it up and go in. So it is best of both worlds. You get radial strength at the ostium, it doesn't collapse, and there is no plaque prolapse there. And then when you are going into the side branch, you have a bigger hole. And that is, I mean, that serves the purpose in a lot of cases, but it doesn't solve the problem of that drug delivery per square millimeter. It doesn't.
What about your views, Dr. Arun? Before I come to Dr. Yoshi.
I mean, having said that, no stent does it. I mean, there is no stent on earth that does it.
So this has made life easier in the sense that earlier we would have to use two stents when we had to do these kind of cases, like have another stent in the proximity and one more stent in the LM and have overlap. So this has reduced that. My concern is when we have this kind of stent being placed, you're actually creating a funnel. You have actually a 29 area in the LMCA and 10 mm. Yeah, you have actually a 29 mm area in the LMCA and a 9 or 10 area in the LED. It takes an abrupt funnel. So what is the chances of in the gutter? There's almost going to be a gutter which is non-physiological. Like in a vessel, it is fine because it's of pulsatile media is there. We have opposed the media there. What is the chance of this creating a flow stasis and the
Change in
thrombogenic of this?
hemodynamics.
Yeah, change in the
change in the
shear
hemodynamics.
forces, you mean,
Yeah,
because
forces, yeah.
see, those forces are there in the vessel itself.
Yeah, but
See, if you look at the natural vessel, those shear forces are there, and all the lateral wall will be having a low shear force, while the carina, the divider, will have a high shear
once we have
forces.
extended this way,
But that is the natural geometry is there.
No. Can no, obviously. You're not going to be God and create his youthful artery back. In the given situation, there couldn't be a more ideal platform to address everything. You are restoring the normal anatomy of the vessel. You're not making left main bigger. Whatever it was, you suited to it. Whatever the LED, we suited to it. Whatever the circumflex, you suited to it. I think it's closest to his
Take
anatomy.
the last comment from Dr. Yoshi before we move on to the next. What about you? I mean, comments on this Megatron stand?
Yes, I think in this, of course, Megatron has and so strong, very good, strong radial force, and of course, and so about in the drug delivery, I think in the amount of the metabolic surface may be same compared with the synergistant. So I think in the drug delivery is no problem.
Compared to the synergistant, it is the same. That is what you're saying. Yeah, it is. Previously, we were having a compression of the proximal part of the synergistant, and this addresses that. And also the fact that it has more radial strength, and you have changed the design, and when you blow it up to 6 millimeters, it doesn't deform it to that extent where the stent, where the plaque prolapses and causes problems.
So on this note, I'll request Dr. Yoshifumi to address on next topic, that is next generation rota for the calcium management, the tips and tricks.
No. No, this is not mine.
This is the third one.
Can you load next generation rota?
Dr. Kashima.
I uploaded from Abaya and Boston Scientific, so you don't have it?
Just a minute. Finish yours, sir? Yeah. Dr. Yoshima, can we request you to do the next one if possible? Oh, sorry. Oh, I'm sorry. So, thank you. We are running about 40 minutes.
Okay, so I'm sorry. So some trouble is happening. So, okay, today I share so my experiments about the so combination of the volume reduction and cracking. So at the first, please show it so case one. So this case is in the so 2070-degree calcified. Of course, this is severe calcified. However, region length is less than 5 millimeter. So IBAS calcium score shows us no need root ablation. However, this fellow used the so cutting button 3.25. After that, huge perforation happened. Please look at case 2. Also, this case is a nodular calcification on the proximal RCA, but region length is less than 5. So my fellow used the cutting button. Also, cutting button, it's good. However, after that, he implanted the ES40, then aortic dissection is happened. So I want to say, calcium volume is of course important. However, even the small calcification, sometimes its hardness is so hard because calcified plaque always different component and so always different density. So even the short calcified region, we have to make a volume reduction. So this is in my friend's case. So acute bending here. So a lot of physicians hesitate in root ablation. So also he used IBL 3.5 and 4.0, 2 IBL. However, IBL cannot work well to this huge calcification. So synergy stent cannot expand it completely. Also, even Megatron stent cannot expand symmetrically. Symmetrical index only 0.5. As you know, 0.7 less, it means so bad result in chronic phase. Sometimes often acute chronic recoil is happened. So this is symmetrically about in the symmetrically index and the radial strength. So if symmetrically index 0.7, 130% stress, much more stress to the metallic stent. If symmetrical index 0.5, 150% stress to implanted stent. So in calcified region, we get large acute gain and also good symmetrically index expansion. So back to the basics. So non-calcified region, balloon and stent have a basic performance like this: plaque compression, plaque redistribution, vessel stretch dissection. However, calcified region, of course, calcification plaque is so much hard. So plaque compression and redistribution cannot work well. So always vessel stretch dissection are mechanisms in calcified region. So often we observe and so huge perforation, huge dissection, hematoma. So those complications occurred. However, cutting balloon angioplasty and IBL is a cracking device. Cracking isn't so good for the calcified region. After cracking, outside of the cracking part, a little bit can be stretched. And compression plaque behind the calcification easily. So cracking isn't so important mechanisms to calcified region. However, this function only improve degraded basic performance. So if we make the cracking, but we cannot get good result as the same as non-calcified region. On the other hand, root ablation, its mechanism is very unique. It's volume reduction. volume reduction is not as same as basic performance of balloon and stent. So this volume reduction can work well every time, everything. So we have to make volume reduction. However, volume reduction cannot affect the plaque behind the calcification. So we have to combine volume reduction and cracking. I call REACT. Of course, and generally, RotaCat and RotaShock is much popular naming. However, I don't like it because RotaCat means to use rota, to use cut, sometimes insufficient result. We have to always make sufficient volume reduction and sufficient cracking. It's an important point. So I share my experience. So this model has a 600 micron calcification and no calcium fracture with 20 atmosphere non-compliant balloon. Vessel diameter 3.5 and lumen diameter 1.5. So of course, no rotablation model. Still severe calcified there. However, if you make 0.5 bar arterial ratio rotablation, much different, and 0.64 rotablation, calcification change mild to moderate. So after rotablation, our enemy is much different, getting weak enemy. So I strongly recommend volume reduction for severe calcified region. So after rotablation, of course, this is a no rotablation on the left side model. 24 atmosphere cutting balloon make cracking. However, please wait a little bit. Bam! Explosion-like expansion. But nobody can observe this phenomenon in our daily practice. So sometimes after cutting a balloon or after non-compliant balloon, we can observe, we observed the coronary perforation and hematoma. This is a reason. However, after rotablation model, very smooth cracking, very gently, so much different. So volume reduction made and easy cracking. So after cracking, of course, I implanted stent for these models. So no rotablation and cracking model is required and 16 atmosphere to expand the DES and overstretch, much overstretch. However, after rotablation with cracking model, gentle expansion, like this, much different. And no rotablation model, just after deformation, acute recoil happened. So already you deeply understand, volume reduction is mandatory to conquer the severe calcified region. So I show you this chart. So European society and so American and Japanese expert recommendation about rotablation. So they recommend 0.4 to 0.6 more bar arterial ratio. I don't like because 0.4 not affect to the calcified, even the good bias. So we have to make more than 0.5 BA ratio rotablation. 0.5 rota can affect like this. 0.6, very great. 0.7, calcified is gone anywhere. So we have to set the 0.5 more. So if you don't make any volume reduction and any cracking, visual calcification goes 50% case, you need 1 millimeter stretch, overstretch, to get in the 5O lumen. So if your fellow use 4 millimeter balloon for the 3O vessel, you said soon, stop your procedure. But in the calcified region, if you don't use the volume blood ablation and the cutting balloon, it's same things. So please make the volume reduction and cracking. So next, my experiment, this case is calcium thickness 500 and calcium fractures occurred with 20 atmosphere non-compliant balloon. This is the result. If you want to get 0.7 more symmetrically index, you need volume reduction cracking, volume reduction cracking, volume reduction cracking, volume reduction cracking. So this case, NC balloon can make the volume cracking. So always we need volume reduction and cracking to get in the large acute gain and good symmetrically index. But only one model get in the more than 0.7 symmetrical index. It's IBL. However, this case, perforation happened in this model. So even IBL, root ablation is mandatory. And one more attention. So Megatron stent is so much great. More than 0.8 symmetrically index shows us rotor cut mega, rotor cracking mega. Megatron is so great. Of course, conventional DES is also good if you make the volume reduction and cracking, but 0.7 something. So I think the best strategy for severe calcified region, sufficient volume reduction, definitely cracking, and using Megatron. So this is my optimal approach for calcified region. So if calcium volume is 40%, well, of course you can use a calcium score. I always make in the rotation. If I set in the BA ratio 0.5 more, and region length in the less than 50 millimeter, IBL high pressure cutting balloon is useful. But then the 15 millimeter more, longer, only the high pressure cutting balloon can be effective. BA ratio 0.6 more, cutting balloon with around rated pressure is enough to make the cracking. So this is my procedure. So finally, I show you my case of following my optimal approach. As you know, this is a very strong calcified region on the proximal RCA. So I make in the 2.25 root ablation. After that, 3.5 IBL, then this is the final result. Good CAZ. So I show you the IBUS result. First IBUS after 1.5 root ablation, like this. Only 1.5 lumen here. So it means about in the 4,000 calcified thickness. So of course you understand, IBL, even high pressure cutting balloon cannot affect. So we need root ablation at the first. 2.25 is my maximum root ablator. However, this region is 4.5 is the reference diameter. So BA ratio 0.5. So I use IBL or I should use an IBL or high pressure cutting balloon. In this case, I use IBL 3.5. So and 8 pulse, all pulse attack to the same position. After that, DES, forward DES is easily expand, and of course I make a post dilatation within the 4.5 balloon. So you can see more than 0.9 symmetrically index good expansion result. So this is a summary slide. There is no history of complete overcoming of severe calcified region with only one of the effects of cracking and volume reduction. Since these different mechanisms react, reduction and cracking technique should always be the basic treatment strategy in the severe calcified regions. And the volume reduction allows for easy cracking and ensures that the stent is easily expandable, gently expandable. Furthermore, volume reduction may reduce the recoil because it greatly suppresses overstretching of the vessels themselves during and so ballooning and so standing. So rotablatation with a BL ratio of 0.6 or greater can be considered a change in lesion condition from severe calcified region to mild to moderate calcification, which allows subsequent device to function efficiency, and it is first to step toward a good chronic result. Since the success or failure of cracking depends on the calcification volume, remaining calcification volume, the cracking method should be selected based on the BL ratio of the final bar size. So, thank you for your attention.
Thank you, Dr. Yoshi. And it's been a real honor to physically listen to you. We have been watching you as a Rota monster in online sessions. I have only one question for you. You play around with the Rota like such a, tool. Is there anything, anytime you fail with the Rota? Any cases?
Yes, of course, and so I make it so rotation for every calcified case.
Yeah, but you play around like a toy. I mean, anything where you miss it out, where you have failed to perform any cases?
No, nothing. I always get the success about the rotabration because
Be it the eccentric, be it concentric, and whatever lesion you are, you always succeed. That's an amazing thing.
One question about eccentric calcium, nodular calcium, non 180-degree calcium. How do you deal versus calcium which is more than 280-degree, and what is the role of orbital?
yes, good question. Thank you for.
I'll just add one more thing. I mean, how you actually bias your rota towards the lesion, if I may. More.
Yes, good question. So of course, and sometimes, and so bad bias generally. So however, I always change the bias, my technique, original technique, max rota. Max rota means the multi-axis rotation within 10 techniques. So sometimes I use it, changing the guide catheter position, changing the wire location, wire position, and sometimes change the speed, rotational speed. Of course, and 10 degree, so 10 techniques. So as I said, always change the wire is easy changing the wire bias. So today I can show that, but if I have an opportunity, of course I show you the maximum max rota technique. So maybe you can easily understand the two changes wire bias.
I have a question. So you are saying that assessing the calcium, this is the REACT is the technique for really severe calcification. But you are using IVUS all the time, okay? So you cannot assess the thickness or the depth of the calcium. So you must be looking at the angiogram as well and the angiographic appearance, and you are making a comparison or an additive view. So IVUS plus angio, then you are coming to a conclusion. So if you could tell us that, that is number one. And number two is, what is your recommendation bar for a 3.5 vessel and for a 3? What burr would you choose? What size burr would you choose? Usually we go for 1.5 for these vessels, but according to your recommendation, it should be a little more. So 3.5, would you use a 1.75 burr?
Yes, so question one, so I always check, and of course IVUS, because I only IVUS can be used a lot of times. OCT required contrast media. So we can use only before the stand and after the stand. So IVUS is much more useful to make an operation. But IVUS cannot see or cannot look at your thickness. But always we can check proximal and distal reference. So it's, yes, it means that so if you can see the calcified surface, so and we can so expecting the so vessel wall. So it means so calcified thickness. Of course, sometimes including and so mixed plaque and
Yes.
fibrous plaque. However, from my few thousand root ablation experience, surface is and so very hard calcium. Of course, another part plaque is also hard. If and it is not calcium.
Last question.
The bird size is,
Second
sorry,
question.
I have
Yes.
another question.
Yes, question two. Yes, if and so target is 3.5, I choose and so if possible 2.0. Because the 1.75 means 0.5 BA ratio. So 2.0 is much better. However, sometimes and so region has an acute burning and some risky part. Of course, I choose the 1.75. However, at that time, 0.5 BA ratio, so I need an IBL or high pressure cutting balloon to make any cracking.
The last question, orbital atherectomy, when do you use?
Sorry?
Orbital atherectomy.
Yes, of course, I used and so used an orbital atherectomy in the so just available in Japan. However, I stopped in the procedure using an orbital atherectomy only 1 month. Because and so orbital atherectomy is under so good idea, so mechanism is good idea. However, orbital makes like this. So efficient, so volume reduction efficiency is much lower. Much lower. So because and so like this motion, sometimes bumping happen. So always so orbital atherectomy can give us and the result is as same as 1.75 root ablation maximum. So I always use and so more than 1.75 root bar. So OAS is not so weak to make and so volume reduction. However, if you are aberration the bar size in the less than 1.5, of course OAS is one option. Almost the same result.
Thank you. Thank you, sir.
Thank you so much.
Can I have my slides, please? Yoshi, your drive. Yoshi, your drive. Can I have my slides, please?
No, I already. No, it is not mine.
Bye.
Safe trip.
So good evening, and I'm going to discuss about the cutting balloon as a tool for the calcium management. Now, we already have listened to Yoshi. I mean, what does calcified lesion need? Why does calcified need a special attention? Because it increases the risk of complications by managing the conventional way, be it perforation or dissections. It impedes the delivery of the stent. And finally, it prevents the stent expansion, which is most crucial. And what we find is calcified lesion is nearly about 34% of the cases. And what we find is there is nearly about 64% increase in the target vesicle failure. So most important thing, predictor of the thing is the minimum stent area, which is a predictor of stent thrombosis and stent restenosis. What does conventional balloon do? It is unable to modify the deep or very thick calcium. It predisposes to dissections and perforations, causes more injury, which causes inflammation, and preferentially expands away from the calcium with limited access, particularly when it comes to the eccentric calcium. So what we need is a tool which can actually restore the vascular compliance by removing the calcium and to minimize the procedural complications. And these tools, we actually, there are two types as you can see here. The one which increases the compliance, increases the drug delivery, those are mostly balloon-based therapy. And the one which reduces the volume of the calcium, it widens the lumen, increases the flow, and these are the atherectomy devices. Which one to choose will depend on the results of the imaging, the lesion severity, the distribution of the calcium, and the tortuosity of the vessel. So this can be very well imaged and seen. And what we look for the imaging is whether the calcium is intimal or superficial, what is the arc of the calcium, is it concentric, eccentric, or nodular, and the thickness of the calcium, is it thick or the thin. And accordingly, we can choose each of these tools, and these tools are complementary to each other, not I mean, conflicting ones. And what I'm going to discuss is about the cutting balloon, which actually causes a blade indentation. It cracks the calcium, but is not effective in very thick calcium, but good enough when we have a thin calcium, eccentric calcium, and it has often been successful, very easy to pass the calcium. So let me take you to one of the cases here. This is a patient who had a calcified lesion in the LAD. You can see here, quite significant. And here, when you image, you can find some nodular non-eruptive calcium. There are calcium which the arc overall is less than 180 degree at most places, and it's if you look at the last curve, it is almost like nearly close to 200 degree. So here I thought I'll use a cutting balloon, and this is 3x15 cutting balloon, and then I again image it, and you can see here it has, as you can see here, it has caused cracks in this calcium, and other places it has caused dissections. So again, some cracks in the calcium. So this cutting balloon can actually put cracks in the calcium which are not thick. So here, because of the lot of discrepancy in the vessel size in the proximal and the distal, I use a 3 millimeter stent distally, and then proximally a short stent across the diagonal, 3.5, and then recross the vessel. You can see here, recrossing to the distal struts, do a dilate the side branch, do a pot and a repot. This was pot, side branch pot, and you can see here in the good silhouette that we have in the stent burst, and these are the final results that we get. And again, if you look at the stent expansion, I have achieved a good stent expansion here. So what does the cutting balloon does? I mean, this as a tool, if you look at, it's based out of an NC Emerge platform, but the balloon material is slightly different because, and that is why if you see here, the inflation profile is different. We have a nominal pressure of 6 atmosphere and a rate blood pressure of 12 atmosphere. So this has reduced the entry profile. There is improved tip flexibility and visibility. We have improved balloon flexibility and durability. The crossing flow profile is low. The tip entry profile is 0.020. There is improved inner and outer flexibility of the staff. And they have changes compared to the flextome in the arthrotome. The arthrotome remains the same height, but this is the base plate which changes. The arthrotome is conical. It's 127 micron in height, is less than the cipher stent that we used to have. There are 3 to 4 evenly spaced, and there are flex points depending on the length of the stent. It is every 5 millimeter. So you don't have any flex points in the 6 millimeter, but if you have a 10 millimeter and 15 millimeter, there are 1 or 2 the flex points. So what is the mechanism that it acts? It's caused micro incisions, and it actually anchors the balloon. It causes less plaque shift, and there is a forced amplification which actually fractures the calcium. So where it can be used, the small vessel lesions, the ostial and bifurcations, which have a lot of tendency to recoil, the fibrotic lesion, and my focus today is the calcified lesion, where actually it cracks calcium depending on its distribution and the thickness. And as a standalone, it can be used in eccentric or thin concentric calcium, and more often it is used in addition to the rotational or other plaque modification devices. So how is it different from the plain balloon angioplasty? If you look at here, there is focused stress points. So there is a controlled fracturing, and there is enhanced states as demonstrated here. And compared to NC balloon, it works, basically this arthrotomes amplifies the stress, and it's, if you look at compared to shock waves, there's a bidirectional, here it is on the 3-directional, and rota actually is, it debulks the calcium and makes it more thin, and therefore it is more effective in thick calcium, while Wolverine is more effective in the thin calcium. It acts on the eccentric calcium as well. Here again, it's not only on the contralateral side, but it has a very forced focal, cracks which develop in the eccentric calcium as well. It acts as a nodular calcium again, but we have to be very cautious because there is a tendency to cause dissection on the contralateral wall and perforation. So but if there is any of the arthrotome gets anchored on the nodule, it will increase the probability of the fracture. It's somehow different from the other devices which can be of similar types, like for example in angiosculp. Angiosculp, you have the blunt edges. These are nitinol wires, 133 micron, while Scoreflex has a single wire, it's a nitinol wire which is part, so this again, the wire acts as a forced focal, but here the three are very well distributed. It's a pointed, sharp edge of stainless steel atherotroms, and therefore it works much, much better way than the other similar kind of devices. So what it results is that almost about 30% gain, acute gain. It's a better lumen symmetry, and it modifies at very lower pressure. As you said, rate blood pressure is only 12, and so we have to be very cautious. So as you see here in the animations here, the atherotroms create controlled fracture compared to the plain and balloon angioplasty. So let me take you to another case here. This is a patient who had a bypass nearly about 18 years back, and this patient had symptomatic, had come. So here again, if you see, this is a native 3-vessel disease, and all the grafts, that is 4 grafts, were working. So what was, graft to the PDA, to diagonal, to the lima, to LAD, and they were all working. But what you could notice here, the graft to the SVG graft to the PDA was only filling the PDA, and we had, as I showed you in the earlier slide, we had a huge RCA vessel, which was actually, is a huge RCA vessel, which was not getting enough this thing, and this patient was quite symptomatic. So here again, I actually imaged the RCA here. So RCA had a huge amount of calcium here. You can see the calcium distribution. It was concentric at most places. So in this case, I used a rotablation here, and this was 1.5 Burr. And what you can see after rota, you can see reverberations in the concentric, so it has actually thinned out the calcium out here. It has caused some cracking of the calcium at other places, shaved off some of the nodules here. So with this, I think the next tool that I could choose here to have more expansion is a cutting balloon, and here it was 3.5 into 15. I do the cutting balloon to the entire extent, and following cutting balloon, I deployed the 2 stents here. And with this, the stent, as you can see here, even despite such a heavy calcium, concentric calcium, nodular calcium, all kinds of variety, we have achieved a good lumen size here. And those are the cross-sectional area where you can find I have got almost 10 millimeter area. So we have found that cutting balloon is effective both in concentric and eccentric calcium, but depending on the thickness, if you have a thick calcium in concentric, there needs to be other plaque modification tool, and this can actually supplement more of this. So we have a COPS trial here. Again, the COPS trial showed that the stent area with use of cutting balloon is much higher achieved. Similarly, we have the PREP calc and rotacut, where again, if you see when cutting balloon has been used in addition to rota, we have had better stent areas. Thank you.
Dr. Roy, thank you. Excellent. I think truly how this Wolverine cutting balloon is distinct with its sharp cuts, with a controlled depth of breaking the integrity of constricting plaque, and by causing multiple cuts, you increase the compliance of the vessel. So that's a great perspective. Anything else you'd like to ask?
So you have this RCA is a 3.5 vessel, and you have used a
3.5 distally, and proximally it was
4.2.
4.2.
Okay. So how do you choose? You took a 1.5 bar, and then you took a 3.5 cutting balloon.
Yeah.
Is that right? And what atmosphere do you go up to? 12 or less than that?
Distally, I went up to 12, and proximally, I went up to 20.
20.
Because the vessel size
Yes,
was large.
yes. And then when after you deploy the stent, you go up to 4 in the proximal, or you stay at 3.5?
No, after deployment stent, I use the NC.
NC, yes. So I'm saying that
proximally it was 4, which I went up to nearly about 24, and distally it was 3.5. So it matched according to the expected vessel size.
Okay, and one concern regarding the cutting balloon that I have had is sometimes I have seen people try to push the cutting balloon across a very calcified lesion without actually first modifying it. And the cutting balloon opening up like not very well, and then when the balloon is deflated, the blades are actually caught in it.
Yeah,
And
in severe calcium, it is contraindicated. Actually, you should not do it unless, as you said,
Exactly.
before modifying the plaque. So you are exactly right. And sometimes these blades can get caught up in the calcium. And when you take out, retrieve the balloon, you find those blades missing. So I think it's point well taken that whenever you have a thick calcium, you need to modify the calcium thickness before you use this. Because see, after all, you understand, I mean, a thickness of 500 to 600 microns is amenable to balloon dilatation and cracking. So you have to reduce your plaque, the calcium volume and the thickness before you use any balloon-based therapy in very thick calcium. But if it is an eccentric calcium, it is a thin calcium, you can see some reverberation else, and the vessels is where you can actually bring down a cutting balloon. You can always go for that. Yeah. Any
Thank you.
comments for you on?
Thank you. I think we'll conclude. It's been fantastic learning for all of us. Thank you, Dr. Bhattacharya, and Dr. Tyagi has not been here. And it was wonderful to hear from Dr. Kashima. And as usual, we all, Dr. Sanjeev Roy is such vivid pictures and great understanding of the cutting nature of the stents, and my two dear co-moderators, and we had a great day, great evening. I think we'll conclude here. Thank you, Boston.